We are from Andreas Gruentzig Hall, and our first session is for 1 hour duration. It's titled Intervention in STEMI. How do I do what I do? We have our expert chairpersons, Dr. Anjan Lal Datta, Dr. Bapaditya Kumar, Dr. P.C. Rath, Dr. Rupali Khanna, Dr. Sudhir S. Shetkar, Dr. V.K. Katyal, and Dr. Vinayak Agarwal. Now, may I request Professor Anjan Lal Datta to start the session? Thank you.
Good afternoon, everybody. We are going to start our session with the speakers, particularly about STEMI program. And our first speaker is may I have the program with me?
So Dr. Tejas Patel, sir.
Yeah. So Dr. Patel does not require any introduction on any part of the art. Is expert, innovative, competent, and highly experienced interventionist of the country globally. So without wasting further time, I would invite Dr. Patel to start his deliberation, please.
Recording in progress.
Can you allow?
Dr. Patel, you are muted.
Okay, now I think it's okay, right?
It's okay.
Acha, can you guys hear me properly?
Yeah.
So yeah. All right. I go from here. Okay. So I was given the task of speaking on recognizing and resolving the unforeseen challenges in
Sorry to interrupt you, sir, but your presentation is not visible.
Not visible?
Yes,
Yeah,
sir.
there are no slides.
There are no slides, sir.
So then let me see. Yeah. Screen sharing. Here it is mentioned that you are screen sharing.
Sir, can you please stop share and again reshare the
Okay, we'll do that. Can you see now?
Yes, it is okay.
It is okay.
Yeah.
Very nice.
You go to the main screen.
So please put it in presentation mode, then it will be okay.
Okay, now you are able to visualize.
Yes, sir. It is okay.
Okay,
Now
yeah, sorry for the interruption. So, I'm supposed to speak on recognizing and resolving unforeseen challenges while doing primary PCI through radial route. I have no disclosure, any relevant financial interest. I think we know the rationale of transradial PCI in STEMI, and we have enough evidence base now, which has proven that STEMI bleeding predicts the worst prognosis, high short as well as long-term mortality. There is some evidence which also shows that the modest reduction with new pharmacological agents and approaches like bivalirudin. And we all know now, with all this evidence, that excess site bleeding is a significant source and transradial PCI decreases the bleeding. Very quickly surfing through the literature in a couple of minutes, the first buzz was, there where mortal study was published in Heart, 32,000 patients in British Columbia, Canada, and 38,000 procedures, and 30 days and 1 year mortality. The association between excess site transfusion and outcomes were assessed. It clearly mentioned 50% reduction, 50% less blood transfusion and accompanying reduction in mortality for the patients done radially. And by probit regression, the absolute increase in the risk of death at 1 year associated with receiving a transfusion was 6.78%. In the same time, a seminal paper from Sunil Rao, NCDR data, mentioned around 600,000 US patients, and they found, it was a retrospective analysis, they found that radial patient experienced about 58% less bleeding complication. And Hammond also published this data, this analysis, and which mentioned very clearly that you have to do 9 major bleeding to lose 1 patient. So bleeding and blood transfusion are so vital as far as, preventing bleeding and blood transfusion are so vital as far as reducing the mortality is concerned. Rival, had 2,000 STEMI patients. And again, the primary outcome, the composite of death, MI, cerebrovascular accident, death, as well as major vascular complications were significantly reduced. Back to back, there was rifle stick study by the Italian group, and they also endorsed the same finding. Following that, a very nicely designed, although a study with a small population, that is STEMI radial, 350 patients in each arm, properly randomized. It also mentioned the same, no difference in mortality, but length of the stay reduced, door to balloon time remained the same, and major bleeding was significantly low as compared to femoral. And metrics also confirmed, the same finding. Following that, there was a big meta-analysis which was published in JACC Intervention, which also showed all significant reduction in all-cause mortality, mass, as well as major bleeding. The last of the list was a Safari STEMI study, which was published in JAMA Cardiology, which was a negative trial. But you can see the main exclusion criteria, the fibrinolytic therapy patient who received fibrinolytic therapy, those who received oral anticoagulation, or those who had undergone prior CABG presenting with STEMI were excluded. These were the patients who were the highest risk patient, and radial actually offers the highest benefit in the highest risk patient. They were eliminated from the trial, they were excluded, and probably that was a major criticism for this study. And this was the last meta-analysis, and which very clearly mentioned that the mortality in STEMI patient, favors radial approach for the reduction in mortality. However, there is there is a sort of confusion in some of the interventionalists nowadays, not many, but some, that it is very difficult to perform complex STEMI cases through radial. And the ostensible reasons given by them at some or other time are the radial artery is a small artery, it is spasm prone, more so during high catecholaminergic situation. It is difficult to use bulky devices. There may be inadequate guide catheter backup, not so good for difficult coronary anatomy, or not so safe in emergency situation. So let me just give some idea. You can get this type of diffuse spasm, but you can still work by giving a good amount of cocktail nitroglycerin plus minus diltiazem depending on the pressure, coronary wire, and slowly under fluoroscopy you can work. If you may come, you may come across this type of bad loop, but again you can work through it by using a baby J. It's a small tiny tool from Terumo, and you can see how it unfolds the loop, and you can by and large work through the loop. There are 2 important techniques. One is combo technique, where you can use 7 French guide through the regular anatomy, even 6 French also nowadays we are using combo, and balloon assisted trapping, both techniques described by us, published, and very extensively used across the globe. Here it is a 7 French and 5 French 125 centimeter long catheter, but even with 6 French and 5 French 125 centimeter long catheter you can use. In previous days, we were doing this, after introducing the guide catheter, we used to, sleeve the sheath outside. But nowadays, we have slender sheets available, 5'6" and 6'7". So there is no need even for that. And this is how it works. This is a relatively small radial artery. And you can see this is a 5 French guide. And 5 French guide is guiding the 7 French guiding catheter, and it traverses so smoothly without any, issues. And this is a balloon assisted tracking, extremely well publicized and widely used. And here we thought of, eliminating razor effect of the guide catheter, because the radial artery is many times very tortuous and has different anatomies many times. So putting a balloon which is inflated at 4, 5 or 6 atmosphere and creating a nozzle with the balloon and just tracking, the catheter using the balloon. This is how it looks in vitro. And this is a case like where a small radial which is arising from axillary, and there are some spots of spasm, particularly at very acute angles, bands. And you can see how smoothly the balloon, coronary wire, balloon, 4 or 5 atmosphere, and how smoothly, balloon tracks the guide in this complex anatomy. And after finishing the procedure, we have always a tendency to take an injection and to see whether we have done any damage. This is how the spasm is gone, the tortuosity is still there. This is one of the extremely complex situation where arterial lusoria, where the right subclavian is arising from the left of left subclavian. We have done good amount of work. We must identify, even we are doing acute MI, if your wire and or catheter has a tendency to dive only in descending aorta, just a small injection to see, and you identify arterial lusoria very slowly, either with the Tiger catheter or maybe in a complex situation, internal memory diagnostic or Suman catheter. You enter ascending aorta and slowly, try to push, advance your catheter inside the ascending aorta. Then you can exchange it with the guide catheter and you can cannulate the coronaries and work. In short, once you cannulate the coronary ostium, radial and femoral are the same. So a few examples: 64-year-old female, old anterior wall MI, LAD total, presented with us acute inferior, severe LV dysfunction, EF 50%, an organized LV apical clot, very, very bad situation, and plan was to do primary PCI of right. You can see organized clot when severe LV dysfunction, and this was the right. It was complicated after balloon dilatation. When we injected, a good amount of air was injected. Patient became even more unstable. Here, we modified balloon-assisted tracking and balloon-assisted deep intubation was done. And with the 6 French guide, we entered 50 cc syringe, removed everything, and slow, gentle counterclock rotation, removed the thrombus. A good amount of thrombus came out, and you can see TIMI grade 3 flow and beautiful blush distally, stented, and patient did well. Buddy technique was also published in the International Journal of Cardiology. Another case, extensive anterior wall MI, 1 hour cardiogenic shock, unprotected left main like this. Intra-aortic balloon pump through the groin, and then the radial. We didn't puncture 2 groins, 2 wires dilated, thrombus removed, stented. And with a good result, patient did well. Another example, again, severe LV dysfunction, anterior wall MI, a good supportive right, and you can see total left main. And without wasting time, even we didn't waste time to put 2 wires, we simply went in and stented, and patient became hemodynamically stable. Arterial lusoria with a subclavian tortuosity, acute anterior wall MI in an 81-year-old woman, extremely complex situation, but we know how to deal with this, and you just go on doing it and you become very comfortable doing it. You can see it was anterior wall MI, dilated and stented in arterial lusoria with extreme subclavian tortuosity. It looks very scary, but once you cannulate, the coronary ostium in arterial lusoria situation, the guide catheter gives super extra backup support, and you just simply without worrying you can do. Another example of arterial lusoria with a normal right, patient presented with a lateral wall MI, and you can see the ramus total, and it, very, very complex arterial lusoria. But once it is cannulated, the IBU was cannulated. It didn't take more than 2 minutes to do that. We dilated and stented, flow started, and MI was reverted. And these were the final injection. This is another documentation of arterial lusoria. Cannulating Lima graft using right radial. We had come across this technique, also was described by us, published in CCI. This was a case, a very, very particular case where left radial was already taken up and the patient had a severe peripheral vascular disease and patient presented with anterior wall MI with difficulty. We had deployed balloon pump and we wanted to do it from right radial. This, I wanted to show this technique. We entered the left subclavian, push the wire all the way in the ulnar or radial, wherever it goes. Radial was not there, it entered the ulnar. And then we asked our attendant in the cath lab to flex the left elbow just to trap that wire. Once it was trapped, you can see how smoothly the right Judkins guide went in, and we were able to cannulate the internal mammary artery, and this was instrumental for anterior wall MI. Very rarely, I think I have seen the only case in my career like this. One by one, 2 stents were deployed, and it went, the TIMI grade 3 flow was established, and we were able to salvage the patient. So there are many challenges through radial. Until when you have adequate experience, you may get frustrated, but every single challenge has a solution. And I'm sure all of you are convinced now. Thank you.
Thank you, Dr. Patel, for a fantastic display of some of the very difficult, exciting cases where approach through radial artery finally resulted in excellent result. It's very fantastic idea. Except for the present, the latest STEMI, Safari STEMI trial, all the earlier trials and reports of radial approach had shown benefit, both survival benefit as well as reduction of MACE.
Yeah, thank you.
I have a question, Dr. Patel.
Yeah.
Except for the technical difficulties overcoming, is simple increased bleeding, say 50 cc or extra 60 cc bleed from femoral artery, hematoma, or whatever bleed, does that bleed, just small increase in the bleed, result in mortality reduction or increment?
See, the problem is the basic fundamental difference between femoral and radial route is femoral, the hematoma, the source is the puncture site. And radial hematoma, by and large, source is not the puncture site. It may be a small side branch perforation or something. And femoral, has a big space to gather 1, 2, or 3 liters of blood in that compartment. And even it has a retroperitoneal space, while radial does not have a big space for any, blood to get accumulated. And that is why even if hematoma develops, they are identified very fast. And they are very easy to deal with using blood pressure cuff, which I have several times shown in my previous radial talks.
I came across a very interesting article saying that when you have blood loss during invasive procedure, the blood loss amount, even though it is not good enough to disturb you hemodynamically, but a compensate whenever there is a bleeding, active bleeding, there is a compensatory mechanism of more procoagulation. So the bleeding results in 2 important phenomena. One is the hemodynamic changes or hematoma, whatever be. The second is very interesting changes. The bleeding stimulates procoagulation as a reflex defense mechanism. And the patient become more procoagulant at this stage. And that is also contributing to the increased MACE or mortality, whatever be.
Yeah, thank you.
Any comment from our co-chair? Or any question?
Thank you, sir. Very nice presentation.
Thank you.
And my only question is, it is the time taken in radial route is slightly higher than the femoral route. And the right radial is usually you like to preserve for bypass grafting. So what is your comment about that?
Still you preserve the radial for bypass grafting. I think, time and again it has been proven that, radial graft and, saphenous vein graft, I don't think there is much of the difference, whereas both are denervated grafts and only the internal memory is a long-lasting graft. So I personally feel like in our setup, 90% of the bypass surgeries are done lima rima Y, and rarely they are using even the vein grafts. So radial is such an important route to me. And secondly, Like time taken is only when you are through that initial process of learning curve. There is a new learning curve even for an experienced operator who wants to start radial, and time is little longer time when an operator is a fence sitter. Like I will like to do 20% of the cases with radial or 30. Like in our lab, when default procedure is radial, I don't think we have any issues anytime about time or nothing. If it is palpable, it is punctured, and if it is punctured, the coronaries are cannulated and the job is done. It may be left main bifurcation, it may be how CTO, how complex it may be, everything. So it's simply go on a question of going on doing it.
On how many occasions did you choose the radial failure through ulnar approach?
Ulnar never. I mean, we did several hundred ulnars initial stage. In initial stage, when I finished initial 10, 15, 20,000 procedures, but we didn't, we didn't find it so comfortable. And secondly, I went through the literature and embryology of this particular vasculature, and I found out that ulnar is actually the continuation of brachial and radial is an offshoot of brachial. So, and ulnar, of course, is, accompanied by an ulnar nerve, and that area many times is not very good for compression and hemostasis. So that is the reason why we usually don't prefer ulnar.
Okay, thank you very much. If there is no other questions, let us.
So I have one question, sir.
Oh, sure.
Sir, regarding the radial approach, do you have any concerns about radiation exposure when there are complex procedures requiring long time?
Yeah, I tell you, 12 years ago, I think 10 years ago, we published a randomized study, beautifully done, right radial, left radial, and femoral Revere study, which has been published in JACC Intervention, and we were able to find no difference in radiation in between femoral and radial. And I tell you, the things what I personally feel is, you are keeping your hand like this and remaining away. And nowadays, I ask all my juniors also that don't use too much of cine runs, only pre and post, or maybe very, very critical evaluation. Everything else is fluorosave. So that is never a problem, at least in our lab, never.
Thank you.
Yeah, thank you, Dr. Patel, for its very interesting and exciting deliberation and session. Now we invite our next speaker, Dr. Ajay Mahajan.
Good afternoon, sir.
Good afternoon.
Hello.
My sincere thanks to Dr. Nitish Naik and Dr. Rakesh Yadav for giving me this opportunity. And it's very difficult to talk after Professor Dr. Tejas Patel, sir, who is a pioneer in radial intervention. So I'm just doing some of my job. So here, what is the difference between STEMI PCI and elective PCI? So STEMI PCI, following things are not known. One most important thing is the anatomy, any anatomy of upper limb, vessels like a radial anatomy, brachial anatomy, subclavian anatomy, and the most important is coronary anatomy is blind. The lesion morphology is not known, extent of disease is not known. Most of the time, the status of non-infarct related artery, we cannot predict on the presentation ECG. There are certain patient characteristics like hemodynamic instability, electrical instability. Then another thing is that most of the patients who are sometimes they get thrombolysis, thrombolytic therapy, and then they are shifted, and all these things lead to slight increase in the complications. And one of the most important complications is excess site bleeding and strokes and more complications. So PCI in STEMI, the access priority based on operator experience and center credentials, but as Professor Dr. Tejas Patel had told, the radial is the best. Hemodynamics, most of the time patient is unstable, he is waiting to become unstable. Rhythm is most of the time they are having arrhythmias, and so all these conditions we need anesthetic support, and we have to act very fast, and the time is muscle in this situation. So it is much more anxiety for the patients and relatives. There is unpreparedness of the patient and relatives, hence require proper and specific counseling and risk explanation, and time is limitation. So unlike elective PCI, in STEMI PCI, everything is anticipated, operator is blind, yet prepared for all possible difficulties and bailout situations. So So in STEMI PCI, we have to go with a diagnostic or any angiogram. We have to find out what is the origin of the coronaries, tortuosity, calcification, and bifurcation, and everything is hidden with compounded with the thrombus. So we have to take history, cardiac function, comorbidities. We have to find out medications which patient had already taken, and hemodynamic compromise and rhythm abnormalities. Then we have to monitor the patient, and we have to take the patient for the procedure. The strategies in primary PCI is the best strategy, but if the primary PCI facility is not available, then one can go with the pharmaco-invasive strategy. And all these things, we have to go with the radial access. It is shown to be better than femoral access, but however, in my humble opinion, the access should be determined by the patient characteristics and operator's comfort. Elderly females with extremely thin build, fragile patients with arterial dysuria or prior CABG, one can think about a femoral route. But in obese patient with the prior thrombolysis or in any young patient, one can go with the radial route, and that is the safest. The features which determining the access is weight, obesity, wrist diameter, any known arterial abnormalities, and any superior limb abnormalities, and negative Allen test. The benefits are always there with the radial access. The site selection should be there. So in all literature shows that around 5% patient there is failure of radial access, and we have to shift from radial to the femoral. The most common causes are inadequate arterial puncture, radial spasm, dissection, and tortuosity. And then we have to take the help of the ideal guide. The guide should be safe, short tip, easy to engage and manipulate, coaxial engagement, and we have to always use a guide catheter which is the operator is most comfortable to use. So left or right radial approach, guide catheter should be choice. Pick up the right guide catheter approach which is comfortable with the operator. And the most important thing is, if there is a complex procedure, we have to think about internal diameter, and there one can use in radial, one can use the sheathless guides. Sheathless guides are dedicated, sheathless guides are also available, and one can use a sheathless guide with Dr. Patel's technique. We can do with a mother and child with a 7 French guide with a 5 French multi-purpose catheter, and or we can go with the balloon tracking. So smaller guides, if there is a spasm of the radial, one can go with the smaller guides, but there are specific difficulties with the smaller guides, with the 5 French guides, that one cannot use bigger devices, one cannot use IVUS, rotablator, one cannot use bifurcation stenting with the smaller guide. And another important thing is that there are chances of guide thrombosis, and air trapping and air suction is slightly more with the 5 French guide. So choosing right guide, the common workhorse guide is EBU3 or XB3 left for radial, and intermediate guides are 3.5 and 4. They are giving extra backup, but we always prefer smaller curves because we don't want to deep throat the left coronary ostia with a 3.5 or 4 guides. So passive support with a stiffer or larger guide should be preferably avoided. Active support with the deep intubation should be additionally done with the mother and child catheter like guide liners and guidezilla. And these are the femoral versus radial, how it is different, alpha angle is different, and because of that we have to use different sizes. The commonly used guides for left are the EBU workhorse catheter, and for left it is for right it is JR Jurkin's right curve. So if you take a EBU, around 60% patients are done with the EBU, and around 40% patient might require a special guide, but for right, around 70% patients are done with the right catheter. So as far as the coronary primary interventions with the post CABG, we have to find out the graft site, if the anatomy prior to CABG, if it is known, then one can plan the thing, and one can plan it with either left radial or with a right radial also. And most of the time, Ampla's left or Jurkin right, they are the catheters which are used for the graft cannulation, and one can do the things. So what are the important things to do during primary PCI? The important thing is that you have to find out the origin and course of the coronaries, tortuosity of lesion, grade of thrombus if it is present, calcification is present, and then you have to find out the strategies. And if there is any anomalous origin of the coronaries, then we have to use the special guides. Like if the RCA is arising from the left, then one can use a JL3 or AR1. If the left circumflex is arising from the right, then one can use the JR guides. And if the Shepherd's screw deformity, then one can use the EMA catheters for doing interventions. Then guide catheter size. So workhorse guide is 6 French. Sometimes we have to use 7 French. The common workhorse guide is EBU for left and right, and Jurkin right for right. Then there is a new concept which is coming as a single guiding catheter for STEMI. So it reduces the exchange of catheter, it reduces the radial spasm. So one can use a single guiding catheter, and one can decide on ECG, we can decide the culprit artery, and directly we can go and engage with the guiding. We can do the culprit artery angioplasty. After finishing culprit artery angioplasty, one can use the same guiding for taking a diagnostic shoot on the opposite side. The most commonly used single guide is Ikari left, and sometimes one can use a Kimney curves. Then primary PCI procedure, these are the ways. One can go ipsilateral approach, one can go contralateral, or one can go to full diagnostic followed by primary PCI. So the most important thing is you have to find out the anatomy after first shoot. If patient is hemodynamically stable, then there is a time to think. But if the patient is hemodynamically unstable, then we have to go very aggressively and urgently. So coming to the guide wires, the standard guide wires and flexible guide wires are the commonly used guide wires in the primary PCI situation. They are Sion, Reader, Champion, Crucier, Galileo, BMW, or Whisper, or Asai, Fielder, or we can use a run-through wire. So these are common wires. High support and chronic total, the wires which are used for chronic total occlusion should be avoided in primary PCI. So the standard wires and flexible wires are having less tip load, and that can be very well done. Everything will be decided by the operator's comfort, and if there is a tortuosity, one can always use a very soft wires, very floppy wires. And the most important thing in the tortuosity is that after putting wire, we get a concertina effect, and that concertina effect should be always anticipated. And if there is significant concertina, then we can take a floppy portion inside the tortuous portion, and then we can take a shoot, and then we can decide the stent sizing. So coronary wires in STEMI is selection of guide wires essentially influenced by the vessel anatomy, lesion morphology, devices to be used, and operator's experience. So the workhorse wire, we have to always use a workhorse wire specifically in one operator should use a specific workhorse wire, and you should be very comfortable with that, and that particular wire you should use. And if there is some special wires are required, then one can use during that particular situation. So coming to the balloons which are used for the primary PCI. So after taking the guiding shoot, one can find out is there is need for doing thrombosection, or need for pre-dilatation, or need for direct stenting and followed by post-dilatation. So anything related to the pre-dilatation and post-dilatation depend upon the non-compliant and compliant balloon, and that should be decided by the vessel size 1:1 ratio. But the new concept which is coming is the drug-eluting balloon for primary PCI. So one trial was published in JAC in 2019, that is a Revolution trial. And in this particular trial, it is prospective randomized single center trial. They compared a drug-coated balloon with a drug-eluting stent, and all these patients were subsequently followed up at the end of 9 months with the FFR. So only 120 patients were enrolled in this particular trial, and the loading dose of DAPT was there. All patients were treated with a drug-coated balloon. They are pre-dilated, pre-dilatation performed, and if after pre-dilatation, if there is a more than 50% residual stenosis, or if there is a flow limiting dissection, then they go for elective stenting in that situation. So around 18% patients of DCB are gone for stenting. So all these patients were followed up very aggressively, and at the end of 9 months, they found that FFR related follow-up, the drug coated balloon and drug eluting stents, both are same, the results are same. So with this new debate is there. So if in young patients during primary PCI, after opening the artery, if the no flow limiting dissection or residual stenosis less than 30% and FFR more than 0.8, then one can go with the drug coated balloon rather than giving a stent, and that is a new concept which is coming. But if there is any suboptimal angiographic result, then one can go with always go with a drug eluting stent. So with this, I am coming to my take home message. As far as the access, radial should be preferred approach. The choice depends upon the operator's comfort, expertise, and patient-related factor. Addressing the infarct-related artery and non-infarct-related artery depends upon the various factors. The choosing of the guiding catheter, the right guiding catheter is the right one, which is the operator is most comfortable. To decrease the time of the procedure, we should preferably switch to the single guiding catheter approach in transradial route. For choosing guide wire, the right coronary guide wire choice depends upon the coronary anatomy, morphology, and devices to be used at the time of primary PCI, depending upon the pre-PCI guiding shoot. and the proper planning and developing the hospital protocol and proper training of the healthcare and cath lab staff will lead to the decrease in door to balloon and cath lab to balloon time, and the more the better. With this, I am stopping here, and thanks.
Thank you, Dr. Mahajan, for your very interesting and valuable inputs in the approach and management of STEMI PCI. So if there is any comment or any question from the audience, please.
I just want to ask one question to Professor Dr. Tejas Patel, sir.
Sure. You can carry on.
Single guiding catheter for primary PCI. So, sir, what is your experience with this technique?
Normally, I mean, you know what? If it is like inferior wall MI and I feel that patient is in cardiogenic shock, RVMI, by hooking the right coronary guide, if we find that the things are bad, we fix the things, and we can cannulate the left just to see the basic idea. But normally, Ajay, I will like to exchange the guide rather than use the single guide. Ikari as well as Kimni guide, both can be used for left as well as right, but they have a tendency for aggressive deep diving in the right. So it can sometimes create a problem. So it doesn't take a long time. Left Judkins, if I am using, because like if I find that the left main is hardly there is any left main and I have to work in the left system for acute MI. After finishing my left, left Judkins can easily be cannulated in the right without any problem, just to see the right. But like Ibu also, I will not like to prefer for left and right, and others also. So by and large, for 99.9% of the procedures, I will use two catheters.
Sir, another thing, so you directly go with the culprit artery analysis on ECG, directly go with the primary PCI, or you do always a diagnostic?
If the hemodynamic permits, if the patient is having a blood pressure, proper blood pressure in 3 digits, then I like to do an angiogram before doing anything. But like patient is coming in a cardiogenic shock situation and runs of arrhythmia, storm, VT, in that case, I will not waste my time and just hit the culprit first.
Yeah, this is a very important lesson for all of us, particularly younger cardiologists going for PCI in STEMI situations. If you have hemodynamically unstable because of hemodynamic change or because of arrhythmia, you better go straight for the clinically suspected artery dilatations with a guide catheter rather than going for a diagnostic shot. Any other question or comments? Dr. Patel, do you like to make any comment or any?
See, I tell you, I always love listening to Ajay Mahajan. He delivered it so well. He's, and it can be very, very useful to all those young guys who are, opting for further bright career. He has narrated everything so well and in depth. And nowadays, the problem is in our era, probably Professor Datta, we have gone through the era of simple balloon and then the transition of stent and then from bare metal to drug eluting. And the character of hardware was extremely, to know the character of the hardware was extremely important for us.
Exactly.
But because of this sophistication in the hardware technology, many times I find that the new generation cardiologists don't give too much of time understanding the behavior and character of the guide wire, guide catheter and balloon. And that can create a problem for them at times. So I personally feel that everybody should understand that whatever you take in your hand, you should be very well versed with the behavior of that particular product.
Yeah, thank you for your comment. Then we have the next, another problem that comes up in STEMI PCI situation is a thrombus. How do you deal with this enigmatic obstructive element in the process of STEMI PCI? Dr. Subhash Chandra will be talking on thrombosuction, when and how. obviously in STEMI.
Right, sir. Thank you. Can you see my slide, sir?
Yeah.
Okay. Thank you, sir. So I'm glad that I'm part of a very interesting session, which has to do with the tips and tricks of practical angioplasties in day-to-day practice. So here I am with thrombosuction. What is the current status? And if at all needed, what should be the way to do it? As we know that acute MI STEMI in particular has the highest mortality of all. And that's because of the fact that the pathogenesis of STEMI is thrombus or thrombosis in the coronary artery. And therefore, to treat it, various means, be it primary angioplasty or resolving thrombus by some drug. The ultimate aim is to bring TIMI3 flow in the artery as well as in the microvascular circulation, which is reflected in the myocardial blood pressure score. So with that rationale, at the outset, I must clarify that as of now, the current status of thrombectomy or thrombosuction primary PCI is in general no. Because the effect of this modality has not been translated into mortality reduction. On the contrary, there are times when it has led to higher incidence of a stroke or peripheral emboli. But it's worthwhile considering it in special niche situations where there's a high thrombus burden, or there is a thrombotic venous graft occlusion, or there are ectatic vessels. But the usefulness is not well established. Let's go back to the history. The concept came in sometime in 2008 when this TAPOS trial, which was a landmark prospective randomized trial of close to 1,000 patients. And it showed at that point of time that if you use routine thrombosuction in primary PCI, it does lead to improvement in the overall cardiac events and cardiac death even. But this trial could not stand the test of statistics because it was a single center trial, and therefore some more proof was needed. And that came in various other real world experience as well as some small trials like Infuse AMI. But then this trial was launched with that aim of showing mortality benefit of routine thrombosuction. And this trial miserably failed to show any mortality benefits by doing routine thrombosuction in primary PCI. And then, of course, the total trial in 2015, again, 10,000 patients, there was no reduction in MACE, and there was, in fact, on the contrary, increased risk of stroke at the end of 30 days. So therefore, the current status in the guidelines is that it, if at all, earns class 2B/C, weak indication for selective and bailout aspiration thrombectomy in patients undergoing primary PCI because it's not well established. And in fact, it is routinely prohibited because of the high risk of stroke. But in the current times, there have been instances, especially in COVID times, or in the younger patients who land up with STEMI under the background of smoking. There are times when the only single vessel has a lot of thrombus burden, and once you've cleansed it by a simple balloon dilation and thrombosuction and some kind of imaging, you realize that the infarction happened because of a very subclinically occlusive plaque, which perhaps had the plaque erosion or rupture, and then you decide whether it, if it all needs stenting or not. So those are the wider ramifications of carrying out a thrombosuction in our niche cases, because it gives you a lot of guidance about the future management. So in the beginning, this tool came in with a lot of fanfare, rheolytic thrombectomy, and it required temporary pacer also. And it was virtually given up because of the trial data which I have shown you. Various thrombectomy catheters or thrombosuction catheters are available to us, ranging from Pronto to Export to Thrombuster. And of course, more powerful suction devices like Penumbra, which is largely used in the peripheral interventions, but sometimes also in coronary interventions. And now, of course, the laser for the very well organized or old thrombus in the coronary arteries. Sometimes people even try deep throttling of guiding catheters, or even guide extension catheters, to suck out large chunk of thrombus from the ectatic vessels. So just a word about, if at all needed, how should we proceed? The selection of the catheter depends on the lesion characteristics, whether it's tortuous, calcific, because you have to go all the way deep into the coronary vessel in the distality, and whether it's 6 French or 7 French compatible with a stylet or no stylet, because so often these catheters kink while you're trying to push them over a guide wire. These are various catheters. I'm sure the astute experts which are there on this panel would vouch that they have used most of them in their practice. The catheter is flushed. Over the wire catheters are there with a very small hugging part, and the vacuum syringe is attached in this manner, as you see. The catheter is attached here. The lock is first done here, and it is then only that you start suction and lock your syringe here, and you will not open it until you have reached in the distality of the coronary artery when the thrombosuction starts happening. And mind you, the process of pushing the catheter and withdrawing it has to be very, very slow, and keeping all the checks on distal embolization, either in guiding catheter or in the aorta, where it could lead to even catastrophic strokes. This is a wrong method. The syringe is never to be connected to the hub of the catheter. Rather, there should be an extension tube, and then only you connect it here. Having done that, you got to insert it on the monorail, not like this into the central lumen, but on the hugging monorail portion where the guide wire goes in. It's always good to have a stylet in these catheters because that avoids the kinking and helps pushing this catheter into the coronary tree. But if you don't have it, you can even use an additional guide wire to push your tool into the coronary artery. So you need a strong catheter support. Do not push too hard because this can lead to loss of guide wire even and guide position sometimes, or even cause dissections or kinking of your own thrombosuction catheters. It is then that you start slowly advancing it and withdrawing it, open the vacuum, and a constant suction or thumping motion on the syringe, and you keep watching on the suction of clots of blood into your syringe. The moment it stops coming in, you should suspect that something has got to stick at the mouth of the suction catheter, and you should carefully withdraw it, clean that mouth, clean the thrombus on a swab, and then reinsert and make several passes so as to ensure that the artery brings in TIMI 2 or TIMI 3 flow. You can even infuse sometimes certain substances like Nicoran or nitroglycerin or even adenosine through this, or sometimes even GP2B3 inhibitors are given off-label into the coronary tree. One has to be very careful about the distal embolization and systemic embolization by these clots, as I said. And this is a classic case when there was nothing coming out in the syringe. The tip of the suction catheter was actually occluded with the thrombus, and until you clean this, the suction catheter has not going to be efficacious. Now, in case the thrombus is dislodged into the guiding catheter, you must thoroughly flush it. Sometimes there are times when you withdraw the whole assembly and then reinsert. And this is what you see. Classically, you see red thrombus, or in the venous graft, you see long serpiginous thrombi, or even white thrombus in a little old MI or an organized thrombus. Having done that, thrombus removed, now we're ready to stent. And it is here that you got to utilize certain imaging tools because the thrombotic vessel is usually undersized, and you always err on picking up the proper size of a stent. Therefore, OCT or an IVS give an exact guidance about the size of the stent and the length of the stent. So here I show a classic case when acute MI presented with a huge thrombotic occlusion of a major right coronary artery, and we immediately started. You could see the thrombus sticking into the whole of the distal vessel beyond mid RCA. So we quickly pass in a wire. Sometimes you need a little tougher wire like Pilot 50, and the usual wire would not go, or may take the support of some kind of micro catheter to push it. Once that is done, then the thrombustor catheter was taken here and was passed all the way slowly into the coronary tree, into the distality, taking care that we open the syringe lock only when we are there, and we start making a few passes carefully in the vessel. And this is what the debris came out. This was relatively older MI, so the color is not exactly red. There's some whitish patches here. Having done that, we must always choose the imaging modality. Luckily, in this case, we did one because it sounded very interesting. And what we saw to our surprise is a large chunk of thrombi sticking to the vessel, and we could even see some kind of plaque rupture at some point, as you see all the way into this vessel, starting from beyond the crux of the RCA to the proximal RCA. Having done that, it also gave us an opportunity to measure the exact size of the vessel, and this vessel was exactly in excess of 4 mm or 4.5 mm. These are large thrombi seen here as the white thrombus. So having done that, we made some more passes because of the thrombosis sticking. We also realized that there was a lesion in the distal vessel, and until we open it, the thrombus will not go into the distality and the artery will not be clear. So we decided to put a stent there in the distal part of the vessel, as you see here on the PLB branch. That was pre-dilated and a stent was put there. And having done that, there was a brisk flow in the end, and the thrombus was still there in the distal and mid RCA. And then we started stenting it, having done some more suction here. So we stented first in the distal part of the vessel with a 4 millimeter stent, and then picked up another 4.5 here in the proximal RCA overlapping, and in the end some post dilatations. And this was the final result, which was very heartening, and patient did well. There have been times when you got to give up your procedure midway because of the large thrombus being present there, and stenting these lesions could result into further compromise of flow. So you may try to bring these patients next day in, or if you've done an imaging and you realize there's just a plaque erosion, you may not stent these vessels at all. Or classically in a smoker, when the lesion is just about 20% or less, you may not prefer to stent these vessels and leave them alone just after thrombosuction plain balloon plasty. So this is my concluding slide, where it is seen that a coronary thrombus, the best strategy is to prevent it from propagating into distal vessels. So anticoagulate properly, give good antiplatelet, especially ticagrelor, sometimes GP2B3 or even cangrelor, which is now available in the country, could be given. And if there's a large thrombus here, the prime responsibility is to restore the coronary flow. And if anticoagulate flow is not present, then you wire through the thrombus and balloon it so as to bring about some flow. If there's a flow, then you estimate the thrombus size. If it's large and ongoing ischemia, you must consider the thrombectomy or distal filter, especially in venous grafts, or using laser if it's an organized thrombus. And all of them work very well to cleanse this artery and decide you to put a stent. Or a simple ballooning in a small thrombus sometimes does. And these are majority of cases where a simple balloon would bring about flow, and the aortic pressure head would just flush your thrombus distally, and you may not need any thrombus. So one has to use a lot of discretion while opening the thrombectomy catheters on your primary PCI cases. Looking at the flip side of it, there have been attempts on the AMGuard stent in a master trial where they say that the thrombus sticking to the wall is arrested or plaster to the wall, and that to some extent can prevent distal embolization, but it has not been translated into any mortality benefits. Or distal filters used in venous grafts, and all those strategies I'm sure most of us follow in our contemporary practice. Thank you very much for your kind attention.
Thank you, Dr. Subhash Chandra, for your excellent deliberation.
Thanks. Sir.
But we have to wait for the last speaker till then. We will not have any discussion or question answer because of the time constraint. I have the pleasure in inviting Dr. Himanshu Gupta, who will be talking on coronary perforation during primary PCI, how to manage.
Good afternoon, everyone. Thank you so much, Dr. Nitish and Dr. Yadav, for this kind opportunity to be part of this nice session. I hope you can see my slides.
Yes, sir, your slides are visible.
Yeah, thank you so much. I was asked to talk about coronary perforation during acute STEMI intervention.
Yes.
I would like to admit, unfortunately or fortunately, I've not had a perforation during a primary PCI, but of course you have perforations in your other elective cases. So I would just like to present what is, I think, a teaching case in terms of dealing with a coronary perforation. So it's a 2-year-old case, a 74-year-old male who presented to us in PGI with unstable angina for a few months and had previous PCI to LAD in 2006. He was an elderly gentleman, 74-year-old. So the right coronary artery was the culprit at that time. The left stents were patent. So you see here, it's a very superdominant right coronary artery, which is very tortuous in its mid and distal segment, and is heavily calcified in the proximal and mid part of it. So we had to treat this right coronary artery, and we decided to do upfront rotablation for this heavily calcified lesion. So here we wired with a workhorse wire and exchanged with a rotawire over a fine cross microcatheter. So considering a very diffuse and tortuous vessel, we decided to undersize the burr initially. So we started with a 1.25 millimeter burr, which we have to burr carefully through the middle of the right coronary artery, especially using the RAO view to also check the coaxial position of the guiding catheter. So after doing a 1.25 mm burr, here you can see on the left side, we take an angiogram, so everything is fine. Of course, the vessel is quite large, so we step up the burr to a 1.5. So here is the polishing run of the 1.5 mm burr in the RAOV on the left side. And you see the angiogram, so everything up till now is all right. This procedure was unfortunately not done under IVUS imaging, which I think it should be essential to do with some sort of imaging. So after that, we took a 3 millimeter balloon, which was not very aggressively sized as the vessel was at least 3.5 or 4 millimeter. So immediately after the 3 millimeter dilatation at 16 atmospheres, we see a large perforation at the site of the dilatation. So the most important thing is whenever the patient has perforation, generally they complain of acute pain. So that is why probably it is a good practice to not take the balloon out and wait for an angiogram. Generally keep the balloon inside the guiding or at the site of the lesion if the patient complains of pain, and then take an angiogram, like was done in this case. So immediately a balloon occlusion was done with the same balloon which caused the perforation. And as it was a large perforation, I think we know that it is going to be a difficult case to manage. So having a balloon occlusion and already thinking about what needs to be done immediately later is very important. So immediately a second access was taken, which is always cleaned and ready. And a JR guiding catheter was taken from the second groin axis, a 6 French JR guiding. The initial guiding was an amplet 7 French. So the balloon is still tamponading the original site of the perforation. So here is very important step. What we do is we deflate the original balloon from the first guide. We take a second guide wire from the second guiding catheter called the ping pong guiding. And in this case, it was a hydrophilic fielder wire, and we just insert the fielder wire from the second guiding. So now we have 2 guide wires and 2 guiding systems, which comes in handy. In a way, what we do is we take out the first balloon, which is in the first guide, which is very supportive, which will help us eventually to deliver the covered stent if required. And we take a soft semi-compliant balloon from the second guiding catheter, put it at the site of the perforation and inflate it at low atmospheres, only 4 to 6 atmospheres, not very aggressive, because generally it can lead to enlargement of the perforation. So we wait for 3 to 4 minutes and we take an angiogram, but the perforation is still persistent. So you need to put in a covered stent. So here again, the ping pong guide comes in handy. So what you do is the second balloon that you took from the JR guiding catheter, you push it distally and you inflate it. So what it does is it jails the first guide wire. So the first guide wire and this balloon actually becomes a rail. So this rail helps you in delivery of the covered stent, as you see on the right side. So because you are jailing the first guide wire with the second balloon, it provides a very strong rail support for you to deliver the covered stent. So once the covered stent is in position, you no longer need the second guide wire or the balloon. So you remove the second guide wire and balloon because you don't want to jail it behind the covered stent and it will become a second complication. So after that, you confirm the position of your covered stent and then you deploy. So in this case, it was successfully deployed. And then distally and proximally 2 other stents were deployed to seal the perforation completely. Thankfully, the patient tolerated the perforation very well, as the perforation was occluded from the beginning till the end with one of the guiding catheter and the balloon. The patient did not develop a pericardial effusion and no tap had to be done. So the patient remained stable. Also, patient had some collaterals to the PDA from the left system, which also prevented him from having any ischemic event during the procedure. So there was no pericardial effusion at the end of the procedure. So I think the learning points in any large perforation is we must prevent it with imaging or a different way of doing the procedure. Immediate balloon dilatation should be the first and is the most important step in any large coronary perforation. Having a second guiding system, like in this case, can minimize the possibility of developing pericardial effusion and acute hemodynamic compromise. Balloon tamponade from the contralateral guide also helps in deployment of the covered stent from the first guide if required by providing a rail support. And we should always do PCI with 2 ready access sites, either 2 radials or 1 radial and 1 femoral. And we should always have 2 ready access sites available. And we should always check the cath lab inventory before the first case, because we should always know what devices and equipment we have, because sometimes we may require guide extension catheters or covered stents, or if there is a wire perforation, some coils. So we must check cath lab inventory, especially if you work in a government lab like me, where you don't know what is there available. And finally, I will just say this, what Professor Colombo says, that if everything looks okay, but the patient is complaining, stop again and look again harder. There's something that you miss. And if you've not had a coronary perforation, then there is only one reason. You've not done enough cases. You will have once in a while. And it's generally not your first mistake that will kill your patient. It will generally be the second. So a perforation probably won't kill, but if you don't seal it properly or you make another complication while managing the first one, it will definitely kill your patient. Thank you so much.
Yeah, thank you very much, Dr. Himanshu, for your very valuable presentation in terms of perforation of the coronary artery, how to prevent it, how to treat it, and your message. Thank you. Because of the time constraint, we will have discussion at the end of the session. I now have the pleasure of inviting the next speaker, Dr. C.B. Meena, who will be talking on the primary PCI STEMI in a patient with hemodialysis, chronic renal failure, what needs to be done.
Good afternoon, everybody. First of all, I'd like to thank STEMI Council India, CSI, and the organizers, Dr. Nitish Naik, Dr. Suman Bhandari, and Dr. Rakesh Yadav, for giving me the opportunity to speak on the PCI management strategy for STEMI patients in chronic kidney disease and patients on hemodialysis. And there are no disclosure regarding this talk. We all know CKD is a major risk factor for coronary disease, and there is a higher prevalence of additional risk factors like diabetes and hypertension in patients with CKD. So they are exposed to increased risk of CKD. Apart from this, the uremia-related cardiovascular disease factors like inflammation, oxidative stress, and abnormal calcium phospholipid is a major risk factor for the CKD and CAD and CKD patients. Following the introduction of the dialysis, it has become evident that CAD is a major cause of premature mortality in the patient with end-stage renal disease. And compared to general population, the cardiovascular death rate is 10 times higher, and especially young, the subject is more than 100-fold. So this is one of the important considerations in the patients who are being managed for the acute myocardial infarction. And it is now appreciated that early stage chronic disease is also a risk factor for CKD, for the CAD in the patients. This figure shows the difference in the mortality. If you compare the patients who are on dialysis with the general population, there is significant increase in the mortality. And if you look at, there is almost 10 to 100-fold to 1,000-fold increase, especially in younger population of 25 to 34 years of age. And if you look at the causes of mortality in this population, like acute MI, heart failure, arrhythmia, and cardiac arrest, and other cardiac condition are the major chunk. That is almost 45% of the mortality in this patient. So this is one of the important considerations in the CKD patient. And this table shows that as the stages of the CKD progresses from stage 1 to stage 5 or end-stage disease, the risk factors or the CV risk odds ratio increases significantly from 1.5 to almost 20 to 1,000. So it is very important consideration in the management of these patients who are undergoing treatment for acute myocardial infarction. There are several large studies, including meta-analysis in general population of over more than 4 million subjects, just showed an independent inverse correlation with the EGFR and cardiovascular death rates. And threshold for EGFR at various studies have shown that at less than 60 or 60 ml per meter square is the cutoff where the mortality increases. 2 recent studies have shown that 10-year follow-up of the data showed that perhaps EGFR less than 90 is also increases factor for the CKD. CKD and end-stage disease modify clinical presentation, and we all know that the patients who present with the acute coronary syndromes have oligosymptomatic, like they either have less symptoms or they have unusual symptoms. And it is known that only 45%, 44% of the patient with stage G3 or A higher have a presentation of a chest pain as acute MI, and they only have some shoulder pain, neck pain, and compared to 72% in the general population. So there is significant variability in presentation. That's why they are underdiagnosed or misdiagnosed and they are undertreated. It is also important that they have symptoms like dyspnea and other symptoms which suggest ingenical, and so we should have high index of suspicion if you have to detect early and to have proper management of these patients. And finally, the intradialytic hypotension and myocardial stenting is important, and this is one of the unique features in patients who are hemodialysis and is specific to hemodialysis syndrome. So this procedure is also taken into consideration when we are managing the patient with myocardial infarction. As far as the guidelines are concerned, in the absence of dedicated clinical trials, because there are no randomized clinical data especially dedicated to CKD patient with STEMI is concerned, the patients who present with STEMI undergo same invasive approach as those with a normal kidney function. Although observational data support that early invasive strategy in non-STEMI SI or acute coronary syndrome have no survival benefit in these patients. All dialysis patients presenting with ACS should be treated as in the non-dialytic patient, but we should have special consideration like drugs which have cleared from the renal clearance. They should be either avoided or they should be used cautiously, like low molecular weight heparin. But all the regular treatment like antiplatelets, the beta blockers, use of ACE inhibitors and thrombolytic therapy should be used as in general population to reduce mortality and morbidity in these patients. Dialysis patient with ST elevation MI should receive acute repulsion therapy, though there is increased risk of hemorrhage. So if the primary PCI is not possible, they should receive thrombolysis. There is no doubt and question about it. But the PCI is the preferred treatment if it is available. The timing of dialysis after the PCI within 48 hours is one of the important considerations. If somebody has acute ST elevation MI and is treated as the primary PCI, and he has to undergo dialysis after 48 hours, that is a major concern. There is no data regarding the safety and risk associated with dialysis 48 hours after the acute coronary syndrome. But the team approach with the nephrologists and the cardiologists have to take a decision, and the important consideration should be given to volume status, electrolyte imbalances, and bleeding potential. And dialysis prescription should be adjusted, taking into the risk and benefit and risk of hypertension during the vulnerable period. Mortality after the acute MI in dialysis patient has been reported to 75% at 2 years. So this is because despite the adequate data available, there is underuse of the drug like aspirin, beta blocker, or ACE inhibitors, or thrombolytic therapy in this patient. So this has to be taken into consideration so that all patients derive benefit of guideline-directed treatment in acute MI with CKD. If GP2B3 antagonist has to be used, efzimfumab or teriflunomide is the preferred agent, since there is no change alteration in the dosage pattern with the CKD. And especially dose specific with the tyroflunomide with the CKD or dialysis is available. So if you use tyroflunomide, then it should be, but preference is efzimfumab or the tyroflunomide. Efzimfumab has shown in one study the safety even in the patient with creatinine of 2 milligram or more, but there is slight increase of the bleeding rates. Despite increased bleeding rate, reduced in-hospital mortality in CKD patient has been documented in one of the trials with acute ACS patient where use of GP2/3 antagonist has been done. To minimize the risk of potential volume overload, it is advised that isosmolar radial contrast should be used, that is hydroxylenol, and whatever the amount is used, it should be minimum amount which should be used. The nephroprotective strategies, especially the patient who have the borderline function or underlying some kidney function, so use of hydroxylenol, proper hydration therapy, and avoidance of nephrotoxicity should be used in all patients. So limitations of the data is that there is no dialysis specific clinical trial, and it is difficult to assess the bleeding dialysis, and therefore risk associated with use of GP2B is individualized, and the use of this drug has to be individualized in every patient. As far as the access side for the preference in the cardiac catheterization is concerned in the patients who are dialysis or end-stage disease, we all know that recent guidelines driven data show that all patients with STEMI, the transradial route is the preferred treatment of mode of management of strategy, because this is associated with decreased bleeding, and bleeding is associated with complication. So patients undergoing invasive strategy, it is important that we have to avoid use of jugular site. We have to preserve the brachial and radial strategy, because the patient may require these access for the future AV fistula formation if the patient is undergoing for dialysis. And there is increased radial graft of the patient. If the patient is undergoing CABG, there is documented data that radial patency is more. So that is also indicate one of the important consideration when patients are taken for the this procedure, the transradial approach. So that we should preserve the radial, especially right radial, and even if the radial using left radial should be used. But ultimately the decision has to be made by the heart and kidney team approach. So as far as the use of femoral versus transradial approach is concerned, the patients are categorized as the high-risk bleeding, so transradial approach is usually preferred, and there is potential reduction in mortality with the use of transradial approach, but and there is potential reduction in the acute kidney injury. But there is increased risk of radial artery occlusion, and there are structural changes documented in the CKD patient. So use of radial artery as a preferred treatment should be avoided as far as possible, or the use of left radial artery should be the preferred mode of therapy. As far as the dual antiplatelet therapy is concerned, there is limited data in the guidelines which can highlight the use of antiplatelets or dual antiplatelet in CKD patient. But important consideration, because the risk of ischemia and bleeding complications in this patient, the risk-benefit ratio has to be weighed. The available data suggests that in the setting of advanced CKD, extended duration is associated with increased bleeding risk, so it is not preferred. So long-term use after 1 year is usually avoided. That should be not the preferred treatment. And there is also no prospective or randomized control trial data available for use of antiplatelet, anticoagulants, or CKD or end-stage patient in patients who have atrial fibrillation along with the acute coronary syndrome. So for the DAPT used in patients with CKD, they both increase risk of bleeding and thrombosis is there. So newer generation DS have low rates of stent thrombosis, so they should be preferred over the bare metal stent. And the minimum DAPT duration for stable CAD is 6 months only, and patients who have presented the acute coronary syndrome into ST elevation should be 12 months. There is limited data to support new P2Y2 inhibitor, that is ticagrelor over clopidogrel, and in end-stage disease patient the ticagrelor is usually contraindicated. And similarly, use of triple therapy including DOAX or P2Y2 inhibitor is also data is lacking, but we should avoid triple therapy in patients with CKD and with dual antiplatelet therapy. As far as the mode of treatment in this patient, PCI versus CVD, again, the short-term procedural risk of both PCI and CVD is higher in CKD patient compared to the general population or without CKD. And there is a data to support the PCI or CVD in patients with CKD, in patients who have acute coronary syndrome. But there are only few patients which are involved in these clinical trials. So only observational study data is available, and which has shown that there is short-term higher risk of mortality and stroke in patients with CABG. But if you look at the long-term data, the risk of mortality and repeat vascularization and myocardial infarction is less with the CABG compared to the PCI. So the frailty and comorbidity conditions along with the CKD makes a critical use of the patient-centric decision. The decision has to be made between cardiology and the nephrologist team along with the patient, and the long-term risk benefit of the intervention and the overall CKD-related prognosis should be taken into consideration once the decision has been taken. As far as the prevention of acute coronary injury in PCI versus CVD is concerned, it is known that there is no benefit of use of bicarbonate or N-acetylcysteine on the reduction of incidence of AKMI. Only normal saline or the proper hydration is the strategy which should be followed in all patients. In dialysis-dependent patients, AKI is low with ultra-low volume contrast strategy or no contrast strategy with the use of proper hydration. Risk of acute kidney injury is considerably higher in CVD compared to PCI. Preservation of residual renal function should be the utmost priority. So whatever we can do to prevent the underlying normal kidney function, we should do. And the recommended strategy includes avoidance of non-steroidal anti-inflammatory drugs, diuretics, proper hydration, titrating blood pressure to avoid hypertension, low contrast volume, and zero contrast PCI. Despite the use of the risk of contrast-induced AKI, there is low risk of patients, especially in CKD patient. So this should not be the reason to avoid the PCI in CKD patient. All patients who are candidates, they should have the PCI as the preferred treatment. This is one of the studies which has looked into the matter of anticoagulation use in patients who are undergoing coronary intervention with end-stage renal disease. And the study is highlighted that use of unfractionated heparin was more in this population, and the use of bivalentine was associated with low rate of hospital bleeding and mortality. But the data is limited, so it highlights that there is a need of randomized clinical trial to look into this matter so that we can have proper recommendation or guidelines. As far as the use of statins in the post-PCI management, benefit of reduction of major vascular event becomes smaller with the declining GFR. And patients who have end-stage renal disease, there is no benefit with the use of statins. So these are few of the studies like 4D, Aurora, Sharp, which have not shown any benefit of use of a long-term statin in patients with end-stage renal disease. The recommendation about the use of a statin is that statin is beneficial in the early CKD, and there is less clear benefit in advanced CKD or end-stage renal disease. They should be used if there is indication for use of statins and they are safe in CKD patients. And the PCSK9 inhibitors can be used as up to stage 3G. As far as the preference of the stent is concerned, this is one of the studies which has looked into the role of drug-eluting stent in the patient with end-stage disease, and the data has shown that there is no the use of second-generation DES did not improve clinical outcome in patients with CKD at 12 months follow-up. So there is no preferred strategy as far as the use of the stent are concerned. And if you want to reduce the risk of bleeding, I think bare metal stent can be considered with the use of short-term DIPT. This is the recommendation as far as the patient's CKD is concerned regarding the percutaneous coronary intervention. It's published in 2011. The class has done a recommendation highlights that the patients undergoing PCI, the glomerular filtration rate should be estimated in all patients before going for procedure. The CKD is independent risk factor for the development of prognosis of CAD and MI and PCI. The GFR of less than 60 or less than 60 ml per minute, 1.73 distance of fascia in the cutoff, which increase the risk of procedure in acute aspiration of patients. But CKD is not a strong predictor for restenosis after BMS or DS. So the use of stent is not a contraindicated in the patient, and wherever the use of stent is done, this can be used. Preferably, the bare metal stent can be used. Platelet dysfunction and the overdosing of antiplatelet and antithrombin drugs leads to increased risk of bleeding. So use of these drugs has to be cautiously, or it should be just as per the need when the individual patient is concerned. The medications required dose adjustment include tyrofipine, bivalirudin, enoxaparin, fondaparoxone, and eptifibatide. And especially patients who are end-stage renal disease, use of enoxaparin and the other agents are contraindicated, especially technology also contraindicated. As far as the contrast-induced AKI is concerned, the recommendation says that patients should be assessed for the risk of contrast-induced AKI before the procedure. They should undergo cardiac catheterization with contrast. We should be isosmolar, and the patient should have adequate volume status to have adequate hydration, and the amount of contrast media used should be minimized as far as possible. And there is no role of N-acetylcysteine or bicarbonate for the prevention of the AKI in this patient. And finally, the indication for re-escalation in patients is shown again in 2014 guidelines. They said the patient who have chronic stable disease, the same as the normal population, left main triple vessel and disease are benefited with the use of invasive strategy. In patients who have acute NSTMI or acute coronary syndrome, invasive strategy preferred if they have angina, hemodynamic instability, or arrhythmia. But in stable patients with non-ST elevation MI, it is class 3 recommendation. As far as the ST elevation MI is concerned, early invasive strategy is also preferred strategy, and all patients who are presenting with ST elevation MI in end-stage renal disease, they should be given, if the PCI is possible, preferred. That is the preferred treatment strategy in these patients. Thank you very much, and we can have questions later.
For your exhaustive deliberation on primary PCI STEMI for the CKD or renal failure patients or on the hemodialysis. Because of the constraint of time, we cannot have discussion for a long time. Just one or two comments, if somebody like to make on the issue on the subjects of this session. Okay, if there is no questions, let us call it a day. But before that, I just make one small comment that doing PCI in STEMI patient early is beneficial in many ways. Not only we are salvaging the myocardium more, but also the thrombus remains very soft like a butter. If you do it late PCI, late primary PCI, the thrombus get organized and all the complications of organized thrombus dislocations and take place. So doing early is best for many of it, for very many reasons. With these few words, I thank all the speakers, the audience, and the vibrant discussions, and special thanks to Dr. Patel for giving his personal opinion on certain issues. Thank you very much.
Thank you. We now move to the next session. This is titled STEMI Primary PCI, When It Made You Sweat and Swear. Our chairpersons are Dr. Ajay Bahl, Dr. Deepti Siddharthan, Dr. Jagal K. Sharma, Dr. Mukund Deshpande, Dr. B.P. Jayagopal, Dr. P.P. Deshmukh, Dr. Samtanu Guha, and Dr. Vinod Sharma. They now request Professor Samtanu Guha to start the session.
Thank you. This session is on primary PCI in STEMI, when it made you sweat and swear. As I saw as I've gone through the program, that is each session, each talk is of 12 minutes. What is the duration of discussion and the talking time to the organizers? Is it 10 plus 2?
Yes, sir, it's 10 plus 2.
Fine. Can we have our first speaker here? Tanmay Mukherjee. Dr. Tanmay Mukherjee, please.
Yes, sir. Am I audible?
You are audible. You start sharing your screen.
Is it visible, sir?
Yeah, it's visible.
Good afternoon, everybody. Respected chairpersons.
You make it full screen.
Respected chairpersons. Today, my topic will be nightmare during primary PCI. A 57-year-old non-diabetic lady presented at our hospital with chest pain. She had anterior wall STEMI diagnosed outside, and she was referred few hours after chest pain, and she was not thrombolized. When she attended our hospital, she was having severe chest pain. Hemodynamically, she was stable. Blood pressure was around 110/70. Patient was in sinus rhythm. Blood parameters were normal, and echocardiographically, we have seen ejection fraction was around 40%. Then we have loaded the patient with clopidogrel, aspirin, and atorvastatin, and decided to go for angiogram. Radial access was chosen. This is the angiographic view. The left anterior descending is cut from proximal part. RCA and circumflex artery were more or less okay. Then the lesion was crossed using the floppy wire. And we did the balloon daughtering. After balloon daughtering, this is the result. Then we have chosen 3 to 48 metaphor stent, sirolimus eluting stent, and deployed from the proximal end. It was inflated around 13 atmosphere pressure, and the nominal was 11. So after deflating the stent balloon, we have checked with the dye, and after injecting the dye, this was the result. There was free flowing perforation from the LAD, and it was from within the stented area. And we immediately look for echocardiographic evidence of any pericardial collection, whether present or not. And luckily, we didn't have any evidence of pericardial effusion by echocardiogram. And we took another shots, and probably it was in the cavity. And throughout, luckily, the patient maintained hemodynamics well. Then we went for balloon inflation to try to seal the perforation. And we have taken the balloon, inflated it for around almost 15 minutes, but it was of no help. And again, we have done serial echocardiography, but there is no pericardial effusion. We have stopped GP2B inhibitors, and we didn't go for heparin reversal as there is no pericardial effusion. And again, we continue to inflate the balloon to stop seal version, but this attempt was in vain. There is no improvement. So we decided to put covered stent, and we simultaneously accessed the femoral root. And in radial access, we kept on inflating the balloon through the radial root. And then after reaching the aorta with femoral guide cath, we could not do it simultaneously. Then we had to take the radial guide catheter and balloon, and had to taken out those things, and we continue with the femoral route, and we could successfully put the stent. This is 3.5 into 19 millimeter graft master covered stent. And after inflating it at what I can remember, it's 15 atmosphere pressure. This is the final result. Although the distal flow is little compromised, but the perforation is successfully sealed and patient remained stable. There is no hemodynamic compromise of the patient. And she was shifted to bed in stable condition, was observed for another 5 days, and then discharged with stable condition. And during follow-up visit at OPD, she was stable. Now, coronary perforation, it's unusual, but it can happen. The overall incidence is 0.2 to 0.5%. There are some predictors. One is clinical predictor, angiographic predictor, and technique-associated predictor. Clinical predictor is advanced age, female sex, renal impairment, non-ST elevation, myocardial infarction patients. Angiographic predictors include chronic total occlusion, coronary artery calcification, type C lesions, tortuous vessels, long target lesions, and eccentric lesions. Technique-associated factors, hydrophilic or extra stiffers, atherectomy devices, increased balloon to artery ratio, intravascular ultrasound-guided PCI optimization, and high-pressure stent post-dilatation and cutting balloons. This is the classification of coronary perforation. The most accepted is Ellis classification. Type 1 means extraluminal crater without any extravasation. Type 2 pericardial or myocardial blush without contrast jet extravasation. Type 3 is extravasation through frank perforation more than 1 millimeter. And type 3 cavity spilling, or sometimes it is delineated as type 4 when perforation occurs into an anatomic cavity chamber or coronary sinus. And like our case, it was type 3 cavity spilling. And type 1 is benign prognosis, whereas type 2 coronary perforations have the potential to progress to tamponade. Type 3 coronary perforations are usually caused by devices like balloon stents or other intracoronary devices, and they can lead to cardiac tamponade necessitating pericardial drainage. However, type 3 perforations can be managed with covered stents. This is algorithm of management of coronary artery perforation. If it is type 1, then you have to see whether vessel is less than 2 millimeter diameter or it is more than 2 millimeter. If it is less than 2 millimeter, then medical management is usually sufficient, and close clinical and hemodynamic observation along with ECG monitoring is very much essential with serial echocardiography. If vessel is more than 2 millimeter diameter, then stent deployment may be considered, and if all these measures fail, CABG should be opted. For type 2 or 3 perforations, we have to stop GP2B3A inhibition and then consider platelet transfusion or reversal of heparin with protamine. And it is recommended only when evidence of contrast-free flow is into the pericardium. Prolonged balloon inflation technique over perforation site is recommended, and it should be repeated. Emergency echocardiography is very, very essential. Pericardiocentesis in indicated situation should be done, and IABP, if needed, can be taken help of IABP. If sealed, then close clinical follow-up with serial echocardiography is sufficient. Otherwise, if there is persistence of problem, then either we have to put covered stent or we have to refer the patient for coronary artery bypass surgery. Now, covered stents, there are several reports that use of covered stents to seal coronary perforations with good effect. This is more effective for patients having perforation in proximal or mid portion of the index vessel. And of course, we have to keep the guide wire in correct position in the true lumen. There are a lot of limitations also of covered stent, their side branch occlusion, then lack of flexibility, and more is more important is high incidence of in-stent restenosis. It can be as high as 25%, and almost 5% of stent thrombosis can occur in covered stents. Usually covered stents are deployed in ping pong method using two guide catheters, and these are some of the available covered stents. Usually we have a graft master, as in our case, and PK papyrus, and these are the specifications of covered stents. These are 6 French compatible if it is less than 4 millimeter, 7 French compatible if it is more than 4 millimeter size, and whereas PK papyrus, it is 5F compatible for less than 4 millimeter stent, and 6 French if it is more than 4 millimeter. So take home message is coronary artery perforation, although rare, but can happen after stent inflation, and it can be potentially catastrophic and can be fatal also. Covered stents are very much important gadget in our cath lab, and we have to keep it, and it can bail out in these devastating situations. Thank you.
Thank you, Dr. Mukherjee. Any question? Any question from any of the chairpersons?
I just have one question, that when you pull out the second wire, should you pull it out after the stent has been placed in situ, because you may need extra support?
Yes, sir. I should have done, but I could not do it simultaneously. That's why I had to pull it out. It was to be done simultaneously.
Tanmay, there is a question from in the chat box from Charan Lanjewar of from KEM Hospital. He has asked you, Dr. Tanmay, why was so long 3 millimeter stent put when the artery size was also not seen well after the first ballooning?
Sir, actually, we had to go along with our availability. In our hospital, the 2.75 stent was not available at that moment, and we had to put 3 into 48.
His question primarily was why so long stent, 3 millimeter, and such a big stent was put in anyway. That may be the problem of all the government hospitals. I think we should move to the. Thank you. Any other question?
Yeah.
Any other chairpersons? Any questions, sir? Otherwise, we move to the next speaker. Thank you, Dr. Mukherjee. Dr. Ranjit Nath, STEMI with heavily calcific lesion. Dr. Nath, please.
Good afternoon, sir. So I think you can see my slide.
Sir, please put it in presentation mode. Slideshow mode, sir.
Okay, so my talk is on STEMI with heavily calcified lesions. So as you can see, heavily calcified fibrocalcific lesions are hallmarks of chronic stable angina or chronic coronary syndrome. But the MI mostly related to soft heat atheroma rupture and thrombus, and related to their related low flow or no flow. However, presence of heavy calcium can be a real challenge and encountered very occasionally. Literature is sparse in this area. Only some case reports and series is published. So I want to show a few of the cases that we encountered during our course of primary angioplasty. This is a 76-year-old male hypertensive ex-smoker. He is presented with 3 hours of chest pain with inferior STEMI. Taken up for primary PCI after loading with DRPT and statin. Now you can see the left system, some fibrocalcific plaques are there. There's a small OM1, which is a type disease, but otherwise there is no significant disease in the LAD or diagonal. There's some plaques, but right corner you can see acute cutoff after the origin. A small soft guide wire of Cougar XT from Medtronic was passed, and you can see the flow has been established. So we thought that it will be a simple angioplasty. But if you see subsequently any balloon, it is a 2 and 2.5 into 10 millimeter balloon, nothing opens up. So even an OPN balloon could not open up the lesion after high pressure infusion. And remember, very high pressure, I don't go because there can be rupture. Sportflex balloon was taken, that also did not open up the opening. So even we tried a cutting balloon of 2.5 into 10 as a 2-hour body hour, but that did not go. So all these things took a lot of time and patient was having chest pain. And this is the ultimate result with balloons, and even the my fine catheter could not be, Corsair catheter could not be advanced. So we changed to a guide catheter because RCA guide was not giving us support. So we go into the AR1 guide, and the Corsair was taken, so it could not cross. So we keep the Corsair and the lesion itself and extend with a body rota where a TPA was put in because we are going for rota. Patient was not very stable. So you can see 1.5 mm bar was taken to a single bar. Initially, it was not going easily, but after some effort, bar immediately crossed. And as you can see from our NGO itself, that there was only one speckle of very severely calcified lesion. Rest of the artery was not having much problem. So subsequent to the rota, you can see the same balloon 2.5 into 10 expanded well, and we took a stand, and you can see that stand after post-dilation, there is nice result. So there is a single calcification that led to so much of problem. Remember, this case came when the lab was full on afternoon hours, and we could do the rota even during the primary and the first week. But most of the cases comes at night. So if you go to the second case, now you can see a 68-year-old female hypertensive. She came only last month, came after 6-7 hours of pain, reaches hospital at midnight for ongoing chest pain. This is just interval STEMI, heart rate 92, BP under 10 by 60. She was in Catholic class 2. She was also again loaded with dual antiplatelet, clopidogrel based dual antiplatelet therapy at atorvastatin, and was taken to the cath lab. This was taken by my senior colleague for at 1 a.m. in the midnight for primary. And you can see RCA some plus, but there is not much serious problem in RCA. And in LAD, you can see there is a width calcium. There is sheet of calcium in the LAD, and there is a very tight stenosis with TME1 flow. So it was wired by a floppy wire, and my colleague tried everything to pass, but even the smallest of balloon that we have is printer 1.25 into 6 did not cross at all. So tried everything, but nothing crosses. Even body wire technique he tried, but even with body wire, he could not pass a balloon. And this was the flow that could be established at midnight after 2 hours of attempt, and patient was very unstable. So it was decided to shift in the CCU. And CCG partially settled with some flow, probably chest pain reduced with IV nitroprusside and tyrosine, but she was having tachycardia, pulmonary crackles, needed bypass support. So decided to take angio and further procedure. So next day, once she was taken to the lab again in the morning earlier, so you can see the flow is much better. That must be the cause of some settlement of the ECG. And but the lesion is as usual, it is same. So it's a very weight-safe calcific nodule that is not allowing anything to pass. So there is no other option but to take we took a fine cross, that cross then extend with a floppy wire, took a 1.5 rota. Again, same, this is a single point of rota ablation, nothing goes. Remember that this point patient becomes very unstable, these flags are drawing, and I lost the wire partially. So I had no option but to do 1 bar, and I did 1 bar, and subsequently the same balloon could cross easily. You can see the balloon giving up, opening up, and was stamped successfully. And this is the result of the full dilation and stamping. So third case that I want to show is another 60-year-old male patient, sometime back, a smoker, has chest pain for 10 hours, admitted as and STEMI under medicine because I had no bed at that point of time, but in ward developed anterior MI, 30 to 35% EF with severe hypokinesia, also very sick patient. Here I actually see RCA, there was some disease in the early PLV branch, but LAD there was acute cutoff. We tried initially with radial, but there was no support at all to take the wire. And LAD, as you can see, some faint flow goes, but it looks like to be calcium, and we are not sure where the LAD is. There is a small branch going. So we switched to femoral approach with a 7-fence guide. Soft wires were not going through the lesion, so we took a field direct wire. With the field direct, nothing could be seen. So we dilated with a 2 into 8 with a 4 atmospheric pressure. Post dilation to this small branch, we can actually see some takeoff of a larger artery that seems to be the LAD, but there is definitely very heavy calcium with thin. But we did not expect so much of problem. So filter X itself, after taking a carb, it was passed. But you can see that the 2.512 PD balloon was taken for dilation. It's not dilating at the point of where there was severe calcium. The rest of the artery dilates, but at this point of time, place, the balloon is not dilating. We got some flow, so we extend with a soft wire, BMW wire, and we can see that LED is distal again after a large diagonal, second diagonal also. Dilated with a 2 balloon, 2 into 12, some flow has established, but LED is dissected in the proximal part. But that point, this dog boning of any balloon, there is a seat of calcium which is not giving away the balloon. These are high pressure PD balloons, and even we try to take a cutting balloon because there is no other option, but we have to debug this calcific plug. So cutting balloon will not go. So ultimately we brought in again a Godzilla catheter 6 fence. Godzilla was not going. Again, we tried your anchoring with a balloon of the Godzilla. Even then, this Godzilla is not going from that calcific point. So keeping the Godzilla there, we could pass the cutting balloon. But even then, you can see the second frame, that cutting balloon got actually ruptured. 2 cutting balloons got ruptured in this calcific plug. So there was no other option for me to open up this artery, available gadgets. So I thought that I have to do an see an IVAS and see. I probably have to go to Rota in a resected artery. So did an IVAS and found that there is a seat of calcium, 270 degree of calcium, and 1 point there was a heavily calcified lesion, which did not give there's multiple dissections. So extends with a wire, and ultimately again 1.75 single bar was taken just to cut that area because I know that there is back there is dissection of the artery. So without option, I had to do the bar and post bar extends the wire with again posterior microcatheter, did post dilation balloon preparation, and again so much of calcium that stent was not going. Now, of course, now it is easy that I could pass the Godzilla with the help of Godzilla. I could put 2 overlapping stents, and post dilation was properly done. And you can see now every balloon is opening up after doing that. This is the final result of the artery with good flow and patient symptoms relief. So if you go that there has been anecdotal case reports of having doing Rota during primary angioplasty. So we are also having done a good number of cases. We have done around 5-6 cases of Rota ablation during primary because there was no other option. But there is a publication from Sugamaya et al. In American Journal of Cardiology Intervention, JAG Intervention in 2019. They tried to find out the calcified plaques in ACS by OCT. They studied 1,241 odd patients where there were 30% were actually STEMI, accelerated MI, and rest were non-accelerated MI. They found that the major cause was plaque rupture in 48.9% and plaque erosion in 38.4%. But remaining 12.7% there was calcified plaque. And these calcified plaque lesions, there was no rupture or erosion they could find out. Out of these 12.7% of HCS patients having heavy calcium, they could divide these calcium into 3 groups. Superficial calcific seat, that is 67.4%. And this nature of superficial calcific seats were mostly prevalent in LED artery. And you can see this type of superficial calcific seats in frame C and D in the OCT picture, corresponding OCT pictures. And they led to more secret release after STEMI. Also, they used to have more calcification index. And calcification index is the mean arc of calcium multiplied by the length of calcific area. So superficial calcific is the male culprit. It is 67.4%. Second is eruptive calcified nodules. That is 25.5%. And you can see that in the respective image of A and B. So they used to be more prevalent in RCA, and they leads to more non-expansion of stent or non-crossing of stent most of the time. And third is the calcified protrusion. That is representative picture is in E and F in the OCT picture. And they leads to again same type of they mostly does not cause that much of problem in passing the balloons and stuff, but non-expansion of stent and all this. So we have to know in sometimes that there may be these stumbling blocks lying in a case, especially because primary we don't think so much because we just rush the patient to cath lab and start it and guide. But things may take a negative. So what are my take-home messages is that heavy calcium can change the course of primary angioplasty occasionally. Remember, it is occasionally because doing around 3,700 angioplasty pre-COVID 5 years, we encountered around 5-6 cases where we required to do all this stuff. Imaging early in the course may help deciding the strategy for respiration, because once you proceed further, because in my last case, there was so much of dissection that it was difficult decision to do rota, but somehow I came out unscathed. Islet of soft plaques in calcified lesions may be the cause of a STEMI, because STEMI is caused to be rupture of a soft plaque. But in these heavy calcific lesions, they should be causing chronic stable angina, but even then they present. So there may be some plaque with ruptures. There may be a real difficult to dilate lesions which needs aggressive debulking. Complications of rota during ACS setting may be high and may lead to more no flow and slow flow situations. So we have to be ready for that and need extra precautions. Thank you.
Thank you, Dr. Nath. Any comment or question from any chairpersons, please? I'll just ask you one thing.
Sure.
The previous speaker said that he had to put in a bigger size tent because it was not available. That means he works in a government center where the supply is not as proficient and as profuse as is expected. But you are in another government sector where you had rota and other things on board to deal with such cases.
Yes,
if
sir.
rota was not there, what would have been your protocol in this particular case?
So I have got high pressure NC balloons, OPN balloon in my the table, and we have got cutting balloon or Scoreflex balloon. So these are the balloons that I have, but I don't have the access to IVL. So somebody may say in the last case would have been a case for IVL because balloon was passing, but it was not going. So maybe a case for IVL, though dissection it can be done. But rather two cases, I don't see anything because I have not the access to other debulking advice like orbital atherectomy. I have got the rotational atherectomy. So I see the first two cases to be only a case of rota. And last case maybe an IVL. People who are doing those routinely, I don't have the access to IVL.
Sir, did you use lower rota ablation speeds for these STEMI cases?
Yeah, I mean all these cases routinely I start around 170,000, but in HCS cases we start with 150. If one fast bar doesn't go, then my technician goes up 10,000 every cycle that I say go up. So it's really 160, 170. But in the second case, we have to go up to 2 lakh revolution. So then only it goes. So sometimes we start low, but we go up.
Okay, sir.
Thank you very much. Any comments or questions from the chairpersons? If there are none, then we move to the next case by Dr. Nitin Modi, STEMI and severe MR. Dr. Modi, please.
Good evening, friends and senior. My screen is visible, sir?
Yeah, your screen is visible.
Yeah. So my case is quite a simple case. And my case was a 60-year-old gentleman, non-diabetic, non-hypertensive, non-smoker. And he had a recurrent chest pain for 3 days. And when he presented to emergency, he had an inflow posterior MI. And on admission, because the pain duration was around 3 days, he started on antiplatelets, IV, heparin, and NTG. And the pain subsided within next 1 or 1.5 hours. I will show you the first ECG. This is the first ECG that was early in the morning, 6 a.m. And this was showing a slight ST elevation in 2-3 AVF. And post V1, V2, V3 suggestive of a posterior myocardial infarction. So he was relatively planned for angiography. But around roughly 3 hours after his hospitalization, he had a severe chest pain. He had some vomiting, breathlessness, and he had perspiration. And his BP fell down, started on inotropes, he had a hypoxemia, started a non-invasive ventilatory support. And this time, the ECG was showing slightly more elevation in 2-3 and AVF. And the changes in V1, V2, V3 were also aggravated. So we did an echo this time. And the echo showed acute myocardial regurgitation. And that may be the reason for his deterioration. The continuous Doppler showing again a severe mitral regurgitation. He had a elevated PA pressures. This is around 50-55. And on short axis view, we can see the inferior and posterior segment was almost dyskinetic. This was the first echo report which was done at our center, moderate to severe MR with the PA pressure around 52. So in this situation, we thought it is a 3 days pain, maybe a recurrent or stuttering MI. So we decided for taking the patient for angiography. We explained the risk and we did the angiography. So on the angiography, the circumflex was 100% blocked. And there was 100% block mid-LAD also. This is allocrinal view, mid-LAD 100% block, circumflex 100% block, and patient was having impending pulmonary edema, severe mitral irritation. And with this angiogram and with this right coronary artery having a mid around 60-70% lesion, so we decided to open the circumflex artery, and this was the end result. We did the plasty of the circumflex, and this was the end result. And the patient recovered very fast within, this is a post-plasty ECG. The infiltrate changes has slightly settled down, but the posterior lead changes, the reciprocal changes in precaudal leads are almost the same. And this was the echo because the patient settled down very fast. The mitral irritation, which was around moderate to severe, has subsided. This is a CW image. And this is a short axis image. For years, we are seeing that ischemic myocardial regurgitation, that may be because of papillary muscular dysfunction and all. We have seen so many patients, but usually presenting as a severe mitral irritation and subsided within an hour after the angioplasty. This was a case which I could find in my career. So this was an echo which was done after 1 hour after the post-plasty. And the echo, the mitral irritation has subsided completely. And this was the post-BTC ECG on the second day of the patient. The infiltrate changes are the same, but precaudal lead changes have subsided. When I searched through the literature, so I could found one article similar to that, which was in circulation 2016. That is, article was heading the course of ischemic mitral regurgitation in acute myocardial infarction after primary PCI. So the mild, moderate, severe having a very short-term high mortality as well as a long-term high mortality. And the vessel, which in that study, they were around 550 patients. Out of that, around 200 were having ischemic mitral regurgitation, primary PCI patients. And roughly 50% of the patient who they had a LAD lesion was there in acute mitral regurgitation, and circumflex lesion was in around 17% of the patients. And multivessel disease was around in this 50% of the patients. So in that study, the time during the vessel involved was LAD more commonly, and the predictors of recovery was onset to reperfusion, the total CPK levels, age of the patient, and the presentation, the CKMB levels. In my case, what we have learning from years, that is circumflex is having more ischemic MR, and the recovery depends how fast you take the patient for revascularization and time to reperfusion. And sometimes the debate is still there when they say double vessel disease with severe MR, CABG with MVR is better, or do a PCI or later plan for a mitral regurgitation. So that was my case, which had a almost complete recovery after the acute severe ischemic MR. Thank you.
I request Dr. Ajay Bahal to carry on the session from this point as Dr.
Right.
Shah, go ahead and immediate work.
Right. That was an excellent case, and that exemplified that the mitral regurgitation rarely regresses after PCI, especially involving the circumflex. So I think in an acute MR, probably we should go in for a primary PCI, and that is what your case reflects, unless there is a ruptured head of a chordate tendinae or a ruptured head of a papillary muscle, in which case, of course, the MR will not regress And your case clearly had a central MR, which makes it likely to regress. Any questions from the chairpersons, please? Or from the audience? Thank you very much. I think that was a wonderful case. And due to the shortage of time, we'll now go on to the next case. And that is ST elevation MI with left main disease by Dr. Raghu. Dr. Raghu, please.
Yeah. Thank you, everyone, for giving me for this nice meeting, Dr. Nitish and Dr. Rakesh, for giving me this opportunity. This afternoon, I am presenting a couple of cases of left main angioplasty in acute myocardial infarction. So, the first patient is a 42-year-old male. He presents to the hospital with chest discomfort and loss of consciousness. When he came, he was very breathless. He was in shock. His ECG was showing this problem. His heart rate was 137. Blood pressure was quite low, 80 millimeters systolic mercury. And then you can see an ST elevation in the 1 AVL and a QS in V1 to V6. So what we did was, we did the angiography. You can see here, with a guide catheter directly we went in because the patient was in shock. So we were suspecting a pre-procedure left main. So we can see that when we cannulated and just with a puff of contrast, the left main is completely occluded. So both the LAD and the left circumflex were completely occluded. So we attempted to pass the wire into the LAD with gradual negotiation. We could enter the wire into the LAD. Then this is the wire into the LAD in the cranial projection. And then we can see the circumflex is gradually filling, but there is no flow in the LAD. We had the option of doing a thromboaspiration, but the patient was pretty sick. We had to shift and put an intra-aortic balloon pump around this time. And then we had to use the other drawing for the IABP patient was quite sick. So we just wanted to take a small balloon and then inflated a 2 millimeter balloon, 220 balloons. And then there was some flow in the LAD. The circumflex was flowing with the TIMI-1 flow. It was like a very sick patient, very low blood pressure and tachycardia of around 130, 120 like that. So we had to quickly go ahead and then fix the lesion in the left main to the LAD. So this was the stent 3.5 into 24 millimeter stent into the LAD, left main into the LAD crossover technique. And then we can see that the flow in the LAD is around TIMI-2. The flow in the circumflex is also in the TIMI-2 flow. So the right coronary, after we finished the left-sided work, we saw that the right is completely normal. Possibly because the right is normal, he was able to tolerate, he could reach the hospital. And this is the angiography after procedure the next day, early hours. What I wanted to say is the post-procedure course of this patient. The patient did not have a favorable outcome. The next day, he succumbed to the illness, or the next day evening. Now, I present to you another case with a 31-year-old male who is a tobacco chewer, chest pain of around 5 days duration. ECG was showing an extensive anterior myocardial infarction with QRPB. This gentleman also presented with persistent angina, hypotension, and breathlessness. This is the electrocardiogram. Once again, like the previous ECG, heart rates were very fast. There's a QRBB with a left posterior hemiblock and very fast rates indicating that this patient is a poor outcome patient. So this patient, because he presented about 5 days, the previous patient presented quite early after the myocardial infarction, but this patient presented after 5 days. So we just started with the right, saw that the right is normal. Then we can see the left system angio. You can see that the left is completely occluded, left main thrombosis and extending into the LAD and circumflex. So, and then what we did was we just passed a wire. This was going into the diagonal. Then we negotiated into the LAD. And when we did the angiogram now, we can see that there's a big circumflex. There's a big circumflex, there's a big ramus, there's a LAD. The wire was going into the diagonal and LAD mid-segment thrombosis is there. Once again, this patient, we did a run of thromboaspiration run, but it was almost 4 days after the MI, so we felt the futility of doing a treatment at that time. So we had to do once again a crossover. We had put one wire into the circumflex, one into the ramus, and one into the LAD into the diagonal. And this was what was the flow. What was happening is there was some thrombus migration into the circumflex, and the research flow is reduced. Now this is the final control angio. We had to do post-procedure lot of thromboaspiration run. You can see this patient also, we had to put him on an intra-aortic balloon pump, and then we had done multiple rounds of thromboaspiration and the various pharmacological measures like adenosine, nicorandil, and sodium nitroprusside. So with this, then this is the post-ECG. What happened was this gentleman on the he could get discharged after the about day 4 or day 7 after the angioplasty. We could remove the IABP and patient, we could discharge him. But after discharge about 7 to 10 days later, he comes again with the acute vascular thrombosis. Is presented with the Lerish syndrome, and a surgical embolectomy was performed, and post-operatively patient developed an acute kidney injury, and finally he succumbed after about 3-4 days after the vascular surgical procedure. So I wanted to show these two cases of left main thrombosis in an acute myocardial infarction, because this is not a common entity what we see in our practice. So I just wanted to take this opportunity to quickly to look at what is the mortality rate, to make the audience understand the mortality in a registry between 2000. It's a 4-center retrospective registry from where some Asian, Korea, Singapore, and USA had about 50% mortality, heart failure of about 60%, and the length of the stay was about 12 days. So you can see our patient also, the second patient stayed for a long time. People who were elderly, people who had diabetes, and most importantly, people who had a low TIMI, less than 3 TIMI flow, had a worst outcome. Now, even in these patients also, the thromboaspiration was not frequently done. You can see about 30 to 40% of the patients undergone thromboaspiration. A data from about in China of about 250 cases once again showed that TIMI flow is the important criterion. Both our patients, we could not achieve a TIMI3 flow, and patients who do not achieve a TIMI3 flow, they are going to pass away. So that's the problem. So previous MI, left main bifurcation, TIMI3 flow is not achieved, and IABP support, these are the poor predictors in this data. And one more Spanish data of about 450,000, they did a retrospective analysis of this, about 3,000 left mains they did, very large data. Once again, in this group also, the mortality was around 70% and mortality of around 75%. So I just wanted to share this data and put these cases to discussion, where the left main and what are the various scenarios, how we will be able to manage them. Thank you, chairpersons, for this opportunity.
Thank you. That's two excellent cases. And in fact, both your cases had almost occluded left main. So it's much more extreme cases. Any questions from the chairpersons or the audience? Thank you very much for those two cases. And since we are running behind time, we'll go on to the next case. And that is by Dr. Mridul Sharma, who will be presenting ST elevation MI with no flow.
I hope my slides are visible and my
yes, absolutely. The slides and your voice both are clear. Absolutely. Thank you.
Okay, I've been assigned to talk about slow flow and no flow during primary angioplasty. Since it's a case-based discussion, I will just focus on the practical application with discussion of few newer innovative techniques. First, we need to know what not to do. What not to do, we start with this case example. This was a 62-year-old female, relatively sick. She presented with the failed thrombolysis. She had suffered inferior and RVMI. The waiting period was around 20 hours. She had 3 episodes of ventricular tachycardia in the emergency room requiring cardioversion. She was bit hypotensive. The LVEF was preserved, and the RV was hypokinetic. As you can see, the RCA has a longish ulcerated lesion in the mid part. What the operator does is as follows. Let me show the left system first. Left was almost normal. The operator did one thing right and one thing wrong. He started with the direct stent, but as you can see, he has taken a shorter stent. He's starting from the middle of the lesion. It's an ulcerated lesion, and he's taken a distal stent first. It should have been the proximal stent first, a long stent, whatever the longest stent is available in the lab, use that. Ends up with a slow flow. Then he decides to put in a second stent. The second stent also didn't give good result. There was further no flow in the right coronary artery. The lady had few more episodes of ventricular in the catheter lab, requiring cardioversion. She went into hypotension. IABP was inserted, and then the usual story, the gradual onset of shock, ventricular tachycardia, beep sips, and she's come in next 24 hours. What is the better way to manage such cases? Sharing is an example of almost a similar case presented one day after failed thrombolysis to us. A huge dominant RCA showing a thrombotic occlusion in the mid part. I follow two rules for prevention of slow or no flow. The first rule is always avoid pre-dilatation wherever possible, or do just minimal dilatation. You can do daughtering with the 1.5 millimeter balloon if no flow is seen post-wiring. The second rule is choose a longish stent when the distal landing zone is clear. What was done here was that after the passage of wire and daughtering with the 1.5 balloon, the distal landing zone became clear. The flow in the distal vessel, as you can appreciate here, is brisk. So I had the distal landing zone. I had an approximate size of the stent that was needed and chose a very long 48 mm stent. I try to cover 5 millimeter proximally and 5 millimeter distal to the lesion, provided the landing zones permit. This was the result after implantation of 4.5 48 mm stent. It was dilated further by 5 millimeter. No suction was needed. No GPI were needed. Minimal intracoronary dilators were needed. There was no hemodynamic compromise in this patient. The procedure was over in next 5 minutes, and the patient could be discharged happily in next 24 hours. There was no slow flow in this case. Coming to another subset of patient. How to manage when the distal landing zone is not clear. There is size mismatch between the proximal part and the distal part, and there is persistent slow or no flow even after daughtering. This is without using any fancy products. I call them POPs, products of pride, like microcatheter, double lumen catheter, thrombustor, etc. This is a young male smoker, was having recurrent chest pain for a week's time, presented to us with acute inferior wall MI, ongoing chest pain. ECG showed minimal ST elevation in the infralateral leads. A large dominant circumflex showed proximal occlusion. The wiring was really difficult. Never choose a hydrophilic wire with like a filter or a whisper in the setting of acute coronary syndrome, so since you don't get the feeling where this wire is going. Even by choosing a cyan blue wire, I had this. the wiring was difficult. It was going into the false lumen. Took a second wire. It was still not negotiating. A little more effort led to this. Whether this is a thrombus or a wire-induced dissection, the things were getting complicated. The patient was having chest pain. With difficulty, however, the cannulation was possible. The true lumen was found and confirmed without using any hydrophilic wire. The third wire was again another cyan blue wire. As you can see here, some distal flow is visible in LPDA. The wire position in true lumen was confirmed by placing the wire from a distal OM into the LPDA. Now, small LPDA, very sluggish flow is visible. What is important is this step. This is an innovative technique. I use it very, very frequently. Wherever there is no flow or no visualization of the distal vessel, I use a split balloon. It's not a fancy product. Take any 2 millimeter new or ETO balloon, inflate it, split it with the knife. Then use a diluted dye with a 2 ml syringe. Do not inject with the 5 or 10 ml syringe, since it can cause barotrauma. It can cause air embolism. This is the injection with the split balloon. And as you can appreciate here, this is an injection without any pre-dilatation of the proximal lesion. It solved following purposes. It revealed the mechanism of slow flow in this case. It's simple to understand this. If injection through the slow, split balloon or any fancy products like microcatheter or thromboster, if you see brisk flow, that means the problem lies proximally, the distal vessel is clear, then you just stand proximally and come out. If the distal flow is slow, then it means the distal vasculature is all choked up, it's in spasm, you need to treat it. Another advantage of injection through the split balloon is it identifies the distal vessel diameter. It identifies the landing zone. You can give plenty of drugs through the split balloon. It helps in sizing the stent. And at the same time, this split balloon does low pressure dilatation of the lesion with potential disadvantages if you do not take care. The first disadvantage is barotrauma if you are injecting too fast, and second is air embolism if you are not taking proper care. This was the NGO after doing local drug delivery through the split balloon. I have not done any dilatation till now. See, the distal flow has improved. On bigger OM has appeared now, which was not visible earlier. Changed the wire to the bigger OM, gave more vasodilators, and behold, the dosage of vasodilator that was used in this case was total of cumulative dosage of 25 milligram diltiazem intracoronary, hundreds of micrograms of nitroglycerin, cumulative 6 milligram of nicodendil, hundreds of micrograms of ADR. I do not prepare them. My staff is taught. I just have to say 501 de de, 502 de de, 503 de de. We are familiar with the 502. So 5 is common. 5 is diltiazem, 100 is anti-G, 1 is variable, that is the diluted adrenaline depending on the hemodynamics. Sometimes I use up to 500 microgram of adrenaline. Following 502, 503, 504 injection, the distal landing zone became clear. I knew that I have to stop before the trifurcation placed a stent just proximal to the trifurcation, and this is the result after stenting. Nothing has been done to the spasm in the OM. It opened up. Otherwise, I would have thought, had I not done the distal management first, I would have thought that this is a true lesion, this is a thrombus, do the thrombosuction, dilate the distal vessels, and this is the final image after further proximal dilatation of the stent. TIMI 3 flow, no GPI, no latex, no suction was used, and no dilatation was done beyond the point of trifurcation. In any coronary ACS situation, first is chemical management by intracoronary dilators. And if you are using them judicially, you don't need these fancy products like latex or GPI inhibitors. It's been almost 15 years since I've used RioPro. Usage of tyrofibon, integralin has been minimal, maybe once or twice in a year. Mechanical obstruction, stented, suction, hardly you need to do any thromboaspiration. And finally, a thing of beauty is joyful.
Thank you, Dr. Mridul. That was excellent presentations. Any questions from the audience, please? I think we are running behind time. We are already 15 minutes behind time. I thank all the speakers for their wonderful cases and the audience for patient hearing. Thank you so much. Now we go on to the next session.
We move to the next session. It is titled STEMI Primary PCI. We have the interesting cases. The chairpersons for the session are Dr. Aditya Batra, Dr. Ajay Mahajan, Dr. B.B. Bharti, Dr. Deepak Gupta, Dr. P. Mohanan, Dr. Parinish Arora, and Dr. Satyavir Yadav. May I now request Professor P. Mohanan to conduct the session.
Thank you. After the sweating and the swearing, it is time for the presentation. Dr. Dilip Kumar, please.
So, thank you so much, sir, and thanks for the opportunity. I will be showing a case of STEMI with cardiogenic shock. So this case was special in one or two reasons, as this was a patient which we treated in the initial days of first wave of COVID pandemic. So he presented to us in May 2020, where things were not clear. Hospitals were not admitting even my patients that time. Nothing was clear at that time. So let me show the case. This was a 46-year-old gentleman who is diabetic, chest pain for 12 hours. In fact, he went to a nearby hospital after 3-4 hours of chest pain. He was kept there in ER for 1-2 hours, and then he was refused admission. And then he came to our hospital. He lost 12 hours. In the meantime, his BP was 98/60 when he came to us. Heart rate was 110 per minute. Saturation was 91 on 10 liters of oxygen. Although the patient was apparently telling that he is fine, but his oxygen requirement was quite high. And he was also having chest discomfort. So we did a quick ABG at that time, which showed a PO2 of 92 and ABG pH of 7.34, lactate of 1.1. This was the ECG of the patient. So RBB with ST elevation, anterolateral leads with ST depression, mirror changes in infrared leads. This was the echo, which shows septum was thickness was more or less there, but the entire septum was entirely akinetic. This was right coronary artery, didn't show any significant disease. The mild to moderate plaque was there. And this was the LED, which shows proximal thrombotic occlusion. So it was not a very tough angioplasty. This was a straight wiring was easy, and then we can see two large diagonal, almost like a dual LED. And we did a thrombosuction and a small balloon pre-dilatation. And since the patient was getting restless at that time, you can appreciate the tachycardia. And we quickly put a stent, and the patient went into no reflow. And with all the vasodilators, cocktails, We tried to avoid ventilation at that time. He was put in BiPAP. He was maintaining a BP of around 100 with heart rate of 125, 120, We had also started noradrenaline. It was going on 4 to 5 ml per hour. So this is what best we could achieve with all the cocktails. And here we didn't post-dilate the stent. We thought let the patient was getting restless, after a severe no reflow after first stenting. Let us have the perfusion going on, and we'll see after maybe 24, 48 hours, we can have a relook. Next day morning, his BP was 110/70, heart rate was 100 per minute. His inotropes were off in the overnight, but gradually it was tapered off. It was not going in very high doses. And we thought that patient would be through. And he was comfortable talking to us and thanking us to do a primary PCI in COVID situation. And at that time, in the afternoon, we also got RT-PCR report. At that time, it used to take 24 hours. So we had taken all precautions while doing, but didn't wait for a COVID report. This a day after the patient developed severe pulmonary edema, he was ventilated, IBP was put on, and even after IBP and inotrops, his augmented BP was in 70s. And at that time, the pH was 7.21 and lactate of 4.1. So this moment, we were really feeling that we may lose this patient. There is no, headway where, what to do now. So we thought, let's check the coronaries, whatever we had opened, what has happened to that. And this was the ECG. Patient was going in, transient atrial fibrillation, but he remained most of the time in sinus rhythm. And patient, we also started amiodarone, although the BP was in 77, the systolic was 75, 80, even augmented. So we couldn't give a proper dose of amiodarone, but thankfully he was maintaining sinus with a tachycardia. We took the patient to cath lab, and we saw that the flow was satisfactory in the LED and diagonal. And at this moment, we thought, let's take time and decide what to do. And after 1 hour, his pH went down to 7.16, lactate of 7.3. And then we started thinking about initiating a dialysis, but still the BP was in 80s. Very difficult. And he was a young gentleman with intervention done at 12 hours, with coronaries open now after the stent, even after 24 hours. At this moment, we are really stuck what to do now. And we had only one option then. We put the patient on ECMO. This was the ECMO cannula, we can appreciate. And there is also an antegrade perfusion catheter cannula to perfuse the left lower limb. So we had in one or two cases earlier, in high-risk PCI, we had found that the cannula takes the entire width of the diameter of the vessel, and we need antegrade perfuser in these cases. And the gentleman was on IBP and ECMO for 9 days. And initial 2-3 days was turbulent, and somehow he didn't require hemodialysis. As we started ECMO, after 2-3 hours, he had a good urine output. And in 8 to 10 hours time, his ABG became much better. And but the weaning took long time, and 9 days. This was the echo. You can appreciate after 9 days of ECMO and IBP. Thankfully, it didn't get ballooned out. As ECMO, we can have kind of apical ballooning because of increased afterload. So it was basically IBP which saved. So IBP and ECMO, the combination worked fine in this case. This was the ECG at the 11th day. And you can appreciate the ECG changes were not there. He was fine in sinus rhythm, and we can appreciate loss of R waves at QS pattern. But ejection fraction was something like 30-35%. And the interval also started showing some movement. After 15 days of the struggle, the gentleman was out, and then we could discharge the patient. And it was a kind of at one moment we thought we are going to lose the patient with augmented BP of 75, 80, and he was on inotropes with a lactate of 7.4 and pH of 7.15. And he got reversed only by the cardiac unloading and with the kind of ECMO support with obviously IABP. So if we put ECMO in these patients without IABP, chances of apical ballooning can be there, but the result was much more than satisfactory in this patient. So historical advancements have happened in treatment of cardiogenic shock from survival of 17% to 77% now. They have come up with a NCSI, this National Cardiogenic Shock Initiative in the US, but we don't have any randomized control data to support any mechanical circulatory support devices. There are registry data which shows benefit, but there is no RCTs, and we are still left with options on an anecdotal case basis in our setup. Impella also, the industry, Abiomed is not promoting cardiogenic shock programs in India. They are more concerned with protective PCIs, as these patients usually we intervene late. So we have an option like ECMO. We have done 2-3 cases. This was a STEMI case, and we also had one non-STEMI case where we did intervention on ECMO. So this is kind of something which can be affordable to our patients. Impella being so expensive and not being promoted in India in cardiogenic shock program is still a far cry. So thank you so much for the patient.
Thank you, Dr. Dilip, for that excellent case. Dr. Ajay Mahajan, are you there?
Yes, sir. Yes, sir. Yes. Very excellent demonstration of unloading in this scenario. So very good case. Why it was happened in spite of open artery? So is there any reason for this extended cardiogenic shock in this particular patient?
Yeah, the patient developed some atrial fibrillation, and probably the AF decompensated the patient. So these patients are on very thin hemodynamics and very thin kind of control, and anything small insult can bring down the entire kind of balance in these patients. So probably that was the reason. But definitely, stunning remains there for 7 to 10 days after MI. Even if you open the artery, stunning takes time. Some of the time it recovers in 5 hours, 6 hours, but 1 week time it usually takes if there is a delayed reverse duration. This large LED, which was a dual LED, you can appreciate. Approximately it had gone, knocked off. So probably that was the reason.
Just one question: what was the anticoagulant and antiplatelet regime in this patient with the ECMO with IABP?
Yes, the patient was on aspirin and ticagrelor, and we had kept the kind of ACT monitored in between, around something like 150 to 200, and APTT of 50 to 55, 1.5 times. So this was the kind of approach we had in the CTVS, our ITU.
Dr. Dilip, before I conclude, what is your amongst the various cocktails that we use for slow flow? But do you think the best one?
Yeah, sir. I think it's a very, very tough question. Depends on basically who is using what. And there is nothing like which one is superior. But definitely some people prefer SNP, which is very effective, but we have to have a good BP before we give, SNP. Second, nicorandil works well, adenosine works well. Intracoronary adrenaline. I think this is the choice of medicine when there is low BP. So if someone has 75 BP, 80 BP, and has a massive slow flow, intracoronary through a microcatheter or even export catheter, if we give intracoronary adrenaline, it works wonderfully.
I have found intracoronary adrenaline the most helpful one among the lot. Thank you. May I have Dr. Arindam Pandey?
Yes, sir, I'm there.
Please.
So, thank you very much for giving me the opportunity to speak in this August gathering. Now, I also had myself and Dr. Dilip is from same institution, and just 2 to 3 weeks back, I also did one non-ST elevated MI under the perioperative support of ECMO. So only for 1 day of ECMO, and that was very cost effective because Impella is so costly, most of the patients they cannot afford. So we did ECMO supported high risk non-ST elevated MI. PCI, and patient had advanced interstitial lung disease and very high risk for bypass surgery, turned down. So we did it, and that was also fantastic. Patient went home within 3 days. So I rather today I'll present a very simple case. Not very complex one, but that will open up a new avenue. And actually we are doing it, but not documenting it very properly. So my case is a patient of intercoronary thrombus, which I did aspirated and used some intercoronary tenecteplase, which actually I'll show worked very nicely for my patient. So my patient was a 57-year-old gentleman, hypertensive, type 2 diabetes, hypothyroid, heavy smoker. He was sort of chain smoker, presented with acute inferior mitral infarction, severe ongoing chest pain for last 5 hours. So he was definitely within window. So echocardiography done at emergency room showed a reduced ejection fraction, 40% with akinetic RCA territory, inferior posterior LV wall. So generally, inferior MI, we do not get ejection fraction reduced to the extent of 40% only. So this was something which indicated probably we are dealing with a very big, large dominant right coronary sort of situation. As the patient was in window, so we take him directly for primary PCI, and this was the left system. We took him through right radial access. This was the left system, which was almost normal. There was not a problem with the left system. We can see the angiography was done in 2nd of January last year, 2020. So the date we can see from the bottom side. So right system, there was problem as we expected. It was a huge right coronary artery and it was totally occluded from the mid segment. So we thought, yes, he's a perfect candidate for primary PCI. So we took the wire, and after some balloon dottering, you could see this was a huge, PDA which has opened. But still, the flow was suboptimal, and the PLP part was not at all visible. A huge thrombus burden we could see over there. So at this point, though using an aspiration catheter, the guideline recommendation wise, the intensity has come down. The recommendation wise, there is no class 1 indication for using it, but in our practice, we do use aspiration catheter, in particular this kind of situation, ectatic coronary, huge thrombus burden. So initially a 6 French eliminate catheter was used, but after using the flow actually did not improve much. We could see hardly any good flow distally, and the PAP is not at all visible. We thought, let us upgrade it. So we did a 7 French aspiration catheter, and even after 7 French aspiration catheter, we could see the flow was not good, though it has improved to some extent. But then we thought, let us do something else, as the patient was already loaded and no heparin, only unfractionated heparin, low molecular not given. So at this point, we thought we should do something else. We did intercoronary thrombolysis. So this is tenecteplase 30 unit given intercoronary, and after giving it, after 5-10 minutes, we could see the angiogram was taken. Now at least we can see the PLV, which was a huge artery, and we can also appreciate the amount of thrombus, which actually has clogged the whole artery, and the territory we can see, the huge territory which is being covered by the right coronary artery. So at this point, we thought doing further intervention in this kind of situation is not good. So we took him next day. So next day, what happened? Next day morning, there was no ongoing chest pain. And very interestingly, ECG showed complete resolution of ST segment, and there was no bleeding manifestation as well. Patient was taken through radial angiography, and the next day angiogram showed this kind of picture. We can see there is some 30-40% plaque, probably with some thrombus as well, but the whole artery is very nicely visible. So we discharged the patient. At this point, we did not stent it. So aspirin, ticagrelor, rosuvastatin, nicorandil, and trimetazidine was prescribed. We thought of giving anticoagulation as well, but as there was very nice improvement, we continued with only ticagrelor and a strong recommendation to stop smoking. And actually we planned for check angiography after 1 month. So he was called again and taken for a daycare angiography to see what exactly is happening. And we can see 29th of January, the check angiogram left system is as it is, and the right system we can see very nice flow. The whole artery is visible. Yes, it is not, may not be a TME3 flow. There is some slow flow, but nice flow, and patient was doing fantastic, no symptom, and he was doing good. So patient now is in up to 1 year of follow-up, is completely asymptomatic. He has stopped smoking altogether. All parameters, including HbA1c, LDL, is fine. Recovered LV function, that is the best part of it. Initially, ejection fraction was 40%, but the ejection fraction now has completely recovered. So that was my case. I'd stop here. Thank you very much.
Very excellent case of thrombus aspiration and intracoronary thrombolysis. So how we are proceeded with the 30 milligram tenecteplase? How you measured this dose?
Actually, his body weight was 60 kilos, so I given complete dose. There are some recommendation in the literature. They are saying that you can give it half dose intracoronary tenecteplase. But we thought the patient has huge thrombus burden, and if actually we are giving it through intravenous route or intercoronary route, the doses we felt should be similar. So we given full dose. So that was the calculated weight-based, tenecteplase dose, and we given the full dose, and that worked. There was no bleeding.
Over how much time you had infused that much tenecteplase inside the
over around 5 to 10 minutes. 5 to 10 minutes. Very slowly, gently, we pushed it inside the coronary.
With a micro catheter or with a thrombistor?
No. We through the guide catheter only. We diluted the tenecteplase nicely over a 20 ml syringe, and gradually we given it directly intracoronary through the guiding catheter.
Thank you. Now there is another case, STEMI.
Sir, can I put in a word, sir?
Yes, sir. Yes.
Yeah. So this is a classical case where you tried for interval stenting. This was a very good example that if you would have found the artery to be closed, you would have gone for interval stenting. But one more thing which you can do in such a gigantic artery is a guide thrombosuction per se. So instead of a 4F, 6F guide, if you take a 5F guide and intubate it deep enough to reach the thrombus, and then directly connect remove your TUHI, and you can directly connect your thrombosuction what do you call that, syringe to the guide and thrombosuck, you can get a large part of it. Only thing is that the dose which you have decided is not mentioned anywhere. What is the dose of tenecteplase which is to be used? Most of the people are just using half the dose. It's not as yet mentioned, but using a 5F guide and doing a guide thrombosuction can also do wonders in this patient. But yes, importantly,
that is a very good suggestion.
Yeah. Most importantly, 5F guide, and because you must make sure that you don't injure the endothelium if you're trying to take the guide over. So take a balloon, take the guide over the balloon till the mid part and remove it, because ballooning will just increase the slow flow phenomenon. So you have to stay away from the thrombus if you have to introduce the guide.
Yes, so that is a fantastic suggestion. Actually, we upgraded our eliminate catheter. Initially, we took a 6 French, then we took a 7 French, but that didn't help. So that was a good suggestion. But we thought the thrombus burden was so huge, and whole PLV was filled with thrombus. So we thought, let's try.
Now we'll move to next case by Dr. Amit Malviya.
Very good evening, and I thank CSI STEMI Council to have been given me an opportunity to present my case. So I'll be presenting a case of very late stent thrombosis. This is a very interesting and a very rare case. Although this primary PCI does not involve any of the heroics of doing a PCI, but the learning from this case was great, and which has changed my practice at least, and I hope it incites a discussion so as to what should be the practice of treating a very late stent thrombosis cases. So we had this 50-year-old gentleman, normotensive, non-diabetic. He had underwent a PTCA to RCA 6 years back with a DES and was doing well. He presented to our emergency with acute onset chest pain for a duration of 1 hour. His ECG revealed ST elevation in the inferior leads, and my colleague there, he decided to, because the patient has presented very early, he decided to thrombolize the patient with available TLT, that is streptokinase. The patient was shifted to ICCU, he was thrombolized, and after thrombolysis, the ECG changes, they settled down. And the pain also subsided, the patient was doing well. But after 2 hours of thrombolysis, there was a sudden reappearance of ST elevation in the same leads, and the patient went into cardiogenic shock. This was the ECG. There was a huge ST elevation with cardiogenic shock. So at that point of time, I was called. So we immediately shifted the patient to cath lab and did an angio to see what's happening. So this is the left side check shot, which did not reveal anything much of significance. And this is the right side. On the right angio, we could see there was a flow in the RCA, but there was a huge thrombus load in the middle portion, along with the evidence of instant restenosis. But we did not proceed immediately for PTCA because we thought, why should he collapse after 2 hours of thrombolysis if the flow has been established? Because clearly it looks like that thrombolytics had worked and the flow was established, but why should he collapse? So we decided to do a OCT run. So this is the OCT run. As you can see from the distal part of the lesion, there is a diffuse neointimal hyperplasia, which is expected in an instant restenosis case. But as we came proximal, you can see these small flaps, which were actually a dissection flaps, and there was some lot of this red thrombus. But as we reach the middle part of stent, which we will see subsequently, I will pause there. Here you see there was an intra-coronary dissection with a large hematoma, intramural hematoma in the proximal part of stent, and the dissection had started just proximal to the stent, extending up to the middle part in the neointima which had formed. So after that, the OCT, as I said, it showed evidence of intracoronary dissection with intramural hematoma proximal to stent, extending well into the stent margin, and extensive thrombus load. We did not find any evidence of late malopposition. After that, it was a routine PTCA. We wired the lesion, we stented it. The end result was good, and TIMI3 flow was achieved. The STL resolution was there, and post-procedure OCT also showed good stent apposition with minimal residual stenosis. But the important thing which we learned from this case, and the patient was subsequently discharged on the 5th day, that what happened after thrombolytics, why the patient collapsed after 2 hours of resolution of chest pain. So most probably, as we can see from the OCT images, the thrombolytic therapy caused a dissection and intramural hematoma, leading to the worsening. Means what would have happened that the patient had a neointimal rupture. It is well known that patient who present with VLST, up to 20% of them may have a neointima rupture in the neointima. And this rupture had caused the initial MI with which he had presented. Once we thrombolized, this rupture got extended and converted into a full-fledged dissection, which extended up to the middle portion of stent and causing an intramural hematoma. And this was the cause of worsening for this patient. And post-implant residual edge dissections are a known factor for stent thrombosis, but spontaneous dissection of coronary artery leading to VLST is extremely rare. In fact, I did not find any case report of like this. We had published this case in BMJ and claiming that it was one of the first to be there, but we could not find any other case reporting VLST resulting from a thrombolytic induced spontaneous dissection of coronaries. The take-home message, which I always follow after this case, is that thrombolytics may not be the best choice in post-angioplasty patients who have stent in situ, who present with STMI even within golden hours. These patients should be ideally taken to lab directly instead of trying a thrombolytic first. And spontaneous coronary artery dissection can cause very late stent thrombosis and further complications. Thank you very much.
Very excellent case. The only thing here is that after thrombolytic therapy with the streptokinase, you moved with a femoral artery approach. So that is the only concern. Otherwise, everything is very well documented and OCT pictures are very nice. And that that intramural hematoma is the responsible for the re-elevation in this particular case. And after sealing that particular thing, we had taken care. So very excellent case.
Thank you, sir. Thank you, sir.
Hello, can I make a comment? Hello.
Yes.
Yeah. I'm Dr. Mohanty here, and I saw this a nice picture and VOCT has been done. What I think, I completely don't agree with the idea of intramural hematoma. It looks like a neoarthrosclerotic plaque. This is known in late cases of drug-eluting stent, and it's a neoarthrosclerosis with a plaque. So like neoarthrosclerosis behaves exactly like plaque, exactly like a new atherosclerotic plaque in native arteries. So that has ruptured and it has caused MI, and there is a recurrent thrombosis happening over that area. So you can see a nice cavitation, that is a thin cap which has ruptured, and this is a new atherosclerosis which has ruptured. And I won't fully buy the theory of bleeding into the neointima, and neointima and neointimal hyperplasia by and large are stable. Neoatherosclerosis are unstable and they can cause a plaque rupture, and yeah, in a plaque rupture it can bleed inside, it can cause anything. But the ST elevation, you need to have a complete occlusion of the artery. So there is recurrent thrombosis which is happening. It has partially opened up the artery, and there is a nidus for this thing. There is a large neoatherosclerosis which has ruptured. That's why the patient is getting into trouble. Once you fixed it up, things have become better.
Oh, Dr. Mohanty, I think how do you explain the patient getting destabilized after 2 hours? And then second thing is, this is an intramural hematoma because this case has been published in BMJ and it has been vetted by the reviewers also. So there is no doubt that there's a big intramural hematoma. They will not publish the images without reviewing it. So that is that there is an intramural hematoma. There is no doubt about it. The only thing is how it was caused. This is what we propose it to be, because the patient improved, then after 2 hours destabilized. There should be no reason for the patient to destabilize after 2 hours.
I think both the arguments could be right. Amit, I think, Amit, your argument that is an intramural hematoma, we definitely buy that. And I think let us take the go to the next case from Arun Mohanty.
Yeah.
Yes, sir.
You see my slides.
Next case is from Dr. Mohanty.
Yeah. Can you see my slides, sir?
Yes.
Yeah. Yeah. So good evening. Thank you, CSI, for giving me an opportunity. I'll just go not into very exotic cases. I'll see how imaging, intracoronary imaging, not IVUS only, OCT also helped me in STEMI cases. This is a male with 51-year male with ST elevation, interval MI, CHB, immediately routine thrombosuction. Then there was some flow in the RCA flow established. Then a routine stent 3.533 without any image guidance was put, giant stent, and deployed at 16 atmosphere, a reasonably good TIMI flow and practically, and the stent boost looks wonderful. After 2 hours of the PCI, the patient gets again chest pain, horrible ST elevation with hypotension, and again CHB. He was taken up to the lab. One can see there is a total occlusion of RCA stent, and IVUS was done. Look at the IVUS images. You can see there is a gross maladipose stent. You see in stent boost, it's such a nicely expanded stent, but it's grossly under expanded. Maladipose, look at the vessel size, it is around almost 5 and its stent is 3.5. You have deployed a 3.5 stent. So once this is a such under deployed stent, you can get into the trouble. So it was corrected, the patient remained all right. So this is another case of RCS occlusion, heavy thrombus load. It was wired with difficulty. Now this is the vessel. What stent size you choose in these cases? So we took a 3.5, 33, 38 synergy first. Then this was the flow. The middle, we put another 3.5 and followed by that at 3.5 proximally. And the flow is good. But look at this stent. The stents in an acute MI setup is always underestimated unless until they are imaged by some technique. So one can see there is a gross underexpanded stent. Look at the area. If you say the minimal stent area is 12.3, and for a left man also 12.3 is a good area. But look at the vessel size. Vessel size is 31 millimeter. So what is the best cutoff? There is no such, what is the optimal stent expansion in acute MI? So this is a paper not in acute MI, none other than Garmenge and Akiko, this is a beautiful article. If you have the ratio of minimal stent area versus vessel area, this is the strongest predictor of late outcome. It should be more than 38.9. That should be more than 39. MSA versus vessel area. So what we did, we post-dilated the stent. Here you have to be very careful. Now you know the size. You can take a 4 millimeter compliant balloon also and go slow, very low pressure in ST elevation MI, so that you don't produce no reflow or such kind of thing. Thrombus migration will be very minimal. You go with a balloon, compliant balloon. We dilated with the 4 balloon. Look at the area. At 12 millimeter MSA goes to 19, and the area, ratio of 42 becomes 68, and 37 becomes 63. So area of 19. So this kind of result can give you a long-term very good result. This is another patient, imaging how it helped. This is a 61-year male with recurrent stent thrombosis. He got an index procedure of LED stenting 2.5 into 38, done somewhere outside. LPDA got a 16 millimeter stent. After 4 months of the index procedure, it gets a chest pain and ST elevation in LED area territory, and it was done outside, and LED stent thrombosis was found. So a second procedure, this was some ISR or something. So second stent was done outside, 2.5 into 32, another overlapping stent. But final CAG was good. So the circumflex is flowing, LED is flowing. But look, after 5 months of the second procedure, he gets into a third time acute MI with acute anterior ST elevation MI, comes to us with Kiliff class 3, impending cardiogenic shock, hypotension. No wonder the ST is elevated in all leads. And look at the angio, it's just like a left vein equivalent. All circumflex is occluded, LED is occluded. So immediately we took him on table, established flow by balloon dilatation, thrombosuction, stabilize the patient. Then we did stent boost, suggest something here. We did an IVUS. Look at the IVUS. I'm showing a very short film of IVUS. You can realize the stent is on one side, totally deformed, crumpled stent. You can see the stent here. There is no stent here in LED. Circumflex is the same. There is a free floating stent inside. You can see a deformed, well-deformed stent here, free floating stent, deformed stent. So we did IVUS guided overlapping stent. We crushed the deformed stent to one wall, put another stent, optimize the result, and similarly, the luminally floating stent was crushed with another 2.5 NC balloon, then 3O balloon. You can appreciate this crushed stent is on the wall side, one side of the wall. A second stent telescoping through that deformed stent was done in circumflex, and it was post-dilated. Final OCT, IVUS picture, one can see there is a well-expanded stent. The stent which was deformed was excluded from the vessel, and it is nicely open stent. In circumflex also, you can see the same stent. It's nicely seen, well open stent, and the deformed stent was pushed one corner of the artery. And finally, the patient remained all right, and he got a check angio because of his doubts. After 2 years, fine LED and fine circumflex and very good flow. And till after that also 3 years follow-up, the patient had never a problem. Now this is a lady, another MI. How imaging gives you insight. 59-year female without much risk factors, comes with ST elevation MI. After 3-4 hours, ST settles. So next day morning, we took her for angio. You see a borderline LED here. So in MI, I thought FFR will not be good. Let us do a IVUS. You can see the IVUS, there is a spontaneous coronary artery disease dissection. This is spontaneous coronary artery dissection because you can see 3 layers of it's a normal vessel, only intimal suppression, good lumen. We have done a OCT for that. You can see normal with an adequate lumen, good flow, but there is an intimal suppression. This is a normal vessel which has gone into a spontaneous coronary artery dissection. So we left her on medical follow-up. After 2 months, this is the angio. One can see beautifully flowing grown-up arteries, and the repeat OCT, a minimal IMH at the proximal and distal edge. The vessel is nicely held up. But this is another patient. This is a borrowed case from my friend. This is a LED, ST elevation MI, totally occluded LED. He has done a thrombosuction. After that, This is the IVUS picture. One can see again IMH here, the intima is separated. This is another SCAD, but there is a rupture here. It's a communicating SCAD with an IMH here, intramural hematoma, and there is a pulsatile hematoma. You can see the compression of the intima here. You can see the pulsatility, and this is the OCT, the similar kind of picture. But look, the lumen is almost compromised, and it's a ST elevation MI. The patient is having ongoing chest pain. This SCAD cannot be left. So it was stented, and final result was good. So we know which artery to be stented, SCAD, how to approach, and if it is a hemodynamic compromise or a lumen compromise with ST elevation, ongoing ischemia, you have to stent SCAD also. So by and large, SCAD should be left on medical follow-up. This is another 52-year female, non-diabetic, hypertensive, non-smoker, dyslipidemic, comes with ST elevation. ST settles once she reaches our hospital. So we took her for angiography again. The next day, this is a very hazy-looking mid-LAD lesion. So we did it, and one can see. Can you see this area? There is an intimal disruption with a plaque rupture. Clearly seen, this is a lipid-rich plaque. You can see black things all around. This is a thin plaque which has ruptured. This is the plaque rupture. So this needs stenting. You cannot leave it on medical follow-up. The lesion was borderline. It was stented. And this is another lady of 43-year female. This is my last case. 43-year female, non-ST-MI, interval 12 hours. Initially, there was a ST elevation for transiently for 20 seconds. After that set, and the ST got, there is a non-ST kind of changes came, and the LDL was 190 with a very high LPA. So this lady was taken off for non-diabetic, non-hypertensive. Look at the LAD, which is very, very tight. So what we did, we took her and did IVUS immediately. One can see this is all dark. This is a catheter. You can't see anything. If you see this kind of lesion without calcium or a stent looking all dark, this is attenuated plaque. Attenuated plaque means very rich in lipid, and you have to give some weightage to this. A routine angioplasty can land the patient into trouble. We knew there is a lot of attenuation all around. These are all lipid and necrotic tissue. So this is what is definition of necrotic attenuated plaque. A 60-degree lipid arc is evident. It was 360-degree in our case, more than 5 millimeter length. That is histopathological correlation. You can see necrotic core, much more common in this. In these patients, if you don't take care, if you are not aware, if you are doing very aggressive dilatation, you will not understand. The patient will have immediate no reflow and cutoff of the artery and can collapse. And the same thing happened. We were very aware. In Japanese, they routinely use filter wire for this, but filter wire, there is a cost and everything. So we just we are dilating the patient here with a small low pressure dilatation. Immediately you can see there is occlusion of the artery which die hanging. So we give sodium nitroprusside immediately. The flow could be established. Then there is a stent deployment from left main to LAD. With low pressure, we knew the size, we knew the length, we are taking all precautions. We have treated the patients with nicorandil, nitroprusside. After post-dilatation of the stent, immediately the left main flow ceased and the patient arrested. And there is cardiogenic shock, cardiac arrest, so CPR was done. Immediately we precisely knew this can happen. If you don't know, you will think there is a dissection, there may be a rupture, there may be a left main dissection. You put stent here and there, you cannot save this patient. So we were very precisely knowing this can happen. So we were very tactful. So we had patients put IBP, TPI and other thing, treated the vessel with vasodilator, the flow established. The patient was in very gross, intubated and sick. After 1 or 2 days, we extubated the patient. So my take-home message, intracoronary imaging is very, very useful in optimization of PCI results in STEMI. Imaging is extremely useful for stent sizing, particularly if you are not interested in STMI to go very high pressure for no reflow and other thing. You can avoid unnecessary high pressure dilatation and slow flow or no reflow. Identifying the mechanism of stent failure, like in our case, stent deformity producing recurrent stent thrombosis or stent fracture, or ISR in an underexpanded stent if you have to expand this stent. So mechanism of stent failure is very important, very useful to recognize attenuated plaque, particularly in our case. If you have this kind of plaque, you be careful. If you have a filter wire, you can take filter wire also. But knowing that thing is going to happen, you can anticipate things and you can treat it better. So you can treat that patient and save such patients, sick patients, to recognize and correct the pathology of ambiguous angiographic finding like SCAD in our case. So you know which CAD to be stented, which CAD can be left on medical follow-up, and plaque rupture, if you find, should be stented. So thank you very much. This is our PCI Imager WhatsApp group. You can post your beautiful cases or interesting cases or queries. Thank you very much.
Thank you, Dr. Arun. Very nice demonstration of IVUS and OCT in acute coronary syndrome. And there is a lot of learning as far as the stent migration and stent deformation is concerned. So we'll move on to other case, next case.
One comment, sir. One comment.
I have a query for Dr. Mohanty.
Yeah.
Dr. Mohanty.
Yes, sir.
When you knew that this is a lipid-laden lesion in your last case, isn't it better not to dilate, go ahead with the direct stent, or even if you are to dilate, just with the 2 millimeter balloon rather than dilating with the 3.50?
You see, anyway, you are going to take a proper size stent and it is mounted, crumpled on a balloon of that size. So once you do that, a patient can land into trouble. So routinely, Japanese, they take filter wire for this kind of patients.
Okay. Where Rajkotians do otherwise.
Monty sir, why did you choose IVUS over OCT in an acute coronary syndrome? An OCT will do a better job.
No, it's your choice.
And the second
if
thing
you,
is,
if you are well versed with your technique and devices, you can take anything. But if, of course, if I'm interested for a thrombus categorization like red thrombus, white thrombus, where I want to see macrophages, I want to see deeply into a plaque rupture, then it's a good thing. But as Giadoli also says, and other people, you can, by doing an OCT in a SCAD, you have done SCAD, OCT in SCAD, but you're doing a SCAD, OCT is dangerous. Sometimes you can cause a hydrostatic extension of the dissection.
and in this first case, you said that malposition of the stent was there. But does malposition of stent per se predispose to thrombosis?
Yeah, the short malposition doesn't cause. Like in a left main, if your stent is hanging a few millimeter, doesn't cause. If you are leaving a 5 millimeter or more stent which is hanging and malposed, is a risk factor.
Can we have Dr. Ramesh, please?
Yes, sir. So I thank the organizers for the opportunity. And my case is not very complex like Dr. Mohanty's case. It's like a straightforward primary PCA, which we routinely do in our center. So the importance of IVUS in primary PCA. So our patient was a 53-year-old gentleman admitted with chest pain for 3 hours. ECG was suggestive of anteroseptal MI. So patient was loaded with tachycardial aspirin and counsel for primary PCA. Our patient was willing for primary PCA. So we took up, and this is the right side. You can see a borderline lesion in right side with the codominant system, and left angio circ was normal, and LAD was, there was a tight lesion. And moment we crossed the wire, the flow reduced. So we pre-dilated the lesion and drug-eluting stent was put, and you can see here that the distal edge almost slightly landed on a plaque. So after stent dilatation, stent was deployed. Then there was a distal edge of the stent. There was appears to be a spasm. So we gave a vasodilator, dilsum we given as, and we also gave nitrates. And still we are able to see some haziness. So we took multiple images. Here also there was a little hazy with not a great TIMI flow, which we expect with a less thrombus burden. So even though the result was okay, so then we decided to go ahead with the IVUS to see what's happening distal to the lesion. So here you can see a flap was seen at 6 to 7 o'clock position. There was a flap and the stent was well expanded, and there was no molar position. So then we decided to place a second stent, and a short disc was put distal to the first stent. So this was a post-stent image. Now the image coronary angiogram looks better, and TIMI3 flow was there. And then we did a post-run. So the second stent also was well opposed, and the overlapping area was post-dilated. So our my aim of presenting this case is mainly the importance of fiber. So in our case, there was a haziness. We initially thought it was maybe a spasm secondary to the stent deployment, but still hazy. So then we decided to take the help of IVUS that showed a dissection. So left alone, if the dissection was not attended, the patient may have presented with reinfarction in the ICU. So this shows my case mainly is shown to tell the importance of IVUS even in primary PCI, like our previous presenter where Dr. Mohanty showed multiple uses of imaging in patients presenting with acute coronary syndrome. Thank you.
Very nice demonstration of IVUS in acute coronary syndrome scenario. Now we'll move on to the next case if there are no questions.
Thank you.
Yes, sir. Good evening, sir. Thank you. I thank the CSI Organizing Committee, STEMI Committee for giving me an opportunity. I'll start with my case. So this is a 78 years old gentleman who had developed angina dyspnea a few hours duration. He was seen by his neighbor, who was our own cardiac surgeon, and recognized that he was in shock, and he was shifted as fast as possible in his own vehicle. Meanwhile, on the way, patient had almost arrested, so he had shifted to a nearby hospital, started inotropes, and shifted him in a ventilatory ambulance. He was seen in our emergency department in bending shock. He had a VTVF. He was shocked and reverted, intubated and on ventilatory support, high dose of inotropes, and he was shifted to the CC. The interesting part is he had underwent a bypass surgery 30 years back at United States. The details of graft was neither available nor the relatives knew of any details of the reports or discharge summary. So the cardiac surgeon himself inserted an bedside IABP, considering he was on, even though he was on inotropic support, he was worsening, his shock was worsening. And he was handed over for further evaluation to our site. ECG at his presentation was showing a significant ST depression in the anterior leads. There was tall T waves in the anterior leads as such. This was ECG taken outside, and this was our ECG. On the posterior side, you can see the posterior leads also showing some ST coving in V4 to V6. And this was his echo showing wall motion abnormality in the inferior posterior lateral territory. So what could be the strategy? This was a hospital arrest, intubated without delay, but we don't know the neurological status, but most probably it will be intact. Details of graft 30 years back, done outside, that too in US. No idea what the grafts are. He is in IBP support, inotropic support. And this is last year, COVID times, RT-PCR also is not available. So all this scenario was there. His neighbor, a good friend, CTS surgeon, frowns at us because he did all his effort and that looks like going in vain. So waited, but definitely we were planning to go aggressively, and his COVID report was negative in a few hours time. So we thought we'll go ahead and see the angiogram. So the left main was occluded, calcified vessels, right coronary also was occluded. Now what matters is what the graphs are. His RCA graph seems to be occluded long time back seems to be, but it's got an SVG graph which is attached to the OMs, seems to have some thrombus in that. Yeah, you can see some thrombus filling in the proximal. The distal flow seems to be fine. There you can definitely see a large area of thrombus involved. That seems to be the culprit for this posterior lateral MI. His lemma was fortunately flowing, but in lateral view, you could see some discrete lesion in the distal anastomotic site, but that's not the culprit, and he's in impending shock and needs to be tackled the lateral surface. So this is the thrombotic SVG graph, which may have occluded or was in impending occlusion. So what are the options? The culprit was identified, patient on balloon support, high dose of inotropes, ventilatory support, risk explained, and the worst part was we didn't have any distal protection device at that time, and this was early morning in a Sunday. So with no time waste, a wire was passed, predilatation was done, and a fast direct stenting was done with the 3.5 into 23 drug-eluting stent, which was deployed, keeping in mind that most probably there could be a thrombus migration. The proximal part needed a post-dilatation as such, and you can see that the thrombus has been distally embolized and slight distal thrombus visualizing over there, but fortunately there was not much slow flow in the native coronaries. A mid lesion also was there, which also was tackled with the 318, and this was the final result. The distal, you can see some thrombus over there, which we thought the antiplatelets would take care along with the anticoagulation, and that's a distal thrombus. He was on ventilatory support for 5 days, IVP removed, and finally stabilized and discharged. Quickly, I'll just run to another case. It's a 45 years old male with angina suggestive of a ST elevation MI, fair alveolar function, taken from a PAMI elsewhere. You can see that ST coving in V2, V3. Attempted, this was the angio over there. It got a discrete long segment disease of the circumflex and an LAD proximal tight disease. An attempted PCI was done over there in the LAD, but some reason or another they wouldn't pass the stent. The RCA seemed to be normal. So culprit was LAD. TIMI 1 to 2 flow was there. It was attempted outside. Now the patient comes with ongoing pain and can get a biphasic T waves in the anterior leads. So the flow is TIMI 2 to 3. The tight disease in the proximal and mid. Calcium also is there. Most probably the calcium would have been the culprit. So what could be the planned strategy? Tight mid LAD stenosis, slow flow, toxicity, patient has ongoing pain. Reattempt EPOBA, if attempt with what balloon size? 1.5, 1.25, 1.8. Crossing is a big question. Reocclusion, dissection risk. If at all atherectomy in this slow flow and thrombus state, will atherectomy have a contraindication? Laser, any role in this? IVL shock wave, possibility also is an issue. Leave it to the anticoagulant, nitrates, take it at a later state, but he's having ongoing pain and seems to be in going pulmonary edema. Or should we send the patient for the surgical side? We thought we'll attempt with the balloon dilatation. Pre-dilatation attempted with multiple balloons, right from 1.5, 1.25, Rai, Tasuna balloons, Ikasuki balloon, no response. And you can see the balloons hardly crossing the mid lesion. So this was tried with the 1.5 balloon. This was tried with the 1 balloon, both the Ikasuchi and Ryore balloon tried. This was a Nick Nano tried. Nick Nano just crossed, redilated, but with other balloons not crossing up. And now it's the time was, as the patient's ST had not settled and pain was worsening, we thought we'll change it to a rota burr. The 1.5 was planned because of the bend. We thought we'll try with the 1.25 first. And the 1.25 took around 2 to 3 minutes of almost 190 RP, 190,000 RPMs to finally cross the lesion. And once it crossed, it was smooth enough. So that was the crossing of the 1.25 burr. And that you can see that the open vessel, almost a 2 balloon could easily pass once it was open up. So this was followed by a 338 drug-eluting stent, and that was the final result. So primaries can be tricky. Anticipate aberrant origins in primaries, calcium, toxicity, maybe a distal CTOs, or especially in graft occlusions. Slow flow, no flow, thrombus, LV dysfunction, arrest are a part. LCA laser atherectomy can be the last resort, but use it judiciously. If symptoms settles, it's always the complex stages can be done at a later stage. Thank you.
Thank you. Very excellent demonstration. Any questions from audience? So what is your take on rota in a thrombus containing lesion, or the lesion already pre-dilated with the balloon or something like that? How you are, what was your comfort level in taking rota in this case?
No, basically it's a very relative contraindication to take a rota, sir, because if at all there's a large thrombus and slow flow, I think if a balloon is crossable and the pain is settled, I think I will leave it out for at least 4 to 5 days and take it once the slow flow is settled and thrombus is gone. As a stage rota, not in upfront procedure. But in this case, the patient was having ongoing pain, and ECG also had not settled, and at least the lumen size should have been improved so that he gets some pain relief.
Can I come in? One can use a rota after doing a balloon, but then it is very, very important that you never use a 1.25 bar. If you have ballooned an artery and then you want to use a rota in that artery, the importance is of not using a 1.25 bar, because the 1.25 bar is not oval. It's the only bar which can get stuck up, because the posterior portion is triangular. So if you have ballooned an artery and you have decided to go ahead and do a rota, the bar should never be less than 1.5. That's important. So that's why it's a relative contraindication, but 1.25 bar is almost a complete contraindication, because the shape of 1.25 is different from all the other bars. Other bunks being the oval, this bar is triangular. So it tends to get stuck up if you have a dissection, which you can have because you've ballooned an artery.
Do we have any further questions, or shall we proceed to the next session?
We can proceed, sir.
Okay, our next session is going to be extremely interesting. We have two guest faculty members. The title of the session is Intracoronary Imaging and Coronary Physiology in STEMI. Learn from the masters. The chairpersons for the session will be Dr. Diman Kahali, Dr. Himanshu Dabral, Dr. Neeraj Gupta, Dr. P.J. Bhattacharya, Dr. Satyavan Sharma, Dr. S.S. Mishra, Dr. Upendra Kaul, and Dr. Deepti Siddharthan. May I now request Dr. Deepti Siddharthan to start the session?
Good afternoon, everyone. In this session, the first talk will be on the role of functional and anatomic assessment of coronary lesions. This talk will be delivered by Dr. Ju M. Lee. Dr. Lee is an interventional cardiologist in Samsung Medical Center in Korea, and a high volume operator. He has expertise in coronary physiology, intravascular imaging, and invasive imaging, including coronary CT angiography. Dr. Lee, please.
Hello, everyone. Can you hear me?
Yes, sir. We can hear you loud and clear.
Oh, yeah. Yes, thank you. Thank you for inviting me to this very fruitful session, and I'm very honored to participate this Indian STEMI concert. Hello, everyone. I'm James Lee from Samsung Medical Center. Today, my talk is functional and anatomic assessment in the ACS patient. So these are my disclosure. And as you well very know, the domain of invasive physiological assessment is either for the epicardial coronary stenosis or microcirculation. The pressure-derived indexes such as FFR and resting indices and HSR evaluate epicardial coronary stenosis, and the combined pressure and flow-derived indexes such as IMR and HMR are used for the evaluation of microcirculation. Let's start with the invasive physiology for the culprit vessel first. This study will demonstrate the impact of acute microvascular dysfunction in STEMI patient in the culprit vessel FFR. In the comparison of FFR value in the culprit vessel between primary PCI and 6 months later, as you can see in patient with microvascular obstruction on the CMR, the FFR value was significantly decreased. However, in patients without microvascular obstruction, the culprit vessel FFR was not different. These results suggest that FFR in the culprit vessel underestimate region severity in the presence of significant microcirculatory dysfunction. Another study from US evaluated 200 non-STEMI patients. In this study, FFR was measured in the culprit vessel, and the PCI was deferred if the FFR was over 0.75, and during 3 years of follow-up, the deferred non-STEMI patient showed significantly worse clinical outcome than stable patient. So this result implied that caution is needed to defer culprit lesion based on FFR in the acute setting of non-STEMI patient. However, there were many solid evidence which support the importance of microcirculatory function in the culprit vessel territory. These many previous studies well demonstrate that IMR correlated with the infarct size, microvascular obstruction, and it is also independent predictor of death or rehospitalization in STEMI patient. In the earlier study published in 2008, elevated culprit vessel IMR was related with higher total CK level and wall motion score index at 3 months after primary PCI. Another study presented patients with MVO showed significantly higher IMR value, and IMR was an independent predictor of LV function and infarct volume at 3 months later from primary PCI. Furthermore, IMR was also significantly related with the recovery of myocardium assessed by wall motion recovery and the FDG PET. Another study also support the elevated culprit vessel IMR after primary PCI was associated with the higher infarct size, higher MVO proportion, and higher hemorrhagic myocardium, and significantly lower ejection fraction and salvage index. In addition, the Dr. Piero group presented elevated IMR over 40 units in the culprit vessel was the only independent predictor for the death after primary PCI. In summary, culprit vessel requires PCI based on the clear prognostic benefit over medical treatment. So evaluating culprit region using FFR or non-hyperemic pressure ratios is inherently limited. However, microcirculatory dysfunction in the culprit vessel territory is more important in this patient, and IMR is the independent prognostic indicator in STEMI patient after successful primary PCI. Let's move on to the invasive physiology in non-culprit vessel evaluation. About 40 to 60% MI patients have non-corporate vessel stenosis, so that the accurate physiologic evaluation of non-corporate vessel stenosis is an important issue in our practice. Nevertheless, there has been a concern for the reliability of non-corporate vessel FFR in STEMI patients. In this very small study, they compared the CFR, resting, and hyporemic coronary flow velocity among corporate vessel and non-corporate vessel and control patients with stable angina. In comparison of hyporemic coronary flow velocity, non-corporate vessel showed depressed hyporemic flow than stable patient. Based on this result, the authors claimed blunted hyporemic response in the STEMI setting may underestimate non-corporate stenosis severity by FFR. However, these two very important studies nicely presented that the actual non-corporate vessel FFR value measured between primary PCI and 1 month follow-up, there was no change at all. So these results strongly support non-corporate vessel FFR can be safely used in our clinical decision. In addition, the impact of corporate vessel microvascular dysfunction to the non-corporate vessel territory was evaluated by meticulous preclinical study. In this study, microcirculatory dysfunction was induced by repeated microsphere injection through the LAD. This means the corporate vessel. With the repeated microsphere injection, IMR was significantly increased, and along with the IMR, FFR was also significantly increased. However, more importantly, in the non-corporate vessel without microsphere injection, there was no change at all in the IMR as well as FFR. This result strongly means that microvascular dysfunction in the corporate vessel is a regional problem and did not affect non-corporate vessel territory. Furthermore, from our group, we compared changes of FFR along with the worsening diameter stenosis in the non-corporate vessel of MI patient. All the FFR was measured after primary PCI during acute stage. As you can see, there was no difference between MI and stable patient in the changes of FFR value according to the epicardial coronary stenosis. All the non-corporate vessel FFR was measured at the time of primary PCI. So these results strongly support non-corporate vessel FFR can be reliably used even in the acute stage of MI. And the two representative trials provided solid evidence of FFR-guided non-corporate vessel PCI. Daramis-3 pre-multi enrolled 600 patients and randomly allocated into the FFR-based complete revascularization versus corporate-only PCI group. And during 27 months of follow-up, FFR-based non-corporate vessel PCI group showed significantly better clinical outcome than corporate-only PCI. In this trial, non-corporate vessel FFR was measured after 2 days later from primary PCI. In compare-acute trial evaluated larger sample size, or the majority of FFR was measured at the time of primary PCI, and the FFR-guided complete revascularization group showed much better clinical outcome than corporate-only PCI group. So currently, PCI for the significant non-corporate vessel stenosis defined by angiographic stenosis severity or FFR are supported by multiple randomized trials. From these results from complete trial and compare acute and Daramis-3 pre-multi, we can use to select significant non-corporate vessel stenosis based on angiographic stenosis severity or FFR measured at the immediate phase or FFR measured at the staged phase. However, which one is better has been an unclear issue. Recent FLOW MI trial compared angio-guided non-corporate vessel PCI versus FFR-guided non-corporate vessel PCI. At 1 year, there was no significant difference in the primary endpoint, which was any death, non-fatal MI plus periprocedural MI, and urgent revascularization between FFR and angio-guided revascularization group. However, this result should be investigated with more caution. Please look more closely in this table, because only 70% of non-culprit vessel PCI was resulted in the TIMI-3 flow in the FFR group. And the FFR group had 2 times higher incidence of periprocedural MI than angio-guided group. And the risk of cardiac death was 3.5 times higher in the angio-guided PCI group. So in the NEJM, very provocative editorial was published for the FLOWER MI trial. The title was "No Role for the FFR in MI Patient." However, I don't think this editorial provided proper interpretation. Please think about the below point. Visual 50% stenosis, is it really deserve PCI? I don't think so. And only 70% of non-culprit vessel PCI in the FFR group resulted in the TIMI-3 flow. And FFR group showed 2 times higher incidence of periprocedural MI. However, PCI rate was only half in the FFR guided group. And the risk of cardiac death was much higher in the angio guided group. And another important point, and in the FLOWER MI trial, 16% of non-culprit vessel FFR were missing data. This means that there was no correct validation for the FFR value. So in this regard, we recently performed network meta-analysis from 13 trials, which compared culprit-only PCI, angio-guided CR, and FFI-guided CR. When we compare clinical outcomes among 3 strategies, both angio-guided CR and FFI-guided CR showed significantly lower risk of cardiac death than culprit-only PCI group. However, there was no difference between angio-CR versus FFR-CR group in terms of cardiac death, spontaneous MI, revascularization, and MACE. So angio-guided PCI and FFI-guided PCI had the same clinical outcome. However, FFI-guided PCI resulted in the half of the PCI procedure. So why not use FFR in clinical decision for the non-culprit vessel PCI? We are clinician, not a stenting technician. And the current guidelines strongly support the use of FFR to evaluate non-culprit vessel stenosis. Before moving to the next subject, I'd like to discuss recent paper about prognosis of deferred non-culprit vessel based on FFR. Dr. Javier Escanet evaluated patient-level pooled data from 3 registry and 2 RCT data. In their patient-level meta-analysis, among treated patients, there was no difference in the clinical outcome between ACS and stable patient. However, in the deferred patient group, ACS showed higher risk of clinical event than stable patient. Based on this result, the authors claimed that further investigation is needed to determine safety of FFR-based deferral for the non-culprit vessel in ACS patient. However, when we compare prognosis between stable and ACS patient according to the FFR ranges, as you can see, ACS patient showed higher risk of clinical event than stable patient regardless of FFR. This means that ACS patients have higher risk of clinical events than stable patients, and it is not because of FFR's reliability. It is just because ACS patients had inherent higher risk of patient characteristics. We can find the possible explanation from imaging studies. These 3 representative studies consistently showed that ACS patients have higher incidence of vulnerable plaque in non-culprit vessel, and those non-vulnerable plaque were significantly associated with a higher risk of clinical event. Considering this result, higher risk of clinical event of ACS patient is not a matter of reliability or cutoff value of FFR. It is just because inherent patient characteristics like diabetes, CKD, or peripheral vascular disease. Let's move on to the last topic about which index is better to evaluate non-culprit vessel stenosis. This study compared acute versus 1 month follow-up FFR in the non-culprit vessel and the IFR in the non-culprit vessel. In paired comparison, FFR showed difference, however, IFR no difference. However, it should be noted that the correlation coefficient between acute and follow-up phase IFR value was only 0.49, which was significantly lower than FFR in the non-culprit vessel. An STEMI trial from IFR SWEDAT group evaluated 120 STEMI patients and acute and follow-up phase IFR value in the non-culprit vessel. As you can see, follow-up IFR was much higher than acute phase IFR. And more importantly, there were significant changes in the proportion of significant IFR during acute and follow-up phase. And the classification agreement was only 78%. This result clearly showed that IFR in non-culprit vessel during acute stage significantly overestimate stenosis severity. In order to explore the serial changes of resting and hyperemic index in non-culprit vessel, our group performed preclinical experiment. So in the non-culprit vessel LAD, the serial resting and hyperemic physiologic index were measured before circumflex occlusion, during occlusion, and after reperfusion of circumflex. Compared with the baseline phase, balloon occlusion induced significant changes in flow velocity and pressure gradient and microvascular resistance. However, the hyperemic indices recovered each baseline value after successful perfusion. However, resting index cannot recover its original value. So non-culprit vessel FFR was same with the baseline value. However, IFR remained to be decreased even after the successful perfusion. So this experimental result clearly demonstrates that resting index in the non-culprit vessel during the acute phase is not reliable. So, however, hyperemic index can be safely used to determine the treatment strategy. So, ladies and gentlemen, this is my final slide. So, invasive physiology in acute coronary syndrome, can we believe it? Yes, it is reliable. However, additional consideration is needed about clinical presentation, target vessel, type of index, and timing of measurement. Thank you very much.
Thank you, Dr. Lee, for the wonderful talk. Any comments or questions from the chairpersons or the audience?
Dr. Lee, this is Dr. Upendra Kaul from Delhi. I thoroughly enjoyed your masterly lecture. I just want to find out, in your lab, do you do FFR in all the patients, FFR or IFR in all the patients, or you go for some selected patients?
Yes, Dr. Kaur, it is very nice question. And as you well know, we don't need FFR for all the patient. Let's assume that typical chest pain, proximal LAD, subtotal occlusion with the TIMI2 flow, we don't need FFR, that kind of patient. And for the patient with CTO, with significant symptom, we don't need the FFR to evaluate that CTO segment. So I think maybe about 40 to 50% of patients with the intermediate stenosis or unclear clinical explanation for the patient's symptom, those kind of patients may need invasive physiology. And for some INOCA patient, which means ischemia without non-obstructive coronary disease, we may apply CFR and IMR to evaluate those patients. So having thought that in mind, the adoption rate in Samsung Medical Center with the invasive physiology is about 40% among the PCI population. If we integrate the deferred patient, maybe that proportion will be a little bit lower. Thank you for your question.
And a supplementary on this, after revascularizing a vessel, what is the utility of FFR to see the correct deployment of the stent besides, anatomy like OCT, which we're going to hear, or IVUS or other things?
Yeah, there is another very excellent question. I totally agree with your opinion. The post-PCI physiologic assessment, such as post-PCI FFR or IFR, usually provide very useful information. Even after the successful PCI, the previous data consistently show that about 20% of patients, the post-PCI FFR is still lower than 0.80. That's because there can be multiple reasons. First, the suboptimal stenting, such as underexpansion, malposition, edge dissection, or something else. And the second major reason is residual disease. That residual disease can be focal or underlying diffuse disease, and we can discriminate that pattern of disease using the pressure wire pullback. That pattern of disease cannot be evaluated by intravascular imaging. So maybe post-PCI physiology and post-PCI imaging have the complementary role. So in my routine practice, after stenting, I usually measure FFR, then pull back and confirm that the final physiologic result of the PCI. If I don't satisfy with that result, I do the imaging to evaluate the stented segment. And if I don't see any suboptimal finding, I look the residual segment. So yeah, that's my kind of routine strategy. Thank you.
Thank you very much. Thank you, Professor Lee.
Thank you, Dr. Lee. The next talk is on the current role and relevance of OCT in acute coronary syndromes by Dr. Takashi Akasaka. Dr. Akasaka is a professor in the Department of Cardiovascular Medicine at Wakayama University in Japan. An interventional cardiologist with over 25 years of experience, he has a special interest in intravascular imaging and coronary physiology. Dr. Akasaka, please.
Thank you very much for kind introduction. It is really my great honor and pleasure to be invited in this meeting. I'm Takashi Akasaka, Wakayama, Japan. Today, my talk is entitled OCT in ACS, a current role and relevance. Right? This is my disclosure slide. This is one of the examples of an FD OCT in ACS before PCI. The OCT is pulled back from distal to proximal. Distal portion looks relatively fibrous plaque, right? And this is the MLA site, and plaque rupture is a little bit proximal. So this is a still frame, longitudinal view and short axis view here. In longitudinal view, you can identify the MLA site, and here is a short axis view. You can identify the white thrombus at the MLA site. However, the actual culprit region is a little bit proximal. Here is a plaque rupture site, very complex plaque rupture, and this may cause the thrombus formation in the MLA site. And if you identify the stenosis, you have to put a stent, right? And you decide the distal portion, reference site, and then proximal site. And if proximal site is like this, the very lipidic plaque more than 180 degrees, you try to move the cursor a little bit proximal or a little bit distal, right? And then we will find this much more stable site And then based on the measurement, we selected a 3.5 and 18 millimeter stent to put here. It's a very similar to a chronic stable condition. How to optimize, how to select the stent. Quarter size bigger if you use the lumen, and quarter size smaller if you use the vessel area. And the length should be decided by distal and proximal reference, and distal landing zone. Distal reference should be burden should be less than 50% and non-lipidic. And after putting a stent, MSS size should be 4.5 square millimeter at least by OCT, or more than 80% of reference area. If you have a malposition, it should be less than 400 micron in distance and 1 millimeter length. And the edge dissection should be less than 60 degree, and flap should be limited within intima and less than 2 millimeter length. And the problem is a protrusion. Sometimes after putting a stent in ACS, you can identify a lot of tissue protrusion with thrombs. However, compared between a plasgler and croptogler, plasgler demonstrate less protrusion mass. And I think we do not have a ticagrelor, but ticagrelor should be much better. This is a data comparison between plasgler and croptogler. And the plug volume and area and maximum area is significantly smaller in plasgler. And anyway, if you do the OCT at the culprit region in ACS, you can identify plug rupture about 60 to 70% and plug erosion near the ear 25% and calcified nodule in few percent as shown in this slide. And you can identify thrombus as a protrusion mass. If it is, you identify the shadow, it might be the red thrombus. If no shadow, it is the white thrombus, and this is a mixed thrombus. Almost all cases, you can identify a thrombus at the culprit site. And the MGH group decided that this plug classification algorithm in ACS by OCT. If you identify the fibrous cap disruption, that should be the plug rupture or OCT calcified nodule. If you cannot identify any disruption, it might be the intact fibrous cap is OCT erosion, and there are other causes of ACS, as you know. And we have to pay attention to the OCT erosion, because there are two types of erosion: definite erosion and probable erosion. This is a definite erosion. You can identify an irregular lumen surface with attached mural thrombus overlying a fibrous plug. We cannot identify any thin cap fibroateroma ateroma around this thrombus, right? And this is a probable OCT erosion. Underlying plug morphology is not visualized due to the presence of residual red thrombus, as shown in this white arrow, and without any detectable rupture. Therefore, it might be sometimes after thrombolysis or thrombus aspiration, we can identify small rupture sometimes. But anyway, if you try to put a stent in case with a plug rupture or erosion, the prognosis is very similar as shown in this slide, and there are no significant difference in the prognosis if we put the stent at the infarct-related region. Right? However, you can treat the erosion without stenting as shown in this slide. This is the data from Harbin University. They finally selected 60 cases with erosion, and 1 month follow-up is performed 55. And they used unsaturated heparin and DAPT. And after 1 month, nearly half of them completely reduced the red thrombus. And more than 80% cases, thrombus disappeared nearly 50% as shown in this slide. So it might be possible to do the medical treatment in case with plaque erosion, especially it is a definite erosion. You can select the thrombolysis with DAPT treatment as shown in this slide. They are doing erosion 2 study in a prospective way. And we have to pay attention to the some types of erosion. This is the site of spasm, as shown in this slide. This is from my friend in Korea. They identified erosion and thrombus sometimes at the site of spasm, as shown in this slide. And at the site of spasm, we can sometimes identify the disruption, erosion, and irregularity, and sometimes normal, as shown in this slide. And finally, they found the OCT erosion or lumen irregularity nearly 80% cases at the site of the spasm in case with vasospastic angina, as shown in this slide. This is another case with chest pain. ECG demonstrate the negative T wave in inferior lead, and during chest pain, sometimes we can identify the ST elevation in inferior lead. In this case, it is unstable condition. Therefore, we speculate the vasospasm. However, we cannot identify any abnormality by angio. Then we did an intracoronary imaging. This is an IVUS. IVUS can identify here the flap, right? We can clearly identify flap, and we can diagnose the spontaneous coronary artery dissection. However, we cannot identify entry and re-entry. Yes, I agree. IVUS is much safer than OCT because we do not need to inject the dye. But OCT may have the risk of expand of the dissection. However, it is important to know the pathophysiology correctly if patient is unstable. Here is a false lumen compressing the true lumen aggressively, and here is the imaging fiber, and it is now the false lumen, and then come back to the true lumen. Therefore, if we put a stent in this case in the proximal site, we will cross the distal true lumen. Therefore, we try to select the true lumen and then put the stent as shown in this slide. After then, we can obtain the improvement of the true lumen size, and there are some false lumen still we can identify. However, it will disappear. This is a steel frame stenting, and the distal lumen improved very much. And the incidence of spontaneous coronary artery dissection is depend on the diagnostic technique. Angiography is not so sensitive. The OCT is the best to identify the incidence of SCAD. However, we have to pay attention to the expand of false lumen. But the risk is very similar to the angiography. And this is a consensus statement of the diagnosis of and treatment of spontaneous coronary dissection from AH group. And they finally recommend the imaging OCT or IVUS if the diagnosis is not complete, right? Or a follow-up, the CT angiography is recommended in case with SCAD as shown in this slide. And this is a consensus document from ESC to treatment algorithm to guide the use of intravascular imaging in patients with ACS. In case with ACS, anyway, you have to do the angiography. And if it is atherosclerotic cause and the culprit is clear, you try to do the PCI, as I already explained. And if the angio is ambiguous or a non-obstructive condition, they highly recommend to do the intracoronary imaging. And if the culprit site is plaque event related, you try to select the PCI. However, if it is not an atherosclerotic condition, we have to decide the diagnose much more in detail SCAD or MINOCA. But MINOCA is only the angiographic definition. We have to differentiate the detail by using OCT, because compared with obstructive condition, MINOCA is much better in prognosis. However, it is still significant, as shown in this slide, stroke and all cause as shown in this slide. Therefore, we have to identify and differentiate the cause of MINOCA, right? Because as shown in this slide, if the cause is atherosclerotic findings, you can select the PCI sometimes, or medically treatment can be yes, suitable sometimes. However, other conditions, CAD or the spasm or other microvascular condition, we have to anyway differentiate. And because, as shown in this slide, this is a little bit yes, a busy slide. However, our treatment strategy is depend on the diagnosis, as shown in this slide. And also, one more yes, important things is artery to artery embolization, right? It is identified nearly 3 to 5% of in STEMI case. That means that culprit is here and the thrombus goes to the distal, and we can identify the occlusion at the time of initial angiography. This is an example. You can identify the total occlusion of the distal RCA. After thrombectomy, we cannot identify any significant stenosis by angio, and OCT demonstrate no plaque rupture erosion at the occluded site, and we can clearly identify the plaque rupture in the proximal site here with thrombus. Therefore, if you would like to put a stent, we have to fix this portion. But in this case, the rupture is very small and thrombus is almost disappeared, and the lumen is very large. Therefore, we can leave it alone if we want. And recommend this clinical algorithm for diagnosis of MINOCA. MINOCA is about 5 to 15% of all AMI, and they highly recommend to do the cardiac MRI and intracoronary imaging, and sometimes coronary functional assessment by physiology, right? And this is the report in last AHA in women and non-obstructive coronary artery disease with myocardial infarction. They finally did an OCT 145 and both OCT and CMR in 116. OCT demonstrate some abnormality at the culprit site in 46 cases, and CMR demonstrated in more than 50% cases the cause of ischemia, and then finally in total 160 cases they identify anyway 84% they can identify the abnormality. And this is the case of OCT image demonstrating various type of culprit lesion in MINOCA, right? And this is a result. OCT demonstrate abnormality 46% cases. CMR identified 74% cases in total. 84% cases can be identified as some abnormality. And so MINOCA is not a single condition. We have to differentiate the condition, right? And finally, I would like to talk about the stent thrombosis. Stent thrombosis is one of the ACS, and there are many reports about the stent thrombosis. However, the OCT can clearly identify the mechanism of stent thrombosis. This is data from a prestige trial in Europe, the acute phase, subacute, late, and very late, and BMS and the DES. And in case with acute, uncovered strut and malapropos strut is very frequent. And also the late, some uncovered and malapropos strut can be identified. However, the very late stent thrombosis, we can identify neoatherosclerosis, and also the BMS, we can identify neoatherosclerosis, right, as shown in this slide. And at the moment, there are no data about how to treat the region of stent thrombosis with neoarteriosclerosis, but it is reported in a stable condition. Neoarteriosclerosis, if instantly stenosis is a very homogeneous structure, that means the fibrous or the proteoglycan rich, we can use the DCB because it is better than the normal balloon. However, it is some heterogeneous condition. There are no significant difference. So this is my take-home message to you today. ACS region morphology can be assessed easily, precisely, and accurately by OCT, not only in native coronary artery, but also in stented site compared with other imaging device because of higher resolution with high frame rate. And different types of disruption, such as rupture, erosion, cultural nodule, and so on, with thrombus can be demonstrated commonly and clearly at the culprit site by OCT. The incidence of SCAD, and it is an uncommon cause of ACS, might be dependent on the different type of imaging modality, and OCT should be the best one. Artery-to-artery embolization of myocardial infarction might be also the uncommon cause of ACS, and OCT might be useful to diagnose and demonstrate the mechanism of it. Using OCT and CMR, different cause of in MINOCA could be diagnosed easily, and improvement of prognosis might be expected because of suitable treatment might be selected ideally according to each mechanism. Thank you very much for your kind attention.
We can take a few questions if we have any in the next few minutes.
Professor Akasaka, can I ask her some practical question?
Hello, Professor Lee.
Nice to see you.
Nice to see you.
Nice to see you, Sensei.
I enjoyed your talk. Yeah, all right.
Thank you very much. Yeah. So in patients with SCAD, sometimes it is very difficult to wiring into the true lumen. And I have some concern about doing the OCT may expand the false lumen because we are shooting the contrast dye. So in the case, I feel like I was maybe safer way for the patient. So can you teach us to get a very nice OCT image for this SCAD patient?
Yeah, thank you very much. It is a very important question, and it is also our concern. Yeah, if the patient is stable and angio is very accurate, you can leave it alone because generally speaking, prognosis is better, right? But if the hemodynamic condition is unstable, anyway, we have to identify the pathophysiology in detail. At that time, I already told you, IVAS should be much safer. If IVAS is enough, we finish the IVAS, right? It's okay. You can decide the treatment by IVAS guide. But if it is not enough, we have to do the OCT to identify the pathophysiological condition in detail. Otherwise, we cannot fix the hemodynamic instability at all, right? That is our way, right? So you can, it is possible you can finish the angio alone. That's okay. But if it is not, IVAS and then next OCT. That is our strategy. Yes.
So Takashi, it is an excellent lecture that you have given on the OCT. I have a small question for you. In all cases of Monica, should we do OCT to define the pathophysiology that is underlying this?
Yes, it is also the very important question, but I would like to say, actually, at the emergency ward or at the outpatient clinic, we measure the troponin and ECG, and if there are some abnormality, anyway, we have to fix the cause of that condition, right? And angio demonstrate no abnormality I highly recommend to do the intracoronary imaging because we can identify some abnormality sometimes, yes, in case with MINOCA, yes.
Patient is a young lady of say, 35 years. The angiogram is normal. She is symptomatic repeatedly with chest pain. And in such a situation, you suggest always a OCT to define something?
It's you can decide. It depends on the symptom, right? If it is the ischemia-like, I highly recommend the intracoronary imaging, especially OCT, because we haven't experienced such young lady having scared, right? Spontaneous coronary artery dissection, and a small dissection can be identified. And also, I could sometimes have a consultation from my friend. The patient having chest pain and troponin elevation, and angio demonstrate no abnormality, and they did an OCT, but they cannot identify any abnormality. But I reviewed the OCT. We can identify very small rupture, yeah, in somewhere, yeah, right. That is a very important finding to identify the abnormality. Yes.
Thank you very much. Excellent. If there is no further questions or anything.
Okay, then we can move to the next session.
Yes, sir. Let us go to the next session.
Our next
Thank you very much.
Thank you very much.
Thank you, Dr. Takashi and Dr. J.M. Lee. Our next session is a very interesting collection of 5 talks by our experienced faculty members. This is titled STEMI Potpourri. The esteemed chairpersons are Dr. A.K. Kumar, Dr. Atul Jain, Dr. Manish Bansal, Dr. Pradeep Baumik, Dr. Shrenik Doshi, Dr. Sudhir Verma, and Dr. Vidut Jain. May I now request Dr. Sudhir Verma to start the session. Thank you.
Hello, am I audible, please? Yeah.
You're audible, sir.
Yeah.
You're audible, sir.
It's a pleasure to invite Dr. Neeraj Bhalla for the initial topic, that is elevated troponin in COVID-19 ICU, when to classify it as an acute coronary syndrome.
Thank you. Thank you very much. So, screen sharing. Yeah, can you see my slides, please? Are they visible?
Yeah, they're visible. Yeah.
Okay, thank you. So must thank the organizers for inviting me. This has been an especially difficult talk to prepare because, you know, this is not something that we are studying on a regular basis, but definitely a very important topic. So thank you, Nitish, and to the organizers. I'm going to talk to you in the next 10-11 minutes about raised troponins in COVID patients and when is it ACS, when we need to take action. So there are several causes of elevated troponin in COVID-19, we know. Acute respiratory illnesses and sepsis are known to be associated with raised troponin levels. And we also know that COVID-induced myocardial injury, COVID may directly cause myocardial injury, and this may take several forms. I'll talk a little bit about these forms, and then we'll come to the topic that how do we differentiate injury by COVID or ACS requiring an action as a cardiologist. So this slide tells you that COVID produces myocardial injury through various mechanisms. Both it can directly invade the myocardial cells, it can cause cytokine activation through microangiopathy. So various ways that the SARS-CoV-2 virus can injure the myocardium. So direct viral invasion is favored by the fact that the COVID virus gains intracellular entry through the ACE2 receptor, which finds very high expression in myocardial cells. So this may directly cause some myocarditis, and immune-mediated protective mechanism may further propagate the injury. However, as yet, there is no robust evidence of direct COVID myocarditis based upon strict diagnostic criteria on biopsy or autopsy, only incidental case reports. So this is a cause, but an uncommon cause. The microangiopathy is propagated by the ACE2 receptor. What the ACE2 receptor does is that it leads to the receptor being downregulated by the virus, and it causes an increase in the angiotensin 2 and pari passu reduction in the angiotensin 1 to 7, which opposes all the angiotensin actions. And so the balance between vasoconstrictor, vasodilator, pro-inflammatory, anti-inflammatory, pro-proliferative and anti-proliferative and anti-fibrotic response is totally disrupted, and there is preponderance of the angiotensin 2 action. Now remember that this ACE2 receptor is widely expressed in endothelium, not only in the heart, but in the lungs, in the vascular endothelium, intestinal epithelium, and kidneys. And this probably accounts for the protein manifestations of this virus, which can injure all these organs by gaining entry into the cells. So microangiopathy causing a severe inflammatory response, fibrinoid necrosis, localized edema, infiltration, inflammatory cell infiltration, and vasculitis in many organs causes microvascular damage, including the heart, and release of troponin. So this can by itself be one of the reasons why the troponin is seen raised in COVID patients. In addition, COVID kidney injury reduces the troponin clearance through the kidney. In addition, coagulopathy is seen, as we all know, and this is caused by various mechanisms caused by the virus, endothelial dysfunction, oxidative stress, and cytokine storm. And we are all aware of the markedly elevated D-dimers. This can cause intense local inflammation and fibrinolysis in the lung, early as well as late pulmonary thrombi, and cause raised troponin levels also. So microangiopathy is a major cause in the early and later parts of the disease. And of course, we are all very familiar with the cytokine storm, which occurs late in the disease, resulting in severe lung inflammation, impaired gas exchange, which is due to the marked upregulation of these pro-inflammatory cytokines. These may directly damage, these cytokines can directly damage myocardial cells, in addition to causing endothelial dysfunction, apoptosis, and promote atherogenesis. And it is seen that plasma troponins closely follow CRP levels late in the disease, which show that the severe inflammatory response to cytokine storm is a plausible form of myocardial injury in the late phase of disease, and as we know, is associated with ARDS, multi-organ failure, and mortality. So several causes of COVID injury to the myocardium through various mechanisms, various pathological mechanisms can cause a rise in troponins. Now, myocardial infarction can also be directly precipitated by the presence of COVID infection. We know that in viral infections, in earlier influenza epidemics, there's a well-documented increase in ACS patients and MI in earlier influenza epidemics also. In COVID too, we understand that the common type of MI is a type 2 MI, which is an imbalance between supply and demand. We'll talk a little bit more about this later on. And many of the precipitating factors obtained in COVID, such as supply issues, hypoxia, fever, and dysregulation. And along with these can precipitate an ACS with or without underlying obstructive CAD. It is postulated that the type 1 MI, which is caused by plaque rupture and thrombus, may also be precipitated by the oxidatory and inflammatory stress, the angiotensin 2 overexpression caused by direct invasion of the endothelium by the virus, and there's a postulate that the virus may also directly invade the plaque, disrupt the plaque, cause plaque erosion and thrombus, and precipitate a type 1 myocardial infarction. So these can be the various putative mechanisms in which the troponins can be elevated. Now, what are the prognostic values of elevated troponins? This is a very large meta-analysis of almost more than 51 studies, which looked at what happened to patients in whom troponin was analyzed and what was the prognostic value. So elevated troponins found in about 21% of patients of those who it was tested. These elevated troponins were associated with a higher risk of subsequent deaths to the rate of more than 2.5 times. And the pooled sensitivity for elevated admissions was 0.6 with a reasonably high specificity. So those patients who had high troponins, the post-test probability is 42% versus 9% for those who did not have elevated troponins, telling us that troponins form a marker of adverse outcome in COVID-19. This is another very big study from Sweden. This is the self-controlled case study. This is a case series with matched cohort in the non-COVID population. And what they did was they tried to find out the incidence of first acute MI following the COVID-19 infection compared with the control group. What they found was that the incidence rate ratio for acute MI was 2.89 times increased in the first week. If you added day 0, which they excluded in this, the incidence risk ratio was 8.44 as compared to non-COVID period of a matched time in the past historically. So you have quite often COVID presenting as myocardial infarction, and as cardiologists, we all have experienced this. But people who carry COVID, who carry cardiovascular risk factors have a markedly increased risk of MI on day 1, increased by 8.44 times, and in the first week 2.5, and second week, first week 2.89 times and 2.5 times in the second week. Similar raised risk for stroke. So this suggests that COVID-19 by itself is a risk factor for precipitating acute MI and ischemic stroke. So that's about what the data is. So how do we decide that what is these troponins in COVID-19 when there's so many mechanisms operating? How do we define that this is ACS or this is part of the disease? For this, we have to fall back on the 4th universal definition of MI, which should be used acute MI label should be used when there is an acute myocardial injury with clinical evidence as well as rise and fall of cardiac troponin values with at least one value above the 99th percentile upper reference limit, and at least one of the following symptoms of myocardial ischemia: new ischemic changes on the ECG, development of pathological Q waves, or on imaging evidence, new loss of viable myocardial or new regional wall motion abnormality consistent with an ischemic etiology, by which they mean it follows a vascular pattern. Or in addition, identification of a coronary thrombus by angiography or by autopsy for type 3 MI. And so this is type 1 MI. If these definition of MI is caused by an acute atherothrombotic CAD precipitated by plaque disruption or rupture, or either rupture or erosion and a thrombotic occlusion, and this can be imaged by angiographically, non-invasive, or on autopsy. Type 2 MI is when this MI occurs consequent to a mismatch between oxygen supply and demand, and there are various reasons that I told you occur in COVID also. And in top of that, hypoxic lack of supply, coronary vasospasm produced by various features, along with tachycardia, fever, all these can cause a mismatch between the oxygen supply and demand. And type 2 MI is what we are finding very commonly in troponin. So what about non-ST elevation MI? So ST elevation MI, by definition, again, this is well known to all of us, but just to reiterate how to differentiate raised troponins and whether it is ACS. So we know that ST elevation MI must have ST elevation in at least 2 contiguous leads, and we know these quite well. So either ST elevation in the contiguous leads or a new LBBB are the ECG definitions that are required to label this patient as having an ACS ST elevation MI in the presence of raised troponin. However, again, we understand that ECG criteria are not particularly specific in COVID-19, and we know that stress cardiomyopathy, possible myocarditis, and other sepsis-associated cardiomyopathy can also cause ECG changes. So we need to carefully consider all the possibilities before we embark on a particular reperfusion or interventional management therapy. Non-ST elevation MI, slightly less of a problem. It mandates upon us to identify high-risk features which demand an immediate or an early reperfusion strategy, and this is in the form of ongoing myocardial ischemia. Either the patient is symptomatic with repetitive angina episodes, dynamic ECG changes, ventricular arrhythmias, or has presented with heart failure or shock. So unless these high-risk features are there, we have more time, we can manage these patients initially, conservatively. Uncertain diagnosis such as require a combined clinical evaluation and ECG, and usually this is enough to make a diagnosis to start the treatment of these patients. Cardiogenic shock or a mixed etiology shock can be particularly difficult to manage in these patients, especially late in the disease, where we know that due to the cytokine storm, there is a surge response and there is a vasodilatory shock. There is also septic shock, and this may be accompanied with concomitant myocardial suppression and cardiogenic shock. So this is particularly difficult to manage late in the etiology, late in the course of the disease, and usually has a pretty high mortality outcome, as we all know. Echocardiography really has quite a limited role, and it is important for us to limit this only to those patients in whom we are going to feel that this is going to have a significant impact on the management or is likely to change the patient's prognosis. Findings on an echo that favor a condition other than ACS are rather more important, and these include no wall motion abnormalities during pain, no wall motion abnormalities that are not in a regional area suggested by the ECG, wall motion abnormalities in a non-coronary distribution of global hypokinesia, you may say, and less specific findings such as small pericardial effusion. Of course, focal abnormalities may present with non-coronary injury, and also we know that global dysfunction of the LV may accompany ACS. So echo, just like troponin, cannot be used as a sole determinant of whether reperfusion therapy is pursued. So combination of your clinical acumen, ECG most importantly as the cornerstone of diagnosis for ACS, and supportive investigations such as troponin, and keeping the universal definition of MI in mind will, I believe, guide us correctly into making a decision as to how to triage this patient and which patients should get urgent intervention therapy and which patients can be followed up more conservatively. So I'd like to conclude by saying several mechanisms, as I've elucidated, can cause a rise of troponin levels in COVID-19 patients. Not all of them are due to obstructive coronary artery disease. Raised troponins by themselves are an independent marker of worse prognosis in COVID patients. COVID-19 infection, on the other hand, significantly raises the risk of ACS in susceptible patients, and these people have worse outcomes. Identification of ACS as a cause is important from management point of view, especially in those needing urgent intervention. A careful clinical assessment along with ECG criteria suffice in most cases in making a correct diagnosis. By themselves, troponin levels alone are not sufficient. Role of other diagnostic modalities is limited and should be used only if it will alter the management of the patient. Thank you.
Thank you, Dr. Neeraj. A fine elucidation of a very recent disease which is striking the mankind. 2-3 points I would like to make. One is that chronic myocardial injury should be seen as a prospective candidate for injury due to COVID. That is, a delta of troponin levels must be done. And secondly, very surprisingly, the incidence of ST elevation MI went down during COVID pandemic. It has been put up in the literature. I think we can elaborate on that, and 1 or 2 comments from the worthy co-chairs.
Can I comment? Dr. Bhalla has given a very good talk. Regarding just EAPCI has also recommended one more thing, you do basal troponin level at the admission time. And if you suspect coronary artery event, it should be more than 5 times at the next event. So next troponin should also be done once you are suspecting. Then possibly you can corroborate and give your conclusion along with ECG, along with clinical, and then you will become much and much informative and confirmative about the ACS in COVID. Thank you, Dr. Balla.
Yeah. So if I may respond, the first question being that incidence of MI came down in the first wave of the pandemic, but I don't think we found that in the second wave. Much analysis has been done about why this happened, and you're right. Worldwide, there was a significant fall of patients presenting to the hospital. Various reasons have been attributed. Mostly, it seems to be that fear of reporting to the hospital have prevented patients from coming. Many patients who came have come late, so patients have either delayed and then there were also some mechanisms that lack of stress, lack of this may have contributed. But I think mostly this has not stood the test of time, and we are finding that the incidence of MI actually has increased in COVID along with the other flu epidemics that have been seen worldwide. So initially it was probably due to extreme fear that patients would not come. The second question, sir, is that all patients should get a troponin at admission and rise of troponin by 5 times. This is your suggestion. I cannot dispute that, but I will say that simply using troponin, since there are so many mechanisms in COVID which are raising troponin, including sepsis and all the others that I showed, along with ECG changes and symptoms should then guide the management. So I think then we'll be better off.
Now, may I now please invite Dr. MP Girish on a very camouflaged ailment, that is RVMI diagnosis and management, still amplitude and helping us whenever it is diagnosed.
Yeah, I think my slides are visible.
Yes, sir.
Yeah, okay. At the outset, let me thank Dr. Nitish and the organizers for organizing such a wonderful meet during the very difficult times of COVID. And I've been interested with the topic of RVMI diagnosis and management. Okay, the entity of RVMI was first described in a series of 6 patients in 1974. And if you actually see, RVMI can be seen in 1/3 to 1/2 patients presenting with infeval MI. And it contributes significantly to clinical and hemodynamic instability. It also increases in-hospital morbidity and mortality. However, one should understand that RV has a unique structural and physiological characteristics that has led to the reduced prevalence and a faster recovery compared to LV. See, there is exaggerated interventricular interdependence in patients with acute RV infarction. And this RV is actually thin-walled and it requires less oxygen. And it is perfused both in systole and diastole compared to LV. It has very rich collaterals from left coronary artery. It has direct blood supply from Sebacean veins, and it has the capacity to extract oxygen more during stress compared to the left ventricle. So the diagnostic approach includes clinical features, ECG, coronary angiography, hemodynamic study, echo, MRI, and radionuclide myocardial imaging. The classical symptoms usually is that of vagotonia, that is nausea, vomiting, diaphoresis, pallor, and sometimes syncope or near syncope, more likely because of bradyarrhythmias. The characteristic hypotension, raised JVP, and no pulmonary congestion. And sometimes you can have small signs, TR murmur, AV dissociation, and because of an increase in RV EDP, sometimes there might be PFO with the resultant right to left hand, resulting in systemic hypoxemia, which is not which is resistant to oxygen therapy. The classical triad, which is described as hypotension, elevated JVP, and a clear lung field, is characteristic, but it is not pathognomonic. It has a very high sensitivity, but a very low specificity. Coming to the electrocardiography, so usually it is because associated with the infi-wall MI, you can have the infi-wall MI changes in ECG. Since the conventional ECG leads barring V1 and sometimes possibly V2, which provide a partial view of RV, free wall, no other leads are directly over the RV. So an ST elevation of greater than 1 millimeter in leads V4R is suggestive of a proximal RCA occlusion, that is occlusion of RCA prior to the origin of RV branch. Sometimes most of the time, these ECG changes are very transient, and absence of ST elevation in lead V4R does not exclude RVMI. But however, if there is a greater ST elevation in V4R, which suggests significant RV dysfunction and in turn higher in-hospital morbidity and mortality. So the sensitivity and specificity and positive predictive value, the specificity of almost 100 is for V4R and V5R, and sensitivity is 87.5%. So this is the classical ECG where there is elevation of ST by more than 1 millimeter in V4R and V5R and also V6R. These other ECG changes which can be seen can be both bradyarrhythmias and tachyarrhythmias, and they usually suggest the poor short-term outcome. Bradyarrhythmia is either it is because of ischemic SA node or AV node dysfunction. Tachyarrhythmias, which can occur in up to 1/3 of the cases of these RVMI, can be both ventricular tachycardia as well as ventricular fibrillations. Since the use of echocardiography and which can be used on bedside, this is the more reliable echocardiography is more reliable compared to other investigations beyond ECG. So there is an RV dilatation and occasionally RV dilatation, impaired RV free wall motion, a diastolic reverse septal curvature, and systolic paradoxical septal motion, and reduced SPAPSy, and impaired velocity on tissue Doppler imaging and IVC plethora. However, there are some problems in with the echocardiography in RVMI because of the complexity of the RV and the transient nature of ischemic RV dysfunction because of the physiological properties that the RV has. So the important finding here would be the RV free wall longitudinal strain, which is shown to be very useful. A cutoff value of greater than or equal to 19.7% is a useful tool for RV involvement. It is an independent predictor to rule in the proximal RCA culprit lesion. As you all know that MR is the standard imaging for RV function. Since it is a very time-consuming procedure and we are dealing with an acute MI, the role of which is not very well investigated in RVMI. However, late gadolinium enhancement is more sensitive compared to echo. If the studies using LGE, the MR studies have shown RVMI to be present in 47 to 57% of the patients of infeval MI. However, radionuclide studies, though they can help in calculate RV ejection fraction and regional wall motion abnormalities of RV, it is less popular because of the easy availability of CMR. So this is the classical MR picture where it is showing late gadolinium enhancement of the RV free wall, which is depicted by the red arrows, and the white structure, which is the inferior wall LV, which is because of the proximal RCA occlusion. So the therapeutic approaches for the treatment of RVMI includes reperfusion, optimization of RV preload, and rhythm optimization, inotropic support, and mechanical circulatory supports. The general principles for any patients with RVMI, the treatment is similar to that of any MI with the early use of DAPT, statin, fibrinolysis, or primary PCI. However, the word of caution as to what should be avoided. So the drugs which have a negative impact on preload, heart rate, and myocardial contractility, like opiates, nitrates, and beta blockers, should be avoided. So the characteristic hemodynamic parameters on a cath study would be an RAP, or mean RA pressure, more than 10 millimeters of mercury, RA pressure versus PCWP, that is the discordance between the right-sided and left-sided pressures of more than 0.8. RA pressure within 5 millimeters of pulmonary capillary wedge pressure. Pulmonary artery pulsatility index, that is systolic pulmonary artery pressure minus diastolic pulmonary artery pressure over mean RA pre. If PAP index is less than 0.9, it has a 100% sensitivity and 98.3% specificity for predicting outcomes in patients with RV myocardial infarction. So the optimization of preload is the one which distinguishes therapy, which is the characteristic therapy for RVMI when compared to only LVMI. So IV normal saline 0.9%, 40 ml per minute for 2 liters, or infusing aliquots of 200 to 300 ml of normal saline. What should we measure by giving saline? Saline, you serially assess JVP or CVP and blood pressure. The aim of therapy is to maintain CVP of approximately 15 millimeters of mercury and pulmonary capillary wedge pressure of 18 millimeters of mercury. So this concept of fluid replacement or in ischemic RV was first described by the group Lopez and Sendon in 1981. And the hemodynamic instability in RVMI is most commonly because of volume status and the degree of LV involvement. Maximum RV stroke index is usually seen when you achieve an RAP of 10 to 14 millimeters of mercury and pulmonary capillary wedge pressure of 16 millimeters of mercury. This is the graph which is showing the optimal right-sided filling pressures and the pulmonary capillary wedge pressures, which has the optimum right RV cardiac index. So rhythm of optimization, infacted RV and preload deprived LV, they have a fixed stroke volume. So hence heart rate is a very important mechanism to maintain the cardiac output. So since these patients are known to have AV conduction blocks, more commonly complete heart blocks, this RVMI with complete heart block should be given temporary dual chamber pacemaker, which is better than single chamber pacemaker, which helps in prevention of development of cardiogenic shock. Inotropic support should be used when fluid resuscitation alone is insufficient. Some of the inotropic agents like dobutamine have an additional effects like other than vasoconstrictor effects. It also reduces pulmonary vascular resistance and reduces RV afterload, as well as improving AV conduction by reducing the vagotonia. The use is largely based on expert opinion and animal data. There are no controlled trials in this subset of patients with these drugs in this subset of patients. Coming to the mechanical circulatory support, we have 3 different types of mechanical circulatory supports: direct RV, indirect, and biventricular support. Direct RV support devices like Impella RP is the only device currently approved for acute RV failure, and it can generate cardiac output up to 4 liters. In the Recover Right trial, 30-day survival and discharge in acute right ventricular dysfunction was 83.3%. However, Impella RP for acute RV failure secondary to cardiotomy or acute MI, survival was only in 58.3% despite use of Impella RP. And indirect RV support in the form of VA ECMO, which reduces the RV preload and RV cardiac output and increases systemic vascular resistance. With an addition of IABP in presence, IABP to ECMO may be very useful in patients who have significant biventricular failure. In one series of 32 patients who underwent culprit artery PCI with IABP support, the survival was to the tune of 81%. So the joint EAPCI SCVS expert consensus document, which was released in this year on percutaneous ventricular assist devices. So these are the 3 devices which are of use in patients with RV dysfunction, that is IABP, percutaneous right-sided support, and VA ECMO. So IABP is not suggested in isolated RV failure. In presence of BIV or in presence of significant LV involvement along with RV failure, IABP can be a good support, especially when the patient is undergoing primary PCI. And Impella RP may be used in patients with cardiogenic shock, predominantly due to RV failure. So the take-home message from this study, from this presentation is nearly 50% of the patients have RV involvement in acute MI patients. And majority of them have proximal RCI occlusion. And the characteristic finding of hypotension, raised JVP, and clear lung fields. And they are known to have increased morbidity and mortality. The key strategy is again early reperfusion, avoiding unnecessary drugs like nitrates, beta blockers, and calcium channel blockers. Fluid resuscitation is the key, and inotropes should be used if required. And mechanical circulatory support can be given to hemodynamically unstable patients wherever indicated. Thank you.
Thank you very much, Dr. Girish. As the time constraints are there, can we go ahead with the next talk, that is risk stratification post STEMI, when and how, by Dr. Parag Barwal.
Audible also?
Yeah, now it's audible, please.
And are my slides visible now?
No, sir, your slides are not visible. Please share your screen.
I'm sharing the screen. Okay.
Sir, please click on screen share button at the below panel.
Yeah, ma'am, I'm doing that, but it's not coming anything. It's like I'm sharing it. You are the co-host, but I'm not, my screen is not, I'm not able to.
I think you can leave and rejoin.
Okay.
It's okay. Then can we request first Dr. Vimal Mehta to start his talk on lipid management post-STEMI, guidelines, recommendations, and practice patterns.
Dr. Vimal, please unmute.
Is my slide visible? Are slides visible?
Yes, sir. Your slides are visible. Please
And
put
I'm
it in
audible
presentation.
also.
Yes, sir.
So at the outset, I would like to thank the organizers, especially Dr. Nitish and Dr. Nitish, as well as Dr. Nitish and Dr. Rakesh Yadav. So the topic is lipid management post-ST elevation myocardial infarction, guideline recommendations versus practice patterns. I've been part of various multinational, multi-center drug trials, including many on evolocumab and PCS inhibitors. Now, AC represents a constellation of event types ranging from unstable angina to ST elevation myocardial infarction, predominantly because of supply mismatch, mainly because of the plaque rupture. And we know after acute coronary syndrome, in the ensuing time period, that is up to 6 months, the risk of further events, future adverse cardiovascular events is very high. So it is pertinent and logical to initiate all risk reduction therapies. Regarding lipid-lowering therapy, it is important to initiate high-intensity lipid-lowering therapy in the initial phase after acute coronary syndrome because it provides, so as to provide continuous risk reduction in risk, stabilize plaque, mainly because of pleiotropic effects of statins, and patient is already in hospital and is more likely to adhere to therapy. Why this is important, I will tell later on. The first Euro Heart survey in acute coronary syndrome done in early 2000s, when statins were not very commonly used, showed that patients who were initiated statin within 24 hours after the acute coronary syndrome, 50% of them being ST elevation myocardial infarction, there was significant mortality benefit seen as early as 7 days. And this was confirmed in a randomized control trial setting in unstable angina and non-ST elevation myocardium infarction patients, in which was 16% relative reduction over 16-week period. And PIMI 22 study took it further, studied the patients of acute coronary syndrome who were given statin, high intensity versus low intensity statin, and followed up for 2 years. In patients who were given 80 mg of statin, there was 50% reduction in LDL, and this again resulted in 16% relative reduction. And this benefit was apparent as early as 1 month, though it achieved statistical significance at 6 months. In the Armida ACS study, where loading dose of 80 mg of statin was given, it was shown that peri-procedural increase in cardiac enzymes were reduced, as well as survival at 30 days was better with statins. And Secure PCS trial, published in 2018, again gave 2 loading doses of atorvastatin, 25% being ST elevation myocardial infarction patient. And it showed patient who received a loading dose of statin and underwent PCI showed significant reduction in events over 30 days, or this reduction in events was not seen in non-PCI patients. And important to note is the fact from IVO study is the reduction in plaque is linearly related to LDL lowering. More will be the LDL lowering, more will be reduction in plaque. And at achieved LDL of 50 mg, that is patients who achieve 50 mg of deciliter, the plaque reduction is seen in majority. So how does statin help detoxify the plaque? By increasing the fibrous thickness, decreasing the lipid necrotic core, reducing the macrophage index, and ultimately decreasing the total trauma volume. However, the problem with high-intensity statin therapy is that it decreases LDL by only about 50%. Now, what will happen if we decrease LDL by more than 50%? This option was not available to recent introduction of PCSK9 inhibitors. Before that, IMPROVE-IT trial, which again enrolled ACS patients within 10 days of the index event, showed a modest relative reduction of 9% after addition of STEMI 10 mg on top of simvastatin 40 mg. However, PCSK9 inhibitors changed the whole scenario, and as shown over here, this was a 4-year study, this was a non-ACS trial. The message is very clear from this study that 2% of patients achieved LDL of less than 10 mg per deciliter. And these patients, this subgroup of patients, had 10 times more relative reduction in terms of adverse CV events compared to those who achieved LDL of 70 to 99. And this reduction was continuous. That is, there was no threshold below which LDL lowering did not help. And in post-ACS setting, PC outcome studied where patients within 1 to 12 months of ACS were given alirocumab or placebo on top of high-intensity statins, and it showed 15% reduction in primary endpoint. And this reduction was markedly more significant in patients in whom baseline LDL was more than 100. In these patients, even CHD death and all-cause death were also reduced. So if we give all three, that is PCI, intensity statin, and STEMI together, we can achieve somebody had, a host had muted me actually. So triple therapy will result in 85% reduction in the LDL, which is very good. Now, it has been shown that plasma PCSK9 levels are increased in acute myocardial infarction, such that the patients who are in the highest tertile of serum PCSK9 levels have lower fibrous cap thickness as well as high necrotic core. So there is a new theory that PCSK9 itself gives vulnerability to the plaque, and increased PCSK9 levels are make the plaque vulnerable and more prone to rupture. And so lowering by inhibiting the PCSK9 can have effect more than lipid lowering effect. And this has been not studied in long-term trials, but safety and efficacy has been studied in a few studies. First is the EOPAC study, in which 308 patients were given 1 or 2 doses of evolocumab within 24 hours of event, and they showed that over a period of 4 to 8 weeks, most patients achieved LDL goals. However, this was not to study the events, because a trial was only up to 8 weeks. OCT in the OCT was done in this OCT trial, in which 64 patients were studied, who were given 4 weekly evolocumab 320 milligram, and showed that after 12 weeks, after a short duration of therapy, the fibrous cap thickness, lipid arc, and lipid length, fibrous arc thickness increased, and lipid arc, lipid length, and macrophage grade all decreased. So it was mechanistically beneficial. And importantly, as shown in this trial, in acute ST elevation myocardial infarction patients, most of the patients at 4 weeks, that is up to 96% patients, were able to achieve LDL goals of less than 55, vis-a-vis those who are only on high-intensity statin, only 10% were able to achieve these goals. And this has been shown in few other studies. Another problem is lipoprotein A. And as we know that 35% of Indians have elevated levels, and at this point of time, only PCSK9 inhibitors are there, which can decrease LPA levels. Statins not only have no effect on LPA levels, but some studies show that they can increase the LPA levels by up to 10%. Nevertheless, patients who have high LPA levels have more events, as shown in Fourier and Odyssey outcome trials, and those who are given PCSK9 inhibitor therapies, they have more benefit in these patients. And 30% of the LPA mass is cholesterol. So certain patients who have very high LPA levels, they will not be able to achieve goals only on statins alone. And we have published multiple papers in various journals, and this is representative. 2 papers where Lipid Association of India has proposed goals for Indians, and this and our editorial appeared on the cover of this journal. And these 2 papers have been recently accepted in American Journal of Cardiology and in Journal of Clinical Lipidology, which particularly deals with the subject of acute coronary syndrome and lipid-lowering therapies. Here, in short, it states that in all ASCVD patients, Indians should have LDL goal of less than 50, and in patients who, despite being on these levels, have recurrent acute coronary syndrome, should have LDL goal of less than or equal to 30. And other guidelines across the globe, ACC and ESC, more or less with slightly higher goals, say the same thing. For example, ACC states that patients who have more than 70 LDL on high-intensity statin should be started on non-lipid lowering drugs. And ESC says that patients who have recurrent ASCVD events should have LDL of less than 50. We have given an algorithm. Basically, it states that patients should have extended lipid profile, including LPA, at the admission only, and based on that, if LDL is very high, it should be started on combination therapy, or maybe PCSK9 should also be added. Now, last 2-3 slides. Now, these are guidelines, and what about practice? As far as achieving LDL goals is concerned, it's a story of failure. Complete and total failure, when success should have been reasonably easy to obtain. Reason is simple. This patient, MI patient, PCI done, and patient is only on moderate intensity statin, and this patient was just representative, and patient has post-CABG and only on 10 milligram of atorvastatin, and patient has presented now with recurrent ACS. And this is a small study of 500 patients from Tamil Nadu, and it shows patient diabetic subjects who had LDL of more than 100, only 7% were on statin, be it rural or urban setting. And in patients who had established coronary heart disease, only about less than 50% were on statin. This is the true picture. And a publication, my last study, publication which has come in JAMA only around 2 weeks back, tells about American scenario, which is not very different. And there are lessons to be learned from it. 5,000 patients, and what they show in dark green bars, that 80 to 83% were given statin, and importantly, over 2 years, there was no change in lipid lowering therapy for most subjects, and this was true for other lipid lowering therapies also. And patients who initially had LDL-C levels of more than 100, here 120 was the mean, and they hovered only in that range only, so no benefit. That is only over 2 years, only 17% patients had lipid lowering therapy intensification. And ultimately, what we get is less than 20% patients had achieved LDL goals, be it less than 70 or be it less than 55. Whatever you take, on less than 20%. So what is the lesson? The lesson is that intensive lipid lowering therapy after the index event should be started at baseline, because rarely it is intensified on follow-up. There are many reasons of it, mainly because of physician inertia or fear of side effects, both from the patient side as well as from the physician side. So to conclude, the risk for recurrent ischemic events is highest during the early period after an acute coronary syndrome. Extended lipid profile should be measured in all patients after index event within 24 hours, because after that lipid levels may change. Higher the baseline LDL, higher the risk, and low and very low LDL are safe and effective in reducing CV events, as has been shown in PCSK and trials. And high intensity statin therapy is the first line. STEMI should be added, and even after the index event, based on LDL levels, one should be very proactive in giving dual therapy at least at the beginning, immediately after the event. As shown over here, 12% patients in the various trials which I listed of PCSK9 in ACS, only 12% in the statin group achieved LDL over short period of 4 weeks, vis-a-vis those who are starting on PCSK9, where 96% achieved goals. For long-term, very marked reduction in LDL, what it translates in, whether it translates to MACE reduction or not, is to be seen in larger trials. Thank you so much.
Thank you very much, Dr. Vimal. Now, may I invite Dr. Parag to join in, please, if the slides are ready.
I hope now the slides are visible.
No, sir, not yet.
Just a minute, just few seconds more. Okay.
Sure, sir.
Are they visible now?
Yeah.
Yes, sir, it's visible, sir.
Okay. So, a very good evening to everyone. First of all, thanks to my teachers who have given me the opportunity to present myself in this STEMI Council meeting. I would be presenting the risk stratification post-MI, which is an important topic. We usually do it by our own ways. Everybody has so much of experience of managing STEMI that they do it on a personal note, but how systematically it can be done, what are the ways of doing it, and what are the timings of doing it, how to do it, I would be just briefing it in next few minutes. As we all know that whenever a patient comes to us with a STEMI, there are so many questions in our mind, in our patient's mind, as well as in the relative's mind. How is this patient going to behave in the hospital? What is going to be the in-hospital outcome? When he gets discharged, what is going to be his intermediate or a long-term outcome? And if he gets revascularization, whether it is going to be a culprit vessel revascularization or a total revascularization. Just to answer these questions, we need to know the factors which are affecting the outcome of the patient and how to combine these factors to come to a conclusion. And thus, there comes the reason for risk stratification in STEMI. As we all know that the therapeutic modalities and diagnostic modalities of STEMI has improved significantly over a period of time. Despite that, there is a significant mortality of almost 6 to 14% of these patients in initial 6 months post-MI. And this mortality is not like, it's different in different strata of patients of STEMI. And that is why these patients can be divided into a lower risk group or a high risk group, depending upon the parameters which they have it at the time when they present to us. So if a patient is low risk, we can stratify these patients into an early discharge within 48 to 72 hours, and it has been found to be safe and it's very highly cost effective also. And if the patient is high risk, he will have longer duration of stay, he may get up into complication and then have the long-term issues. On these background, we need to have a better allocation of our resources for the patients of STEMI, and that is where risk stratification is the most important aspect. Early risk stratification usually starts when the patient comes to us at the time of presentation into an emergency hall, or else they present to us in an ICU. We need to, and early risk stratification, what we get to know is how is the patient going to behave in the hospital and is going to have a short-term outcome. And later risk stratification at the time of discharge or when the patient comes to us for the first time follow-up will tell us whether the patient is going to have later complications such as non-arrhythmic deaths, heart failures, or arrhythmic deaths. So what all factors on which the patient's outcome depend? Immediate, early, like at the time of discharge, 30 days, 3 months, 6 months, and 1 year. So there are certain clinical parameters such as age, weight of the patient, the traditional risk factors for hypertension, diabetes, dyslipidemia, and smoking, prior history of an MI, his heart rate, his blood pressure, his Calip class, whether he is in heart failure, edema, whether he has an anterior wall MI, inferior wall MI, or an LBBP, and time to reperfusion. There are certain investigations such as ECG findings of ST elevation in what all territories, the quantum of ST elevation, the cardiac biomarkers, the revascularization status, whether he has been revascularized or not, angiographic details, meaning that we can calculate the syntax score of the patient at the time of presentation when the angiography is being done. And then the TIMI flow status, ejection fraction, hemoglobin, creatinine. And for late risk stratification, we have MRI, PET, or nuclear studies. On the basis of these parameters, by taking individual risk parameters or mixing the parameters from the clinical and from the investigational part, there are so many scores which have been devised. These scores are from the time of either a fibrinolytic area or from the era from where the primary PCI or the PCI have come into picture. From the fibrinolytic era, there are Gusto score, TIMI score, dynamic TIMI score, simple risk index, GRACE risk score. From the PCI era, we have a Cadillac score, PAMI score, Apex AMI score, Zoll risk score, and Action Registry score. These are so many scores, and detailed scores are being given on the internet as well as in the literature. I won't be going so much in detail because that's not practically possible with this presentation. But I would be just brushing upon at what time which score needs to be used. At the time of emergency, if the patient comes to you in emergency, the immediate outcome of the patient within 24 hours up to the time of discharge can be best appreciated from a TIMI score and a GRACE risk score. So I would be discussing in brief about TIMI and GRACE risk score. If the patient undergoes a fibrinolysis, the basic score which can be applied to the patient is a Gusto or a TIMI risk score. If he undergoes an angiographic stratification, what we can use is a MI syntax score, which is practically a syntax score applied in a patient's of MI. If a patient undergoes a primary PCI, we can use a Cadillac, PAMI, or an Action model. And at the time of discharge, Zoll risk score is the best score for stratify these patients into low risk or high risk. These scores are made by statistical methods. I can't go into much details of that. So coming to the TIMI risk score, which has a prognostic ability to give the prognosis of a patient at 24 hours in hospital, 6 months to 1 year. A score of less than 2 is considered to be low risk, and more than 2 is considered to be high risk. In this, these are the parameters such as age, 65 to 74 is given 2 points. Then there is hypertension, diabetes, angina, 1 point, and there are blood pressure, heart rate, Calip class, weight, and whether the patient presents with anterior wall MI or a left bundle branch block, and if there is a time to reperfusion more than 4 hours. The risk of dying during the hospitalization depends upon the individual number. If the person has a risk score of 0, his odds of dying is only 0.1, but his odds increases to more than 8 if the risk score increases to a score of more than 8. And STEMI is not a one-time procedure. Basically, if you have a STEMI, then if the patient remains in hospital, it's a dynamic process. Patient can go into heart failure, patient can go into stroke, patient can develop major bleeding, can have arrhythmias and renal failure. So as and when each and every point is being added to the current situation, you will have increasing dynamic STEMI risk score, which also determines that the risk of dying increases from 1.3% to 24.8% in hospital as these points are being added to the patient's clinical status with time. There's another very simple risk score is called as age simple risk index, this is the formula for calculating simple risk index based on only 3 parameters, that is age, heart rate, and systolic blood pressure. And it has been found that this has got a very good 30-day mortality prediction. GRACE risk score is a very detailed risk score, the formula, and it has got a simple calculator which is available on the internet, which we can go through. And it has got a very good predictive ability for both STEMI and non-STEMI. I would not be discussing much more detail in that. So if a patient undergoes a revascularization, these were the scores which were applied to the patient who were in the fibrinolytic era, but are still applicable to patients who are having STEMI and come to us in an emergency setting. If a patient undergoes revascularization based on his angiographic finding, as well as certain clinical, as well as investigational parameters, CARDIOLOGY, PAMI, and the ZOL are the 3 risk scores which can be applied to these patients for risk stratifying them into low, intermediate, or high risk, and their mortality or their in-hospital outcome changes accordingly based on these scores. CARDIOLOGY risk scores says that a score of 0 to 2 is considered to be low risk, means the risk of dying of the patient in hospital is less than 0.1%. But we need to understand certain pitfalls of these scores also, because there are certain limitations. These scores were basically determined in patient population who were highly selected in STEMI trials, such as they were not failed thrombolytic patients, they were not multi-vessel PCI, they didn't have any hepatic or renal dysfunction or bleeding diathesis. So basically, these scores are specifically derived from trials which have taken into consideration stable patients. So unstable patients were meaning the real world patients were taken out of these studies. So the practical applicability of these scores are not that great. Similar is the situation of PAMI risk score also and ZOL risk scores also. Coming to an important risk score of syntax. Syntax, as we all know, that was used only for, at the beginning, it was used for chronic stable angina patients who were undergoing either a multivessel PCI or a CABG, but later on in patients of MI also, syntax score is very important. As the syntax score increases, the chances of having complication or in-hospital mortality also increases. There's another very important aspect is the residual syntax score. Means if a patient undergoes an angiography, there is a culprit vessel which we address at that point of time, and then there are certain more lesions which are going to remain if you just address the culprit vessel. And if the syntax residual score is more than 8, his chances of having major adverse cardiovascular event at one year is very high. So coming to another important aspect of risk stratification is whether we should do, in cases of MI, only culprit vessel PCI, or should we directly go with a multi-vessel PCI? There are these trials. These are the PRAMI trial, Dynamic 3 trial, and culprit trial. From 2013 to 2015, good amount of evidence has gathered that if you do non-culprit related PCIs also in a same hospitalization or in the near future, there is going to be lesser risk of major cardiovascular events such as death, MI, and revascularization. And this was predominantly derived from decreasing rate of revascularization. But there came another very important trial in 2017, which was culprit shock. And here comes the importance of taking this a specific subset of population, that is shock. Earlier it was thought in RDM times that if a patient is in cardiogenic shock, you can address the culprit followed by non-culprit artery also. But this was the first trial in 2017 which has shown that if you address the culprit only, then the chances of having death or renal replacement is less by 9.5%. Absolute reduction of death or renal replacement is less by 9.5%. So after this trial, we have gotten information that we may not be actually doing the non-culprit PCI if the patient is in cardiogenic shock. You just need to address the culprit vessel and just get out of it. And then come the latest trial, which is the Dr. Shamir Mehta's trial of 2019, which was published in NEJM, which has shown that if the patient is not in shock, so we have seen a very specific situation of shock. Now, if the patient is not in shock, and if the patient comes to you with a STEMI of anterior or inferior wall MI and has simultaneously lesion in other territories, and if you address them with an intent to complete revascularization in the same hospital admission or in near future, you're going to reduce the cardiovascular death or a new MI by 26%, meaning that number needed to treat is only 37 to prevent one MI or death. And if you take into consideration cardiovascular death, MI and ischemia-driven revascularization, only 13 patients you need to treat to prevent one of these episodes. So initially we thought that culprit vessel is the only vessel which we need to treat, but only in patients who present to us with shock. If the patient doesn't present to you with shock and he has lesions in other vessels also, you need to treat them in immediately, meaning that in the same hospitalization, or you can do it in the near future. Then comes once the patient is discharged from your hospital and comes back to you, then there is a importance of late risk stratification where you need to do ejection fraction assessment. You can do ischemia assessment on the basis of PET or in a nuclear study or an MRI, and you can risk stratify these patients. And how does it risk stratify? As we all know that the ejection fraction is a major determinant of outcome, and we can see that as the ejection fraction falls to less than 30%, the risk of 6%, 6-month mortality or 1-year mortality creeps up very significantly after the ejection fraction has gone down to less than 30%. When should we measure the left ventricular ejection fraction? Probably not within the index admission, because the heart is remodeling. The stunning is there. So within 3 to 14 days, there occurs a spontaneous recovery of the left ventricular ejection fraction, and specifically if a patient has undergone a revascularization. So we need to assess them after 14 days or probably up to 6 weeks, where the real ejection fraction after revascularization is assessed. And then we can risk stratify these patients into a moderate risk or a high risk, depending upon what left ventricular ejection fraction they achieve. There are various other parameters which can also be taken into consideration, such as MRI, PET, or any other nuclear studies. So again, coming back to the same algorithm, at the emergency, these risk scores, at the time of fibrinolysis, the Gusto or a TIMI risk score, invasive strategies being used, then this risk scores can be used. So overall, STEMI is a complex clinical scenario that requires an immediate diagnosis and a rapid therapeutic management and early risk stratification. There are so many risk scores which are being used by various trials, but and has been accepted in the practice guidelines. Many risk scores have been built and validated in the setting of STEMI to have a prognostic information, and it facilitates us to for the better health resources allocation. There are different aspects should be considered for selection of proper risk scoring, and then we would be able to actually explain it to the patient as well as to the patient relative that what is going to happen to this patient, because we need to know, first of all, what we need to tell it to our patients also, that what can they expect from their manager. So this is my presentation.
Thank you, Dr. Parag. After these excellent elucidations till now, may I now request for the final brief discussion on echo in STEMI by Dr. Sameer Srivastava.
Doctor.
Hi, sir. So, Sunidhi, can it be
Sir,
seen?
sir, please share your presentation. We are seeing your screen, but not your presentation, sir.
How about now?
No, sir, not yet. Can you please stop share and reshare the screen in which your presentation is open, sir? Now it visible, sir. Can you please put it in presentation mode?
So, good evening to you all, Dr. Bhandari, Dr. Naik, Dr. Rakesh. I think the stage has been appropriately been set by Dr. Parag to rather than just to pitch in my two pennies in favor of echocardiography, which was absolutely not discussed. So acute MI, we know historically has been entirely dependent on history, ECG and serum markers. But we have echo at our hand, which can give us some reasonable wall motion abnormality defects, which may not directly or indirectly appropriately say that it's an ACS. These are certain views, parasol, short axis, not going into the details. We know that there are wall motion defects, which again may not translate into an acute MI or an ischemia or an old one. So let me just come back to our basic discussion. This is an ST segment elevation. The ones who are astute would know that we are certainly not dealing with an acute myocardial infarction. But here, if the debate continues, I can debate that this is an hyperacute phase of myocardial infarction. Possibly, possibly not. This was actually a patient who had come with shortness of breath with renal failure and serum creatinine on 6.8, serum potassium of 6.8. So we know that this is not an acute MI. I'll give you one more example. This is yet another example. Chest pain, marginally raised drops, whether it was pericarditis, whether it was acute ST elevation, myocardial infarction. It's a global ST elevation. Again, for the people who are astute ECG readers, they would have said that please sit on it. But what about people who are there who have little concept about what is early repolarization, what is WPW syndrome and ST elevation, what is pericarditis and ST elevation? Where are we? One very basic test comes at our hand, which is go and look at the wall motion abnormality. If you look at the wall motion abnormality, you can fairly well see that if there is no wall motion abnormality, we are pretty much sure that there is no acute ST elevation myocardial infarction. Now, we know that there are certain drawbacks of picking up wall motion abnormalities. If you have an echo with a regional wall motion abnormality, there is a likelihood of ischemia or MI with positive predictive accuracy of only 50%. And what is 50%? It is like tossing a coin. So you either toss a coin or you have a diagnosis based on echo, you'd be fault. However, if there is no regional wall motion abnormality, the patient is unlikely to have an MI and the negative predictive value is close to 95%. So here comes the importance of echocardiography at hand. Not only that, it has got reasonably good prognostic implication, which probably none of the risk evaluating scores have ever addressed. And there is something known as a wall motion scoring index. If it is greater than 1.7, the perfusion defect on any myocardial perfusion imaging would be greater than 20%, and there is an increased risk of complications. This we have known. There are certain caveats of wall motion abnormality. We know that the machine has to be good, the operator has to be reasonably good, and the patient has to be non-obese, non-inflated lung fields, etc., etc. So these are certain technical caveats, and the most challenging ones are obesity, thick chest wall, and lung disease. However, if you really want to see what is happening into the ischemic cascade, when the ischemia develops, the first thing which happens is probably lactic acidosis in the coronary sinus. But then next thing which can be done reasonably practically is pick it up by perfusion imaging, whether it be PET or whether it be nuclear testing. Then the next thing which happens is diastolic dysfunction. Again, you don't know whether it's a fresh onset of diastolic dysfunction or whether it is an old one. Regional systolic dysfunction again has the same problem. You don't know whether it is a fresh wall motion abnormality, old one, or this STA segment elevation, whether it is because of aneurysm or whether it is because of fusion, you don't know. Certainly, ECG changes are the sine qua non, and I'm not debating that we should make a diagnosis or take the patient for perfusion, the PCI or thrombolysis based on just echo. However, when the chest pain occurs, we know that we have gone far and beyond as far as ischemic cascade is concerned. Now, these are certain very old studies, and this was early diagnostic facts, that close to about half the patients presenting to emergency room with chest pain and later having confirmed myocardial infarction have a non-diagnostic ECG. Good about 3/4 of the patients with non-QMI present with ST depression only, and 80% of these have subtotal coronary occlusion. Where is the value in acute coronary syndrome? Echo has provided new and useful information in 29% of patients admitted with CCU. It is twice more likely to be useful in those who had an echo in recent past, which is again a bone of contention within 3 months. However, if they don't have this, we can still be making some sense of it. So where are we as far as prediction is concerned with chest pain? So this is again a very old study where 260 patients were taken for echo within 4 hours with wall motion abnormality and ejection fraction of 40%. The sensitivity of predicting events was 91% as against only ECG, which was 40% or thereabout. Multivariate analysis, only male gender and positive echo predicted cardiac events. Not going into the details, because this is how the triaging could be done in absence of using biomarkers. And not only that, we have a reasonably good idea that echo can give a very good prognostic. Ejection fraction being less, yes, I agree. There have been many more ways, but utilizing 3D, you can have equal or at least as big a fight you can give to the MRI people with 3D echo, because that is quite close and the R values are quite comparable with the MRIs. So this is systolic dysfunction. If it is less than 40%, bad prognostic indicator, extensive infarct with wall motion scoring index more than 1.7, bad prognostic indicator. Restricted mitral flow inflow, independent predictor of development of CHF and increased sudden cardiac death. LV enlargement, this is something which has been really ignored in past. But if you look at the diastolic or the systolic index, LV enlargement is very useful. Now, for picking up ischemia, we have talked about MRI, we talk about PET, we talk about nuclear medicine, but dobutamine stress echo is probably the cheapest and the most well studied or extensively studied and most probably utilizable in our country, where the resources for other things is so little. A few words about left ventricular and systolic volume. It is simple but very powerful standalone marker of LV remodeling, and it is most powerful predictor for survival and repeated hospitalization. So how I've remembered is that if your end systolic volume index is more than 43, it is a severe issue, and end diastolic volume, it is more than 97. So it is roughly 50 or 50 ml per meter square or 100 ml per meter square. That is how you can remember it for sake of remembering with end systolic volume index and end diastolic volume index respectively. So echo provides a quick bedside specific marker. Not only that, where were we lacking? We were lacking because echo almost always overestimates the size of infarct due to stunning, due to hypernation, and due to tethering. Now, where is the place for echo? The place for echo is in finding out the complications, and that is the reason why it got pitched in, and it was only till very recently that echo was never considered. And it was the Europeans about 3-4 years back, they said, no, it has to have a space. So that is how echo also came into existence in the guidelines and recommendations. But these are certain things which can't be picked up very easily unless you have echo at hand. One is LV aneurysm. Doesn't play well. This is one patient with cardiac rupture. If you look at it, this is an anterior infarct where there was a rupture which happened at the junction of inferior and which is the infarct related, and the normal segment, which is where it hurts. Again, acute myocardial rupture is here with it leads to a ventricular septal defect or ventricular septal rupture. VSR, acute mitral regurgitation. These are the mechanical complications which are so easily picked up by echo. This is yet another example of inferior wall myocardial infarction with basal septal aneurysm and leading to VSR also through the aneurysm. And this is one of the most favorites of mine. Here, if you look at it, this is a person who had a bypass surgery in past. This is a pseudoaneurysm. And this pseudoaneurysm, not only that, it has a pseudoaneurysm which is also leaking from the pericardium. So if a pseudoaneurysm is leaking, the patient should have been dead. But fortunately, the old fibrotics, because of the scar of and fibrosis within the chest wall, he was prevented from having a free flow into the cavity. And that's the reason why when the surgeons opened it, they found that it was the pleura which was stuck and was preventing rupture from the. So these are certain things which are very easily done. Now the problem comes that if there is a non-ischemic chest pain is one of the differential diagnoses of ST elevation. We know that aortic dissections are very notorious to give rise to falsely elevated, not falsely elevated, they actually hurt the right coronary artery more often than not and give rise to ST elevation. But this is the pain that you can't give anticoagulants or a thrombolytic therapy. Pulmonary embolism, pericardial diseases, these are all tricky situations to handle. And once you have dissections of this sort, you know that you can't be playing around with or fooling around it. And the best way to do it is by an echo. So we have, this is wall motion scoring index, that you have a sum of wall motion scores and you divide it by the number of segments. And if it is more than 20%, you are in big time problem. Diastole, compliance defect, you don't want it, higher mortality. What are the other hemodynamic information you get? You get pulmonary artery pressures, whether systolic or diastolic, you can calculate them reasonably well. Left ventricle end diastolic pressure, you can calculate by E to E prime ratios very well. Diastolic function, cardiac output, stroke volume, LV contractility, IVC flows. So your fluid volumes, status, hepatic vein flows, all those things can be seen very, very easily. Now, this is a niche area. Dr. Girish did talk about this extensively, but we have one modality which is reasonably good with RVMI. The problem is that the anatomy of RV is so bad that it is, you can't really make some reasonable sense of it. But with now 3D reconstructions, you can really make good sense of RV volumes, RV contractility, and of course you have the tissue Dopplers to tell you what is the exact status. We can discuss about the dobutamine stress echocardiography and issue viability. We know that viability, if you revascularize without viability, the prognosis is worse off. Roxy Senior had told us several decades back. When you look at the PET, DSE, and thallium overall, you know that there is a very good negative predictive value for all three, and thallium probably is the best. And positive predictive value is probably the best out of everything of dobutamine stress echo. So these are certain examples of hibernation, scar, and stunning, but not going into the details. If I were to have a dobutamine stress echo of this sort, I would be the happiest person, regardless of what my STT changes are, because this is where the septum and the posterior wall are almost kissing each other at the peak of dobutamine, which is extremely good prognosis. The problem comes is in assessing wall motion, because the biggest Achilles heel in echocardiography or within the echocardiograpers have been that there is no objectivity So what is hypokinesia for you maybe and akinesia for me or otherwise. So people have been experimenting with these color kinesis and things like that. They have come and gone. But for all practical purposes, we have myocardial contrast also, which is more sensible to operate. I know we are running out of time, but we can see coronary arteries on transesophageal echo more commonly as compared to transthoracic. But these are arteries which are seen when you don't want to see, and when you really want to see, you probably can't. And then you can look at the IMAs also. You can look at the athromas if you're doing the transesophageal echo. So these are some additional informations which you can really pick up on echocardiography. Lastly, my take on it is that it can give you a reasonable detection of site and size of infarct, though it may be overestimation, assessment of prognosis, associated cardiac defects, and detection of complications and effect of therapy. All these things can be studied with echo, and no wonder it took almost about 40 years for echo to find its space in the guidelines for diagnosis of myocardial infarction or ACS, but eventually it has. So I'm happy on that, and thank you for giving me such a patient listening.
Well, thank you very much, all the speakers, Dr. Bhalla, Dr. Girish, Dr. Parag, Dr. Vimal, Dr. Samir. Excellent, stimulating elucidation, and thank you very much. Paucity of time, myself and my fellow chairpersons, they now request for completing this session, please.
Thank you so much. We will move to the next session. It is titled Controversies in STEMI. Is there a consensus? We have the following chairpersons: Dr. N.C. Krishnamani, Dr. Pintu Nahata, Dr. Rajiv Kumar Rajput, Dr. Ravindra M. Chabra, Dr. S.C. Mandal, Dr. Satish Kumar Kaushik, Dr. Satyaprakash Yadav, and Dr. Satyaveer Yadav. The first presentation, in fact, will be a pre-recorded presentation due to some internet-related issues from the presenter. So I request Dr. N.C. Krishnamani sir to carry on the session.
Good evening, all of you. Every beginning has to have an end. 2 days of academic feast. Dr. Nitish Naik, Dr. Rakesh Yadav, and Dr. Suman Bhandari, sir, we are all indebted to you for giving us such an excellent feast in the weekend. And this will be remembered for years together. Such an excellent, legend which you have started. And of course, coming to the last session of the STEMI meeting, we have the speaker, Dr. Rajiv Bagar Hata. Do all post-COVID patients need cardiac assessment? The COVID has been there for last 1.5 years, and we have seen and we have all dealt with all COVID patients and COVID complications, cardiac complications. Dr. Rajiv is going to present to us the controversies and what about the consensus about this particular very important topic of COVID patients needing cardiac assessment. Please play on the record, please.
Good evening. First of all, I would like to thank the organizers for getting us this great academic feast. And the topic which is so burning these days is about the COVID patients and their cardiovascular implications.
The troponins, which have been the landmark in all yesterday and today also, there were a lot of discussions and of course consensus about the troponin levels, and it is one of the landmark, the tests which has to be, and it is to be taken up as one of the important markers. And they deal with the troponin levels. We often see that they are raised after the surgery, and when it is an MI, troponin elevation after surgery, when it is an MI, I would request Dr. Sunil Modi, who is no one needs any introduction about Dr. Sunil Modi. He has been the legendary in Delhi of cardiology. Dr. Sunil Modi, sir, please.
Thank you. Thank you very much, Krishnamani. And thanks, Dr. Yadav, Dr. Nitish, for giving me opportunity. And I'm just going to share the slides and start off. Although it has been put in the controversy symposium, but I personally do not think there is too much of controversy, after we have these newer techniques of measuring high sensitivity, troponins and all. So I'm going to just summarize the whole thing in next 8 to 10 minutes. I'm sure it won't be an exhaustive talk, but just the few points which I wanted to tell about this troponin elevation after surgery. It's not cardiac surgery, it is just any surgery, troponin elevation after any surgery. Should we call it a MI? Now, troponins are protein molecules that are a part of cardiac and skeletal muscles. Now, smooth muscles do not have troponins. It's only the cardiac and skeletal muscles. And naturally, when we cut the skeletal muscles, troponins do change. Troponins are of 3 types: troponin I, troponin T, troponin C. C doesn't interest cardiologists, but troponin I and T are interest of cardiologists because they act on myosin, actin. I won't go into details of the biochemistry here. The troponin T and troponin I are different molecules with different roles. While an elevation of either of these two, if elevated, they specify myocardial damage, but their absolute values differ. The standardized assay exists for troponin T, while multiple assays are available for measuring troponin I. Each has a different cutoff value. You have to know it as these assays target distinct epitopes. Clinicians need to be aware of the abnormal reference ranges for different assays used in their practice, and that absolute values from different assays cannot be compared or cannot be correlated. So you have to check with your laboratory and with your biochemist that which assay they are doing and what are the normal values for that particular assay. This is particularly important for troponin I. It is proposed that there is a small cytosolic pool and a larger muscular pool of troponins. During cardiac injury, depending on the severity, troponins are released from both the pools. Initially, small elevation occurs when troponins are released only from the cytosolic pools, when troponin molecules in the cytosol of cardiac muscle diffuse across the sarcolemma into the surrounding lymphatics and blood vessels, and that is how they become detectable in the blood in the very beginning. But then later on, if the injury persists and the necrosis progresses, then troponins are released also from the muscular pool. So initially, cytoplasmic or cytosolic pool, and then later on from the muscular pool. Now, just to remind our friends here that number of surgeries performed annually are about 300 millions, and almost like 1 in 30 or 1 in 33 surgeries develop some or the other kind of cardiac complication. So out of 300 millions, about 10 million patients all over the world develop major cardiac complications in the perioperative phase. This is the statistics of the United States. I don't have any such statistics from India, but I presume and I can extrapolate the similar statistics for India. Now, when it comes to perioperative myocardial infarction, the incidence ranges between 5 to 20% in various studies. Now, what is new for us to know is that conventional myocardial infarction, all of us have been diagnosing for ages. There is another new terminology recently is what they call it MINS, that is myocardial injury in non-cardiac surgery. This MINS is essentially, let me just first tell the perioperative myocardial infarction, the conventional one, which we have been diagnosing for a long time, in which we have elevated troponins. We have some symptoms of ischemia, if patient can describe ischemia, if patient is not intubated and all. There are some new or presumably new ECG changes, either STT changes or new left bundle branch block or development of pathological Q waves, depends on when you are ordering the ECG. there is mostly, almost always, some new regional wall motion abnormality on the imaging by echo or by any other imaging if you are doing that. And of course, intracoronary thrombus if patient reaches to that stage, either on the angiogram or on the autopsy. So these are the classical evidences of myocardial infarction, which were there for many decades, making us to diagnose perioperative infarction. Now, what is new is that fourth universal definition of myocardial infarction in the recent past recognizes myocardial injury as a distinct entity with milder form of myocardial necrosis leading to release of detectable troponin. Now, this myocardial injury is prognostically relevant. Myocardial injury due to ischemia that occurs during or within 30 days of non-cardiac surgery. So any myocardial injury occurring during surgery or within 30 days of surgery is included in the myocardial injury of non-cardiac surgery. Now, what is special about this MINS is that only the troponins are elevated. There is no symptom, even if patient is awake and fully out of anesthesia, no symptoms, no ECG changes, no wall motion abnormalities on echo imaging. And of course, if you diagnose MINS, the most important thing is that you have to rule out that there is no non-ischemic cause of the myocardial injury. And those common causes, non-ischemic causes of myocardial injury are sepsis, rapid atrial fibrillation, pulmonary embolism, cardioversion, or chronically elevated troponins. You know, some of the patients have elevated troponins even in the stable condition. Even pre-operatively, if you check their troponins may be high. So one has to be sure that you are not overdiagnosing MINS because of these reasons. If you have one of these reasons, it is not myocardial injury. It is the result of these conditions which is producing high troponins. Now, this is very clear that in MINS, if you have elevated troponins versus normal troponins, the prognosis is totally different. This mortality rate is almost like twice if you have elevated troponin as compared to the normal troponins in the post-operative phase. Cardiac troponin T normal values, cardiac troponin I normal values. Now, new thing is high sensitivity troponins, both T and I, and they are being standardized by different companies, by Roche, by Abbott, and we are getting more and more into it. And you know, they are high sensitivity troponin. Even the smaller amounts in the nanograms can be measured, whereas these are actually micrograms. The major the non-high sensitivity troponins are in the micrograms, and the high sensitivity troponins are in the nanograms. The advantage of high sensitivity troponins is that they appear in the blood very early because you can detect very, very small amount, whereas the conventional troponins will have a phase where you are not sure whether troponins are high or not. And then, of course, later on, they will be clearly high. So high sensitivity troponins are clearly of advantage as against the classical troponins of the past. Now, we must know here, right here, before diagnosing the MI or the MINS, is that these are the various other causes of high troponins, myocarditis, pericarditis, dissection, endocarditis, so on and so forth, stroke, cardiopulmonary resuscitation, defibrillation, chronic severe heart failure, arrhythmias, renal failure, hypertrophic obstructive cardiomyopathy with the severe obstruction, and various other forms of cardiomyopathy, burns, extreme exertion, post-cardiac surgery. They have their own, you know, the rising titer is important in the post-cardiac surgery. One single troponin is never enough. Infiltrative diseases, medications like doxorubicin, snake venom, transplant, vasculopathy, critical illness. So there are many other reasons when the troponin will be elevated, but that is, you know, that's the reason that MINS is diagnosed with very, very careful assessment of the patient, and just simple. You have to rule out, you know, all these associated problems to call it a myocardial injury. These are the analytic interfering factors which can lead to falsely elevated falsely elevated troponin. And some of these interest clinicians also, although most of them are of pathologist or the biochemist interest, but then rheumatoid factor, elevated bilirubin levels, markedly elevated alkaline phosphatase levels, incompletely clotted specimens. There are quite a few reasons that the elevated troponins may be actually the measurement of troponins may be false, and you can have elevated troponins. So without expanding it too much, I'll just finally conclude that myocardial injury and MINS has been formally recognized as novel nosologic entity. They are recent terms which are coming up in the field of cardiology. While diagnosis of myocardial injury has been achieved more consistently with advent of 5th generation high sensitivity cardiac troponins, it is yet to be universally standardized. Two big companies are trying to standardize it, and they are successful to a great extent. But I think the effort will go on. Formalized clinical management or prevention pathways are yet to be delineated of MINS. With increasing test sensitivity to detect cardiac troponins, an elevation of high sensitivity cardiac troponin needs to be interpreted as a continuum rather than an absolute for the detection of extent of myocardial necrosis. So it's not wrong to say that if you are able to detect high sensitivity troponin, a little later, maybe an hour, 2 hours later, you will be able to detect even the conventional troponin. So it is just a kind of continuum of the myocardial injury. And as the myocardial injury will increase, your conventional troponins will be as good as high sensitivity troponin. Trending a serial rise or fall must be considered, if you to conclude So friends, take home message is that troponin elevation after surgery should be considered as myocardial injury, whether or not accompanied with ischemic symptoms, whether or not ECG changes, whether or not echo imaging abnormality. Provided that there is no cause of non-ischemic rise of troponins, which we have seen and we have enumerated, and provided that there is no evidence of chronic elevation of troponins. So, people have discussed these policies, and they have come even to the conclusion that it is advisable to have a baseline preoperative troponin levels measured, particularly in case of high-risk patients or in cases of high-risk surgeries, because these are the patients who get much more incidence of perioperative MI. So if you have a baseline preoperative troponin levels measured, it will be much easier for you to compare the postoperative troponin and then draw to some conclusion. Thank you very much. Thanks a lot.
I would request Dr.
Recording
Chabra.
stopped. Recording in progress.
Thanks, Dr. Modi, sir.
Just a minute, sir. Let me stop sharing. Yeah.
We will next play the pre-recorded lecture from Dr. Rajiv Bhagarata. And we also have in our chairpersons Dr. Rajiv Kumar Rajput and Dr. R.M. Chabra, who may carry on with this session.
Good evening.
Are you going to start the recorded message, Dr. Rajiv?
Yes, sir. We are starting the recording. Yes, sir.
Good evening. First of all, I would like to thank the organizers for getting us this great academic feast. And the topic which is so burning these days is about the COVID patients and their cardiovascular implications. As we understand that over the last year and a half, the COVID pandemic has been raging, and it's just stretching the already stretched resources which have been reallotted just to take care of the pandemic, as also at the same time, this reallotment has a serious impact on the resources which are left for the cardiovascular disorders.
So as a cardiologist, we are also faced with the rising COVID cases, which come to us with their cardiovascular symptoms, cardiovascular complications. And along with the cardiovascular load, which we have already to cater to, we have to deal with these cardiovascular complications. So this raises the important question of whether all post-COVID patients require cardiac assessment. Now, I shall be dealing with a few studies which have got contradictory implications about how to deal with these complications. How far do we need to chase these COVID patients as far as the cardiovascular complications are concerned? Along with that, after that, we'll be dealing with a systematic review of these studies. The first of these studies deals with the outpatient clinic 6 weeks after the discharge. That is short-term outpatient follow-up of the patients of the COVID patients. And as a part of this study, they came up with the post-COVID functional status, that is PCFS score. The more the PCFS score, the more limitation is of the patient. And the lesser the one, the lesser the score, the patients are better preserved. Now, as you see from here, that the outpatient clinical evaluation reveals that those patients who had a higher NYHA score, those patients who were admitted in ICU, they were significantly affected with they were having patients with higher NYHA scores. That is, those patients who had ICU admissions, as we see here, they had been significantly affected with higher NYHA scores of NYHA class 3, as we see here. That those patients who had admitted in ICU, 10 of these patients were having, 29% of these patients were having NYHA class 3, whereas as compared to 6% of the patients who were having NYHA class 3 in those patients who were not admitted to ICU. Similarly, if we stratify these outpatient after 6 weeks, according to PCFS score, we realize that those patients who had higher PCFS score, there were more patients in NYHA class 3 in this group, significantly more patients. But though these patients were having higher NYHA score, they were having a higher PCFS score, but the cardiac functions were normal in majority of the patients. With of the patient, and early dysfunction was not related to either functional status assessed by NYHA class or PCFS score. Rather, this was related, the NYHA score or the PCFS score was deemed to be related to pulmonary fibrosis rather than to the cardiovascular complications. In 2019, the ESC came with a guidance paper, and which dealt with certain components of the COVID-19 pandemic, along with those patients, and it suggested some guidance regarding the biomarker assessment during the patients of COVID-19 pandemic. Now, they came with a guidance that patients with cardiovascular risk factors, including male sex, advanced age, diabetes, hypertension, and obesity, which are already established risk factors, they were more prone to have cardiovascular complication later on. Moreover, it was realized that these patients of COVID-19 infections, besides their arterial and venous thrombotic complications, which came up with as acute coronary syndrome or venous thromboembolism, myocarditis also played a role in these patients, and thus led to heart failure. Moreover, these patients were also having arrhythmia, wide range of arrhythmias, which could be either because of myocarditis per se or certain viral modifying drugs which had poor arrhythmic effects. Regarding biomarkers, it was assessed that in the absence, it was recommended that in the absence of typical angina, chest pain, and or ischemic changes, the troponin T or I or anti-proBNP levels, if they are less than 2 to 3 times the upper limit of normal, they do not require any further workup or any treatment for type 1 myocardial infarction. It was also seen that the D-dimers which quantify the activated coagulation, which is a prominent feature of COVID-19, And it is got a central zone, because of the central role of endothelitis and VT in COVID-19 patients, the serial measurements of D-dimers might help the physicians in the selection of patients for the imaging of venous thromboembolism or use of higher than prophylactic doses of anticoagulation. So the essence was that we need to chase the patients with elevated biomarkers in only situations which clinically led us to believe that the patient might be having either type 1 MI or the patient might be having venous thromboembolism. Another review said, which was dealing with the long-term surveillance and outcomes in survivors of COVID-19 infection, it emphasized that up to 20 to 30% of the patients hospitalized with coronavirus disease or COVID-19 have evidence of myocardial involvement. And the acute injury in cardiac patients hospitalized with COVID-19 is associated with higher morbidity and mortality. According to one of the studies by Shai et al., it reported that cardiac injury, the factors which are responsible, those patients who had acute respiratory distress syndrome, those patients who had acute kidney injury or coagulation disorders, they were more prone to have cardiac injuries in those patients who had been also affected by COVID-19 infection. So we have to watch out for those patients who had a turbulent course with acute respiratory distress syndrome, acute kidney injury, and coagulation disorders, because these are the patients who may likely go on to have the cardiac injury. Another study by Pontman et al., it basically assessed the patients with the COVID-19, and these patients, 100 of these patients in this prospective observational cohort study, 100 of these patients, they were assessed by CMR after a variable, after median period of 71 days. And it revealed that cardiac involvement was present in 78% of the patients and ongoing myocardial inflammation in 60%. This was independent of pre-existing conditions, severity and overall course of acute illness, as well as the time from the original diagnosis. So these findings indicated that there was a need for ongoing investigation of the long-term cardiovascular consequences of COVID-19. So till now, we have got an array of studies and articles which suggesting that all the patients of COVID-19 should be followed up very aggressively. For example, also to the extent of following up with CMR to diagnose the overt cases of myocarditis. On the other hand, there have been certain studies where it has been suggested that these patients of COVID-19 infections, their LV functions or RV functions are not deranged, at least in the short term. To resolve this issue, there came up a systematic review in 2021, that as early as 23rd June 2021, which had a systematic review of 35 studies. And there was 35 studies which had a total of around 53,000 patients. And the median follow-up of these studies was around 48 days. And for the cardiac sequelae assessment, the studies had included the CMR, echocardiography, ECG, biomarkers, questionnaires, and also the myocardial biopsy. So this is the gist of how we should be we should stratify the patients of COVID-19 as far as their cardiovascular complications are concerned, and what investigations at which point of time are going to be helpful. As we see here, that in those patients who were being followed up for less than 3 months, that is the short-term follow-up, it suggests that in the short-term follow-up, the patients cluster, the investigation which cluster around are in the CMR, which had the evidence of increased T1 inflammation in the form of increased T1 and T2 images, along with these patients had pericardial effusion, pericardial enhancement. Whereas if we come to the ECGs, there were T-wave abnormalities in the earlier phase, and the cardiac the elevated troponins were also there in the earlier phase. If you move on to the midterm investigation of these patients, it was realized that late gadolinium enhancement, elevated extracellular volume, and reduced GLS on CMR, pulmonary hypertension and diastolic dysfunction on echocardiography, as well as elevated NT-proBNP were the main markers of involvement of cardiovascular system in those patients who had been affected by coronavirus. So that is how this particular slide that helps us to streamline or to strategize our patients of COVID-19 as far as their investigations are concerned. Now, the presumed pathophysiologies, which lead to the cardiovascular complications in patients with long-term complications of cardiovascular complications of coronavirus disease, are basically related to prolonged inflammatory state, hypercoagulability, dyslipidemia, either induced or worsened by immunosuppressive agents, or frailty. Frailty is an important is an important factor which can basically predispose these patients to cardiovascular complications. And as a matter of strategy, how to follow these patients up, how to strategize these patients as far as their management is concerned, as far as their investigation is concerned, this flow chart will give us an idea that in the acute phase, if the markers are increased more than 2 to 3 times the normal, and if the history is also suggestive of STEMI, these patients should be treated as standard STEMI protocol. And later on, post-MI therapy should be followed up. If the markers are elevated, but the patient is not a case of STEMI as far as the history is concerned, as far as ECGs are concerned, or there are other evidences of myocardial injury, the standard imaging protocols in the form of echocardiography and therapy as indicated should be followed up. In the convalescent phase of after 2 to 3 months, if the patients are followed up with ECG and echo, or maybe in some patients the Holter monitoring might be done, and if the symptoms are slightly abnormal, then in that case, only these patients should be followed up with echo, especially with the strain, along with the late gadolinium enhancement MRI scan. And then the treatment should be clinically indicated, as in those patients, some patient might be having myocarditis. So in conclusion, patients with cardiovascular complications, the risk factors including male sex, advanced age, hypertension, obesity, diabetes, and patients with established cardiovascular and cerebrovascular events have been identified as particularly vulnerable populations with increased morbidity and mortality, mainly in hospital mortality. Active disease severity has been found to be the most relevant predictor of symptoms at 6 months after COVID onset. And therefore, patients who are more severely ill during their hospital stay seem to be the main target for the tight follow-up after discharge. Therefore, these high-risk groups should have a post-COVID cardiovascular assessment, which should include a detailed history, physical examination, electrocardiogram, 2D echocardiography, including LV strain, and MRI when indicated, especially for myocarditis.
Process, we cannot ask the question to Dr. Rajiv. So nice presentation when we should evaluate the patient after the COVID infection. So next, the coronary CT angiography for the chest pain evaluation in the emergency department. So speaker none other than Dr. Uday Yadav. He doesn't require an introduction. Everybody knows him. Not in the nationally, but internationally, he is known person. So I request Dr. Uday Yadav, what is the importance of the coronary CT in the emergency department?
Thank you. Thank you, Dr. Saab. Thank you, Dr. Nitish Naik and Dr. Yadav. May I share the screen, please? Is the screen visible?
Yeah.
It's visible.
Thank you very much. All right, so in this quick 10 minutes presentation, let me highlight some of the aspects that we try and look for when a patient comes in the emergency department with a chest pain. I'm starting with those patients where your troponins are negative. He comes for evaluation of chest pain. The troponins are negative. The ECG changes are pretty non-specific. Will CT coronary calcium as an upstart help, it does help. And how does that happen? Let's say if you get a patient who comes with acute chest pain, this is one of our patients, and you can see the presence of calcium in the LAD, which doesn't necessarily prove that's the cause of acute event, but does tell you that a patient who has come for chest pain eventually wants to know whether there has been a cardiac problem. And this gives opportunity as a treatment provider to figure it out as to whether this particular chest pain, even if it's non-cardiac, can we have an assessment in this situation where it helps further? So the presence of calcium already tells you there are atherosclerotic plaques. Need not be vulnerable, need not be a culprit plaque, but still gives you the first guidance. Rather than sending these patients, traditionally what we do for a stress test, calcium score makes more reason because they provide a prognostic value and a diagnostic value in terms of advanced atherosclerosis. The calcified and the non-calcified plaques both would help. Stress testing will detect the functional consequence of atherosclerosis. Per se does not diagnose atherosclerosis, cannot detect a non-flow limiting plaque, and is just superior for detecting those who are at a higher risk. And therefore, our strategy is that if you get a calcium score in the presence of chest pain, which is high, let's say more than 400, even when the troponins are negative, there is a reason to just go ahead, do the treadmill test and figure out what's going on. The first stop probably would then be the presence of calcium on the cardiac CT. Now, you do get patients, mind you, who may have a zero calcium and still will have softer plaques. So in one of our studies, which we presented at ESC in Vienna long back, must be about 14 years back, lesions more than 50%, or rather lesions in total were seen in 2.7%, more than 50%, 7%, and more than 70%, 4.76. These were young patients. What I'm trying to do is in young patients, the CT coronary calcium at the age of less than 40 may necessarily not be the one-step exclusion, but as a patient is older, it helps. The Scott Hart tried to look at this question very nicely. Patients who come with chest pain, who have a low to intermediate risk, subjected to a coronary CT versus only stress test, more than 4,000 patients were looked at 1.7 years, maybe a little shorter duration of follow-up. But the interesting part was exactly what you need in India. The mean patient age is 57 years. In these patients, a treadmill test was performed, 15% had abnormal in both groups. Subsequent stress imaging was performed as an advanced investigation is only 9% of the coronary CT and 10% of the standard. The median radiation dose was 4 millisieverts, which is the standard of real world practice in today's date for cardiac CT. Here were the endpoints. In terms of standard care versus adding a CT, the primary endpoint reduced by 41%, non-fatal MI by 40%. Invasive angiogram use was not increased. The primary diagnostic outcomes, CT increased the diagnosis of angina due to coronary heart disease versus standard care, relative risk of 1.79. So what does this Scott study tell you in general? That if one uses a cardiac CT in addition to standard care in patients, then we have a stable chest pain. You may have a result in a significantly lower rate of that from CHD or non-fatal MI at 5 years than standard care, without resulting in a significant higher rate of coronary angiogram. Having said that, the important part is that can we have the same conclusion or inference in the emergency department with acute chest pain? Yes, you almost have the same sort of protocol one can follow. So I would still say, go ahead, get a calcium done. As necessary, go ahead and get a cardiac CT done in the ED. So should it be a non-invasive test of choice? Unequivocally, yes. Other available tests, all predicate risk, etc. name a test. Which other test would tell you there is underlying coronary artery disease if it's in a non-intervention form? Does it make a difference to the patient? When you say your lipids are abnormal and therefore you have a likely cardiac disease, or they're normal and therefore you may not have a cardiac disease, your treadmill test is positive or negative, EKG is positive or negative, nothing. Besides the troponin markers, the most sensitive test in today's date would be a cardiac CT. Few quick important highlights. If you see on a cardiac CT in a patient of acute chest pain, forget the calcium score. 4 characteristics. I think this is the best and the most correct slide. A shows a vessel remodeling. You can see the remodeled vessel in A, where the entire vessel has got puffed up. Second is you see the eccentric soft plaque. Here the Hounsfield units will be very less, maybe 40 or 50. Third is a spotty calcification exceeding 3 millimeters in an eccentric plaque. Although the lumen looks okay, this is a very vulnerable plaque. Fourth is the classical ring sign. You can see the contrast. You can see the lesser enhanced contrast and absolutely lucent area. That's the napkin ring sign. It's not just one, in my opinion and experience also. It's good to try and see if you find more features in a single cardiac CT. More of these 4 rather than one individual will help both in terms of positive and negative predictive value very, very high, very, very sensitive to pick up vulnerable plaques, even when you don't have very advanced technologies in your cardiac CT department. Here is acute chest pain. You can see a closed LAD, absolutely closed LAD. And this is a patient where we could see a proximal occlusion. We went ahead and did a cath, and to our surprise, the LAD right at the ostium, you can see a little bud and then nothing else. And we thought, well, there is a difference. You certainly see a proximal well-ossified artery on the cardiac CT. On the cath, immediately you found nothing thereafter. What happened is that this patient had a very lucent area, if you have noticed carefully. This is the one I'm saying, right? You see a very eccentric lucent plaque and very thin ring, as you see, and a very lucent area. When we went ahead and calculated the Hounsfield units in the dark area, it was less than 40. This was a thrombus. And it's the movement of the thrombus proximally that occluded the artery completely on the cath, and therefore we thought it could be, it is probably a difference between cardiac CT of cath. But in the emergency department, this helps us to understand. So mind you, in the emergency department, look for features of vulnerable plaque, look for features of thrombus once you do the cardiac CT. Finally, this is a very good slide of the occluded stent. As you can see, there is no contrast going on there. So does CT help in acute stent thrombus? I would first suggest that we should not recommend doing CT in a stented patient with elevated troponins. That's not in order. You should send him for a cath. No second opinion on that at all. But if your trops are not elevated and you have a reason to do cardiac CT, then one should go ahead. One can see the instant restenosis if at all a thrombi is coming up, which is something which we don't advocate. It's more for restenosis than acute thrombi and closure of the stents. Thank you very much for the kind attention.
Sir, I think Dr. R.K. Goplu has not joined. Can we please move on to the next speaker?
Dr. Rajiv Rajput would take up as a chairperson, please.
Yeah, I think this is the last talk of the session. Is aspirin losing the role post MI? And I will request Dr. Sudeep Kumar to give his presentation, and we'll have discussion. I think looks like we'll have discussion at the end of the session.
Is my slide visible now?
Yes, Sudeep, go ahead.
Yeah, at the outset, I would like to thank Dr. Nitish, Dr. Rakesh, and all the council for inviting me on this to present an important and interesting topic, that is aspirin losing its role post-ST elevation MI. I know I'm the last one to present. I am the last batsman on the crease, but let me do some justice on this topic. So we know that over the last 25 years, we were using P2 vital inhibitors with aspirin for after the stent implantation, and now the new recommendation are changing, and recently the Japanese recommendation has cut short the DAPT duration, basically because we have a newer generation, thinner stents, and with less of a polymer, less of thrombogenic milieu. And then we have a stronger, newer, potent P2 vital inhibitors in the form of the prasugrel and the ticagrelor. And then we also are now dealing with the patient who have higher bleeding risk patients. So the duration of DAPT now is getting shorter. Then the aspirin-free strategy is now a new dawn in the era in the interventional cardiology, because we know that aspirin compared to the P2 vital inhibitors have a higher chances of bleed, especially in the GI bleed. And this was analyzed in the meta-analysis, especially in the stroke patients. And we also note that the major bleed have a similar outcome as of ischemic events. These are the guidelines. You can see that Japanese guidelines have further shortened the DAPT durations, and the European and the American guidelines are still, I think they will take some times with more robust results of newer trials to decrease DAPT duration. So evidence so far for the shorter DAPT trial, and the continuing monotherapy without aspirin with the newer generation P2 vital inhibitors. So global leaders trial was a multi-centric international trial. It enrolled around 15,000 patients. It was planned for the superiority trial, and what it found that the superiority was not found. The ischemic events was almost comparable, but there was no significant bleed when we compared the ticagrelor monotherapy compared to the DAPT for 1 year, followed by the aspirin monotherapy. So ticagrelor was having the similar rates of ischemic events and lesser bleeding events. But in the GLASSY trial, which was the adjudication of the global leaders trial, because there were some issues with the reporting of these MI and the bleeding events, what it had found that the experimental arm, that means that the ticagrelor monotherapy after 3 months of DAPT was comparable in the terms of all the bleeding, all the events rate. But when we can see that after 1 year, the MI rate and then the stent thrombosis rate were much less in the ticagrelor arm compared to the aspirin arm, and the bleeding events were also similar. So they concluded that the ischemic events rates were almost similar, but the major bleeding rate was not increased with the continuation of the ticagrelor. The STOP DAPT trial, which there was 1 month of DAPT followed by the P2 vital inhibitor. There the clopidogrel was used. What they have found, there was no change in the ischemic event, no increase in the ischemic event, and that the major bleeding risk, TB major and minor bleeding, were greatly reduced with the 1 month of DAPT. Remember, they continued clopidogrel as the monotherapy after 1 month of DAPT. So here again the aspirin was omitted, and the net clinical benefit was in favor of the shorter DAPT followed by clopidogrel monotherapy, because there was a much reduction in the, mainly driven by the reduction in the bleeding events rates. Smart choice trial was again a comparison with the duration of the shorter duration versus